12 12 3 4 5 6 12
Không, vậy 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 cái này á, là để đi, tại vì mấy ổng mình không thể nào
2
nhấn vào
12
khi mày nói á, mày nhấn vô
12
rồi khi mày
3
không nói
4
là
5
mày
6
nhả ra.
12
Cái ở dưới đó mình sẽ nói bác sĩ,
12
người Việt thì mình nói á, khi nào chị cần nói với ổng á, chị cứ cần nhấn vô chị nói là được, xong rồi chị tắt, đúng không?
12 3 4 5 6
Ừ, rồi giờ mày
12
coi mày
3
nghe đây nè.
4 5 6 12 3 4 5 6
After 10 editions, the annual Congenital Heart Disease Conference of the After 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only two major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal defect, ASD, intervention, is highly significant as ASD is one of the most common congenital heart diseases, affecting not only children but also adults. A study published in the Journal of the American, JAHA, in January 2023 reported that ASD is a common cardiovascular defect. With a prevalence of 2.5, 1.000 live births. With 25 to 30% of cases present in adulthood. The conference is expected to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as the USA, Canada, the UK, France, Germany, Italy, Poland, Australia, China, India, Pakistan, Bangladesh, Japan, South Korea, Thailand, Malaysia, Indonesia, Singapore, the Philippines, Egypt, Iran, Taiwan, and over 100 pediatric cardiology experts from Vietnam. During the three-day event, 55 speakers from both domestic and international backgrounds will present over 100 scientific papers and demonstrate live interventions, focusing on ASD and related issues such as ASD closure techniques in patients with abnormal heart morphology or special health conditions, using various devices for ASD closure, using bioresorbable devices in ASD closure, and managing complications in ASD intervention. In addition to the on-site presentations, the conference will feature more than 30 live cases performed at 6 leading centers both domestically and internationally, including Children's Hospital 1, Ho Chi Minh City, Vietnam, Tam An General Hospital, Vietnam, Queen Sirikit Hospital, Thailand, Institute Jantung Negara, Malaysia, National Taiwan University Hospital, Taiwan, and Apollo Navi Mumbai Hospital, India. The images of these cases will be broadcast live to the conference, allowing delegates to discuss, learn, and share experiences.
Everybody come up on the stage.
đi đi 56 12
Tắt
một hai một.
Hello, Malaysia. Can you hear me now? Use your microphone. We want to check if there's any echo again.
Anh ơi, nhờ anh đẩy cái tiếng nó này ra đây cho chị nói chuyện giùm em tí.
Hello, Malaysia. Can you hear me, Malaysia?
After 10 editions, the annual Congenital Heart Disease Conference of the PD
Hello, hello. Can you hear me, Malaysia? Please answer if you can hear me.
After 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only 2 major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal ASD, intervention, is highly significant as ASD is one of the most common congenital, affecting not only children but also adults. A study published in the Journal of the American Heart Association, JAHA, 23 reported that ASD is a common cardiovascular defect. With a prevalence of 2.5, 1.000 live births. With 25 to 30% of cases present in adulthood. The conference is expected to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as the USA, Canada, the UK, France, Germany, Italy, Poland, Australia, China, India, Pakistan, Bangladesh, Japan, South Korea, Thailand, Malaysia, Indonesia, Singapore, the Philippines, Egypt, Iran, Taiwan, and over 100 pediatric cardiology experts from Vietnam. During the 3-day event, 55 speakers from both domestic and international backgrounds will present over 100 scientific demonstrate live interventions, focusing on ASD and related issues such as ASD patients with abnormal heart health conditions, using various devices for ASD closure, using bioresorbable device closure, and managing complications in ASD intervention. In addition to the on-site presentation, the conference will feature more than 30 live cases performed at 6 leading centers both domestically and internationally, including Children's Hospital 1, Ho Chi Minh City, Vietnam, Tam An General Hospital, Vietnam, Queen Sirikit Hospital, Thailand, Institute Jantung Negara, Malaysia. National Taiwan University Hospital, Taiwan. And Apollo Navi Mumbai Hospital, India. The images of these cases will be broadcast live to the conference, allowing delegates to discuss, learn, and share experiences.
Everybody come up on the stage.
Hello, hello, can you hear me? Nhưng bên em không thấy trả lời chứ. Gọi nó nghe. Nó đang set up, gọi nó nghe. Hello, hello, Vietnam speaking. No, I cannot hear you. No, we did not receive any audio signal. Okay, let me check with the technician. Nó đang gửi qua rồi á, nhưng mà không lên sóng. How many microphones will you use at the same time during the live case?
Con đẩy bớt ai mà sao đẩy master kia?
Three doctors at the same time.
Nam Nam Nam
Okay.
chuẩn bị đồ cài bên kia chưa?
Nó đang làm bớt A, bây giờ muốn vậy.
Gặp bác Tính á, nói bác Tính nói với Malaysia nghe điện thoại của mình đi. À nó nghe rồi, nghe rồi, nghe rồi, nghe rồi. Hỏi con. Lô lô
Không,
một
nó nghe
hai.
được mình nhưng mà mình đang không có tiếng tụi nó.
À rồi.
Nên là mình đang fix cái đó.
Nó đang gửi mình kênh 2 đúng không? Kênh 1. Mẹ cái tiếng của người ta đang là kênh 1. Tiếng mình là kênh 2. Giờ mình lấy về là mình phải lấy kênh 1 chứ.
Can you play a random video so we could check? So can you play a video montage?
Ủa đâu?
Hú gì?
Nó đang chạy một cái video có sóng.
Nó đang gửi lớn quá đúng không?
Không có. Nhưng mà nghe được tiếng mà.
Hồi nãy là mình ở đây mình vẫn nghe họ mà chỉ có là họ không nghe mình thôi đúng không?
Dạ không, họ nói mình không nghe.
Đâu có mà hồi nãy có nghe mà.
Nhưng mà họ vừa ấy thì bây giờ không nghe nữa rồi. Trong khi họ vẫn đang nói.
Là hồi nãy mình đang xếp đúng anh. Cho đường số 4 mà.
Can you talk something? Turn to the microphone. You're speaking on the mic now. Đó nó đang nói á, nãy giờ nó đang nói mà. Dạ. Okay, can you talk again? Hi. Talk again, please. noise sensor if you can hear me. Malaysia. Hello, anyone there?
After 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only 2 major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal defect, ASD, intervention, is highly significant as ASD is one of the most common congenital heart defects, affecting not only children but also adults. A study published in the Journal of the American Heart Association, JAHA, in January 2023 is a common cardio with a prevalence of 2.5, 1.000 live births, with 25 to 30% in adulthood, to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as the USA, Canada, the UK, France, Germany, Italy, Poland, Australia, China, India, Pakistan, Bangladesh, Japan, South Korea, Thailand, Malaysia, Indonesia, Singapore, the Philippines, Egypt, Iran, Taiwan, and over 100 pediatric cardiology experts from Vietnam. During the 3-day event, 55 speakers from both domestic and international backgrounds will present over 100 scientific papers and demonstrate live interventions, focusing on ASD and related issues such as ASD closure techniques in patients with abnormal heart morphology or special health conditions, using various devices for ASD closure, using bioresorbable devices in ASD closure, and managing complications in ASD intervention. In addition to the on-site presentations, the conference will feature more than 30 live cases performed at 6 leading centers both domestically and internationally, including Children's Hospital 1, Ho Chi Minh City, Vietnam, Tam An General Hospital, Vietnam, It Hospital, Thailand, Institute Jantung Negara, Malaysia, National Taiwan University Hospital, Taiwan, and Apollo Navi Mumbai Hospital, India. The images of these cases led to the conference, allowing delegates to discuss, learn, and share experiences.
Everybody come up on the stage.
Vietnam, Tam An General Hospital, Vietnam, Queen Sirikit Hospital, Thailand, Institute Jantung Negara, Malaysia, National Taiwan University Hospital, Taiwan, and Apollo Navi Mumbai Hospital, India. The images of these cases will be broadcast live to the conference, allowing delegates to discuss, learn, and share experiences.
Everybody come up on the stage.
After 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only 2 major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal defect, ASD, intervention, is highly significant as ASD is one of the most common congenital heart defects, affecting not only children but also adults. A study published in the Journal of the American Heart Association, JAHA, in January 2023 reported that ASD is a common cardiovascular defect, with a prevalence of 2.5, 1.000 live births. With 25 to 30% of cases present in adulthood, the conference is expected to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as the USA, Canada, the UK, France, Germany, Italy, Poland, Australia, China, India, Pakistan, Bangladesh, Japan, South Korea, Thailand, Malaysia, Indonesia, Singapore, the Philippines, Egypt, Iran, Taiwan, and over 100 pediatric cardiology experts from Vietnam. During the 3-day event, 55 speakers from both domestic and international backgrounds will present over 100 scientific papers and demonstrate live interventions, focusing on ASD and related issues such as ASD closure techniques in patients with abnormal heart morphology or special health conditions, using various devices for ASD closure, using bioresorbable devices in ASD closure, and managing complications in ASD intervention. In addition to the on-site presentations, the conference will feature more than 30 live cases performed at 6 leading centers both domestically and internationally, including Children's Hospital 1, Ho Chi Minh City, Vietnam, Can An General Hospital, Vietnam, Queen Sirikit Hospital, Thailand, Institute Jantung Negara, Malaysia, National Taiwan University Hospital, Taiwan, and Apollo Navi Mumbai Hospital, India. The images of these cases will be broadcast live to the conference, allowing delegates to discuss, learn, and share experiences.
Everybody come up on the stage.
After 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only 2 major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal defect, ASD, intervention, is highly significant as ASD is one of the most common congenital heart defects, affecting not only children but also adults. A study published in the Journal of the American Heart Association, JAHA, in January 2023 reported that ASD is a common cardiovascular defect, with a prevalence of 2.5, 1.000 live births. With 25 to 30% of cases present in adulthood, the conference conference is expected to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as after 10 editions, the annual Congenital Heart Disease Conference of the Pediatric Cardiology and Congenital Heart Disease Society of Ho Chi Minh City has gained international recognition. This year, over 200 international delegates are attending, the highest number ever, after only 2 major congenital heart disease conferences in the world, PICS, USA, and CSI, Europe. The theme of this year's conference, a disease of atrial septal defect, ASD, intervention, is highly significant as ASD is one of the most common congenital heart defects, affecting not only children but also adults. A study published in the Journal of the American Heart Association, JAHA, in January 2023 reported that AS and cardiovascular defect prevalence of 2.5, 1.000 live births. With 25 to 30% of cases present, the conference is expected to attract over 200 leading congenital heart disease intervention specialists from countries and territories such as the USA, Canada, the UK, France, Germany, Italy, Poland, Australia, China, India, Pakistan, Bangladesh, Japan, South Korea, Thailand, Malaysia, Indonesia, Singapore, the Philippines, Egypt, Iran, Taiwan, and over 100 pediatric cardiology experts from Vietnam. During the 3-day event, 55 speakers from both domestic and international backgrounds will present over 100 scientific papers and demonstrate live interventions, focusing on ASD and related issues such as ASD closure techniques in patients with abnormal heart or special health conditions, using various devices for ASD closure, using bioresorbable devices in ASD closure, and managing complications in ASD intervention. In addition to the on-site presentations, the conference will feature more than 3 live cases performed at 6 leading centers both domestically and internationally, including Children's Hospital 1, Ho Chi Minh City, Vietnam, Tam An General Hospital, Vietnam, Queen Sirikit Hospital, Thailand, Institute Jantung Negara, Malaysia, National Taiwan University Hospital, Taiwan, and Apollo Navi Mumbai Hospital. Images of these cases will be conference, allowing delegates to discuss, learn, and
Everybody come up on the stage.
Good morning, everybody. Let me start with the meeting. I would like to invite Dr. Nguyễn Thị Ngọc Trung, President of Medical Society Association in Ho Chi Minh City, for welcome speech for everybody. Dr. Dung, please.
Ladies and gentlemen, distinguished guests, dear colleagues, on behalf of Ho Chi Minh City Medical Association, we would like to welcome all of you to Ho Chi Minh City and to the 11th Vietnam Congress of Genital and Structural Heart Disease. Organized by Ho Chi Minh City Cardiology and Congenital Heart Disease Society. This yearly conference marks a significant milestone in our collective efforts to advance the medicine not only in Vietnam but also across the region and around the world. With the participation of over 300 distinguished delegates from 28 countries and speakers from 34 countries, we are sure that this event serves as a bridge of medical education, bringing together experts, researchers, and practitioners to share knowledge, experience, and innovation in healthcare. During more than 10 years of continuous organization of the Congress by CHD, we noticed that the conference is not only an opportunity for exchanging professional knowledge in cardiology, but also the opportunity to meet old friends and make new friends. Some of you have become brother and sister in the big family of cardiology, especially in pediatric cardiology in Vietnam. We would like to send our deep appreciation to professors and doctors who have accompanied our Vietnamese colleagues on a more than 10-year journey as lecturers, speakers, and trainers. With your support and encouragement, the Society of CHD have the motivation to organize this Congress once per year more and more effective. We also would like to profit this opportunity to congratulate the staff leading by Dr. Do Nguyen Tinh from Pediatric Hospital No. 1 for performing successfully 6 cases of fetal infection. It is not only saving the baby, bringing hope, happiness, and joy to the family, but also showing the progress of our doctors on experience and skills, proving the effect of collaboration in medicine, especially via training course and conference like this event today. We would like to express our gratitude and our deep appreciation to all the speakers and participants from over the world for dedicating your valuable time to join the training course and congress this year. Over the coming days, we hope that you will work together to spark innovative ideas, forge lasting partnerships, and create a meaningful contribution that will benefit societies worldwide. Thank you again for joining us in this important event. May this congress be a resounding success, paving the way for the more transformative progress in the treatment of genital and structural heart disease. We wish all of you health, happiness, and success. Enjoy your time in Ho Chi Minh City and in Vietnam. Thank you.
Thank you very much for welcome speech. I would like to say on behalf of the Society of Congenital Heart Disease in Ho Chi Minh City, I would like to warmly welcome all of you to join the meeting. Welcome to Vietnam. I'm very thrilled and excited to see all of you to be here for joining the meeting, and your presence is essential for the congress become more successful. Over past decade, the Vietnam meeting has become the festive playground for diagnosis and treatment in the congenital heart disease, not only in our region but expressed to the many countries around the world. And this year with the topic is ASD intervention from A to Z, the contrast we will mention almost everything about the ASD intervention, from the simple to challenging case, from the diagnosis to intervention, and we also update the new technology, new devices in the ASD intervention. And of course, it's a plenty of knowledge, experience, interesting case around the world will be brought here, and we can learn, we can share together. It's really a good opportunity for us to learn together. And a part of Ho Chi Minh City, the live cases from Taiwan, Thailand, Malaysia, and India, several centers around the world would be the focal points for the congress. Many lessons I think will be learned from the interesting case, and not only the ASD case, but also the complex congenital heart disease will be intervened. And with the many activities, 3-day contracts, we hope and bring the many changes to get engaged different culture things, and we can enjoy the hospital of the Vietnamese people and as well as the Vietnamese culture. And on behalf of the Congress Committee, and I would like to express our sincere thanks to all our course directors, the faculties and sponsors, and for your great attribution to our Congress. And now I officially announce the Congress begins. Thank you very much. And for express our thanks to some our teachers, our friends, our colleagues who help us to run the meeting more than 10 years. And I would like to invite some special distinguished guests to receive our gift. Of course, our gifts to send to all of you to express our grateful thanks. But I would like to invite Shaq Qureshi, Mario, Jahid Amin, Teishi Akagi, and Jae Chung Choi, who is here. Yeah, and I would like to thank Dr. Jung, is the president of the Medical Association of the Ho Chi Minh City, and Dr. Min from the Children's Hospital is my hospital, who spoke us a lot for the meeting. Please come to receive the gift, the special gift, not share, not yet. And Trọng Phi Ly, sorry. Trọng Phi. Yeah. And thank you very much. And we continue with our scientific program. I would like to invite Jack for the run the first section, right? Yeah.
Right, good morning, ladies and gentlemen. I'd like to add my welcome to Tin's welcome and the President. So welcome once again to Saigon for this 11th meeting. It's really a highlight of the calendar, isn't it? Because this has become quite a large family event almost, and you'll all appreciate that the meeting content is always stimulating. And so we always carry on learning. And although ASD closure has been going on for decades, meeting this year will also emphasize to you that we've still got a long way to go, we're still learning. So again, welcome to this. We'll kickstart the meeting. I've got Dietmar on my left and Mai next to her, and Jin and Wang next to her. And I don't know if Songhai Kim and Deva Prasatha here to join us as well. Otherwise, I think, are we ready to go live or? Oh, all right. Okay, they're not quite ready yet in the cath lab. So let's go on to the first part, which is it's sort of a debate, if you like, where we're arguing whether ASDs should be sized with a balloon or just decide on a device based on imaging. And so there's no better debaters for this session than my pleasure to welcome Bharat Dalvi, followed by Zaid Amin, who are going to completely oppose each other on this. And Bharat is going to say, well, probably, we should still carry on sizing with balloons. Bharat, welcome to Ho Chi Minh.
Respected chairpersons and my dear friends, I don't know whether this is a debate or not, but I have tried to make it into a debate. So the title of the debate is Sizing Balloon in ASD Closure, Still or Stop. I am proposing the motion that sizing balloon in ASD closure should still be used. It's always a pleasure to debate with my friend, Dr. Zaid Amin. So, let me start this debate by taking an audience poll. How many of you balloon size the ASDs? And how many of you don't balloon size? Okay, so majority of the people say that they don't balloon size. But I think this is out of threat. Most of them are threatened by my dear friend. When I walked in the lobby yesterday evening, I saw this gang trying to threaten the delegates and trying to make them vote against the motion. Debating has not been a part of Zahid's armamentarium, but nevertheless, he took his training at Mar-a-Lago from none other than Mr. Trump. And what he actually learned was that you should threaten, you should disrupt, and then you can talk anything, it will go. But that is in a presidential debate, not in a debate where you have so many academicians coming together. And it's not only that he threatened you, but he threatened me as well. As a matter of fact, he changed his course from Orlando to Vietnam. He met all his allies on the way. So he took a flight from Orlando, and then there he goes to Moscow to meet his first ally. Had a friendly bout with Putin, and then flew into, and then flew into Beijing. So you can see that he flies from, how do I start this, guys? Can you start this for me? Hey, come on. Can we start this? Okay, so he goes here to Moscow, has a friendly bout with Putin, then moves to Beijing to meet Xi Jinping, and then to Pyongyang. So he has collected his allies across the world, and he has threatened me that if I bash him up verbally in this debate, he's going to bump me off. So now to a more serious issue of sizing balloons. Sizing the defect and deciding the device size is one of the functions of the sizing balloon, and one who believes that this is the only function, it is being myopic. All of you, like me, who see a bigger picture, sizing balloon is used for things beyond sizing, for interrogating the defect and the interatrial septum, to decide whether we are going to use one or multiple devices in cases of multiple ASDs, the type of device that you're going to use, and last but not the least, the same balloon can be used for deploying the device using balloon-assisted technique. Why is sizing the defect so crucial? What are the current practices, whether it is imaging guided or whether use of a sizing balloon? Why balloon sizing makes sense, and what are the disadvantages of empirical sizing? So that's all that I'm going to discuss in the next 5 to 6 minutes. So is sizing the defect crucial? Yes, of course, because it helps in deciding the device size. And if you oversize, you will end up with AV valve injury, pulmonary or systemic venous obstruction, heart block, and last but not the least, erosion. And if you undersize, of course, you will end up with device embolization. Now, there are two ways of sizing. One is image-guided sizing, where by using one of the imaging modalities in 3 standard views, you make the measurements, and then you either take a mean, or you take the maximum measurement, or you take the mean of the major and the minor axis, and decide what size of device you're going to use. So a kind of approximation. In 3D imaging, you can take the maximum measurement, or again, mean of major and minor axis. And different groups have their own formulae of adding nothing, or adding 2 millimeters, 4 millimeters, 6 millimeters, so on and so forth. Now, even in a moderate and a garden variety of ASD like this, you can see that there is a significant difference between the anteroposterior and the superior-inferior diameter. Anteroposterior is approximately twice the superior-inferior. And if you see in a large ASD like this, you can see that the long axis is 37 versus the short axis of 30. So most of these defects are oval and very difficult to quantify, therefore, is circular equivalent. So my questions to my worthy opponent are, How do you convert an oval into a circle? What is the relationship of the minor and the major axis of an oval to the diameter of a circle? And last but not the least, how do you judge the stretchability of the surrounding tissue? And none of these can be done by mere imaging unless you use balloon sizing. Now, as far as balloon sizing is concerned, we started with a circular balloon with a pull-through diameter, which was not a great idea because you could traumatize the tissues and you could overestimate the diameter. But with elongated balloons and with stop flow technique, I think that you are able to come closest to the actual diameter of this particular defect. And here again, different groups have different formulae of adding nothing, for example, in children, or in patients who have excellent rims, or adding 2 millimeters in absence of aortic rim and maybe 4 millimeters in adults with large ASDs without aortic rim. So this is an example of a large defect, and you can see that a balloon is used to make the measurement. It was 34 millimeters, and we could get around using a 36 millimeter device. So why balloon sizing is better? Because as I just showed, all modalities of sizing are an approximation, but balloon sizing allows conversion of an oval to a circle and helps you assess the stretchability of the whole. With balloon sizing, there is a room for more standardization than just looking at it. Therefore, less chances of over or undersizing and paying the price for doing it. And if you were to end up with a complication, professionally as well as medico-legally, you will be able to justify yourself and justify your stand in case of a medico-legal issue. Now, role of sizing balloon is beyond sizing for interrogating the intratracheal septum, as in PFOs, multiple ASDs, malaligned ASDs, and aneurysmal IS with ASDs. And as I said, you can use the same balloon for balloon-assisted technique. In multiple ASDs, balloon interrogation helps in deciding one versus multiple devices, helps in deciding the size of the device, and helps in deciding the type of the device. And you can see here, 2 ASDs. You can never know whether you're going to use one device or 2 devices. With balloon interrogation, this is just a stop flow, and then we inflate the balloon further, as you will see in fluoroscopy, to stop the flow completely through both the orifices. And then you can safely use a single device and close both the defects very effectively. As against this, you have these 2 ASDs, the balloon through the inferior ASD, balloon interrogation done, but the flow persists through the superior defect. Balloon interrogation through the superior defect, the flow persists through the inferior defect. It's only when you put balloons through both the defects that you are able to close both the defects. And hence, rather than using a single device strategy, you would end up using 2 device strategies. This you cannot decide just looking at the defect, whether you are going to use one device or multiple devices. Similarly, you interrogate a defect like this with a balloon, which has a discrete secundum and multiple defects in septum primum, and you can see that you need to actually use a septal occluder and a cribriform septal occluder to completely close all these defects. In malaligned ASDs without balloon sizing, you will underestimate by echo sizing alone, and there would be high chances of embolization. In aneurysmal IAS, it can be very tricky. You can see this. This is a huge aneurysm. What kind of device and what size of device you are going to use. But with the help of a balloon interrogation, you can see that you take the balloon, slowly inflate the balloon, and the whole defect is closed. So you can safely use a septal occluder and close this entire aneurysmal defect very effectively. The opponents of balloon sizing usually tend to argue that it oversizes the defect and therefore the device. Stabilizing of the balloon is a problem, but I don't think, because this is a 34 millimeter defect, which was effectively closed by using a 36 millimeter device after sizing with a balloon. So I think this is not an argument really valid, although it can happen in some cases. It There would be an extra cost, there is an extra time, but it is better to pay the price of extra cost and extra time rather than paying the price of under and oversizing the device. So in conclusion, ladies and gentlemen, role of sizing balloon is beyond sizing. It's more accurate in sizing the defect and the device. And amongst all the approximations that we use in our day-to-day practice, it is the best of approximations. Therefore, there is no substitute when it comes to interrogating the defect of the intratracheal septum. Just by imaging it, you will not be able to decide the type and the size of the device that you are going to use. And certainly, it's mandatory when you are dealing with multiple ASDs, aneurysmal intratracheal septum and intratracheal septum, which is malaligned. So I would rest my case by saying, please say yes to sizing balloon and don't throw it in a garbage bin so far. Thank you, ladies and gentlemen, for your patient hearing.
Bharat, thank you very much indeed for a very stimulating start to this session and the debate. Before we get Zahid to present the opposite view, they're ready for us in Taiwan, I think, and Zhuku Wang. So let's join Taiwan. Yeah, we can hear you. Yeah, Zhuku. So, Juku, yeah, Juku, just give us the current pressures, because from the angiogram, the predominant lesion is pulmonary regurgitation, free pulmonary regurgitation, isn't it? So, what are the current pressures? Okay. So just because the sound's not very good, but so have I understood it correctly that you're planning, there's some gradient at the distal end where, on the lateral where the pigtail is, and you're intending to put a stent there. Is that correct? 10. Okay, Ahmed.
There are many stent fractures in this distal end of the stent. So also there is narrowing just before bifurcation. So it is better to put another stent to cover all of the narrowing part and also fractured part.
So you would put another stent in like Juku's planning, yeah?
Absolutely.
Yeah, okay. Okay. Can you show us the various steps that you've done then? It's a good job we didn't disagree with you. So just tell us, I'm assuming this is a Lunderquist wire, and what sort, just give us some, and what sheath is it, what French? 14 French. And you've got the, which stent is this? CP. Bare or covered? Bare. This sounds like an interrogation, doesn't it, in a prison. And what size balloon? 22. Okay, thank you. Okay, Gareth first and then Dietmar. Okay, Gareth's got a comment or question.
Yeah, thanks, Shaq. Hi, Jobu, how you doing? I was going to ask, what other options you have for stents, given that you can see you've got multiple fractures in the CPs that you put in before. Is this the concept of hope over expectation? That this is not going to fracture when you put this in here? Would you have considered putting a stent that's less amenable to fracture in to allow you to be more confident that that's going to give you a stable landing zone for the future, like LD Max or even a big PAMA stent or something? What are your thoughts? You don't? Okay. Understood.
All right, Dietmar. So Juku, Dietmar has a comment or a question for you.
I have a question. Juku, here's Dietmar. Nice to see you. I want to know the connection, the surgical connection, previously before the stent was implanted. Was it done by a conduit? I didn't got it because and the stent what you are using now is the covered one, because a little bit I fear a disruption in this area if you implant even stent, bare metal stent alone. So can you comment on this, because it is very important. I have a bad experience with a similar case. What do you mean?
sorry, Juku, I may have missed it, but Dietmar asked the question as well. What is the conduit made of? No conduit. Oh. Oh, I see. Patch, okay. Okay. And then the encouraging thing, I guess, to justify bare stent versus covered, is there's no or hardly any calcification in that region, so you're less likely to have a rupture. So, Juku, carry on now if you could, because Warwick's ready in Bangkok. Okay. Anything a little bit more distal, perhaps, but yeah. So, I would have done a check angio between the inner and outer, but that's fine. Too late. What, I won't disturb you. Have you, I'm assuming that you've got a clear idea that the coronaries are okay. Right, yeah. And is your plan, Mario, if you come to the microphone, what would you do next? There's a microphone in the middle. Yes, there somewhere. What would you do next? Leave it as it is, or would you be thinking of a valve, or what?
Well, it depends upon.
Hold on, Juku, hold on, Mario. Just go ahead, Mario.
Well, it depends upon the pressure. If you have zero gradient, you can be satisfied with this. But if you have a residual gradient, and lucky enough to have been implanted in a cover stent, you can further enlarge the stent by achieving a larger size, which is going to be probably better for the long-term result.
So you would not plan to put a valve in at the moment?
Well, what I would have done in this case, first of all, I would use a cover stent just to be safer. And if you're not happy with the size achieved, I will post-dilate with high-pressure balloon to achieve a larger size. And based upon the final result of the size, I will decide the size of the valve to be implanted in.
Yeah. And what valve, whilst you're at the microphone?
Well, you can use whatever you like. If you, for example, reach a 24 millimeter valve, you can either use a larger Melody or a Sapien. Probably the Sapien valve will be the easiest to implant in this case.
Okay, thank you. Right, Juku, so tell us what you're doing.
I think we are implanted to 22, so I will use the 24 by 38 pasta bar. Yeah, so probably allow us a few minutes, then we'll go back again.
Okay, so you're definitely going to go ahead with Polster. Is that what you said?
Yeah. We have pasta only in Taiwan.
Okay. All right. Well, Ahmed, very brief comment or question.
The size is too large, so it may not work properly. 26.
Sorry, what's too large? I can't hear you.
Yeah, as far as I understood, it's planned to put a 26 millimeter.
24.
Even 24, I think it is not more than 20. I think it is about 20 millimeters. So 23 is okay for
22.
Much.
Okay. All right. All right. Juku, we'll come back to you because Warrican's getting a bit impatient as well. So, all right. Let's move over to Bangkok. Right. Good morning, Warrican. Oh, no, it's not Warrican, is it? Where is he? Oh. Yes, it looks like Cici and Super. I can see that.
Good morning, chat. So welcome to Queen's Circuit National Institute of Thai Health. So right now I'm with Supa from PHU and also Dr. Petanyu from Queen's Circuit National Institute of Thai Health, our fellow, Dr. Claire and also Larissa Faulkner. And we also with the anesthetic team, big AV team and also notes prepared for the wall.
18 by 23 millimeters. MPA diameter was 31 by 37. RPA diameter was 17. RPA diameter was 15. The dimensional show enlarged RVLT and small proximal RPA with the maximal diameter at the RVLT of 32 millimeters. And there also was no query issue seen from the G ratio. The angiogram is in iopedia and the top view show fibular and suspected RPA stenosis. There was NPA to RPA gradient about 4 millimeters mercury. The measurement of the distal PA was about 30 by 35 millimeters with T was 35 by 36 millimeters. The proximal RPA diameter was 12 and distal RPA diameter was about 13. The symmetric volume size 18 by 30 millimeters was big and inflated, but there was no waste, so the gradient light from the RPA angulation. This was the selective laboratory angiogram without balloon inflation, and compared to balloon interrogation simultaneously with RV angiogram and selective laboratory angiogram using ASD cyclic balloon 34 millimeters, show complete occlusion of the RVT and no compression. With the measurement of the base at combined last was 28.7 by 28.3 millimeters, and the distal part has stretched up to 38 millimeters, and the proximal part was 32 by 34 millimeters. So the next is that I want to talk more about the three-dimensional case.
Okay.
You cannot see me chat, but I hope you can hear me quite nicely, right?
Yep, we can hear you very nicely.
Just to share some tools that we just received this year, so you can see if this is the Western navigation. You see it on the screen?
Yep.
Yeah. So just to share that this has been quite useful for us so far in terms of the planning. So how we plan is actually we start with like a routine like this, so you can appreciate that with that it's not been good to review the anatomy quite nicely. So that's why sometimes we need to be a little bit more changing in angulation. So with that, in cranial, you can see it's much better to delineate the alignment of the APA together with the R and RPA. And if you want to see the bifurcation, of course, you have to be in a little bit more cranial like that. So with that, you can mark it as the angle that you need to use. And also with that, we put the rim here, and as you can see that the rim is where the waist is, which is likely that you are anchoring sort of for any kind of valve you're going to use. And one more thing, when we try to change the contrast, with that it shows up the coronary artery here quite nicely, and you can see this is the right coronary artery, which is quite far away from the very far, but it's just there. And on the posterior view, you can appreciate that where is the right left coronary artery is lying there. So it means that likely the landing zone that we could use, which is less compliant, would be at the blue ring. And in this particular case, I'm not sure whether the team what kind of valve we use, likely to be venous, but likely that with that the proximal flap should stay just below the blue ring, and the distal flap should be somewhere around there, which is the thing that we need to a little bit concerned where the distal flap is. It may interact in the right left coronary artery down there. So I'll stop here for a while and let Sissy ask if you need more detail from me. Otherwise, please proceed.
Okay, Warren, fascinating. So if you could just hold it there. GT, if you go to the microphone, faced with this sort of anatomy and some of the dimensions we've seen, what do you think, what would be your planning?
You mean what kind of valve or
Yeah.
size? Yeah, to me, looking at the measurements, we have a kind of a narrowing of a 28 millimeter, but there's huge dilatation of the just pre-bifurcation. I will look for a P venous valve of 34 millimeter times 25 in length. That's with my thing.
34, 25 length.
34 millimeter.
Okay. And just hold it, supraannular or transannular positioning?
I will place it in the position at the ring, the valve, that area. Not sure you want a supra or not, but I think it's very dilated above the supra valve area. So I will put my valve at that ring.
Okay. Thank you, GT. Alison, quickly to the microphone, please. And the same question to you, faced with this sort of anatomy in the US.
So I think we may consider Harmony with a little more annular implant or potentially Altera. I'd defer that to Jenny sitting next to me. We haven't used venous P-valve yet, but
Okay.
hope to.
So in your center, what would you use then? Altera?
Probably Harmony, annular.
Harmony. Jenny, I've just, now that I've seen you, what do you think of the planning here, and what would you do?
I think the planning with vessel nav is great, as Warakan said. We use it too, and it's very helpful. Yeah, I think Harmony or Altera, from our perspective, the only thing is like for the MPA, the concern is like if it dilates a lot in the dynamic angiograms, then I don't know, advancing the PDS and the sapien valve towards the Altera may move it forward if there's no good opposition. So I think Harmony, or we're talking a 32 venous speed.
Thank you. Jae Young, to the microphone very quickly. There's one just behind you. What would you be thinking of using? Polster?
I think the size-wise, first 32 millimeter valve would be very nicely fit to this anatomy. However, the only concern is that we have to implant annular to subannular area. So then, if the patient has some ventricular edema, there would be some concern.
Okay. Oh, Zahid, very quick then, and then we'll get Warakan or CC to move.
So, two things. This patient is 17 years old, and I think, right, so I think you should put the regular Edwards 29 valve in this patient without any Harmony or Altera or Pulsta, because this is a 28 millimeter ring, so you can add 4 or 5 cc's and just put just a valve there. 10 times better than putting all the other mess in it.
Yeah. All right. I didn't. The sound is not brilliant, so I didn't understand pretty much any word of what Zahid said. So, just a brief one. What size valve would you use, and which one?
Edwards 29.
Edwards 29. Okay. Why didn't you say that in the first place? All right. Warakan, let's. You've had multiple opinions. What are you thinking, or CC rather?
Okay, so we will show our debate today. So, Dr. Nathaniel, please.
In this time, we perform cardiac cath in the S-state with right femoral vein. So we can see the right femoral vein in size about 8.3 millimeters. And then we perform hemodynamic data. The hemodynamic data was collect LVDB was about 8 millimeter mercury. And there was no significant pressure across RV to PA and slightly pressure gradient at the RPA to PA about 4 millimeter mercury. The FDA kilogram review the CVHDR with RV derivation and the zero duration of the RPA. The measurements as follow: the distal PA verification is 35 millimeters, and the mid NPA was 52.4 millimeters by 42.6 millimeters. And our EOT was measurement as 31.8 by 33.7 millimeters. The range was about 25. We perform selective left coronary angiogram review, no origin of the left coronary artery and no coronary obstruction. And we also perform balloon infiltration simultaneously with RV angiogram and selective left coronary angiogram. There was no compression of the left coronary artery. And we measurement the balloon measurement. The weight of the balloon was about 29.2 millimeters by 28.1 millimeters. And the distal balloon measurement was 34.1 and by 37.2 millimeters. And proximal balloon is 32.5 by 30.7 millimeters. And the length was about 25 millimeters.
So the measurement at the annular area is around 29 by 28. 45 by around like 35 to 37. So we plan to use PSP to deal with this particular PR. And what size of the Venus P that you think we need to use?
Well,
Do you have our
okay.
Do you agree with that or any concern?
GT suggested 34 by 25. Kevin, very quickly, just a one or two word answer size-wise.
You could go with the 32.
Sorry?
You could go with the 3225.
3225, okay. Any suggestions from the panel? Microphone there behind, on your left. Mai?
Yeah, hi. Hi, Sopa. It's Mai here from Egypt. 3225.
3225.
Yeah.
All right. Kim?
But she might get away with a 34, actually.
We have harmony in Japan, so 25 is a very best fit for that.
Harmony TB with 25. Okay. Jianan?
I think 32 to 34.
30. Which, 32 or 34?
32, I think.
32. Okay. All right. So you're getting a mixed opinions here. I must say, I'd be inclined, looking at the distal MPA, I'd be inclined to use a 34-25.
So we plan to use 32 by 25, and we want the landmark to be at the third sternal wire where we measure. It's similar. The wedges on the AT is also on the third sternal wire, and also same with the lateral. So we may put the valve in and then try to get the proximal marker at the waist of the balloon. Then Dr. Katanju will show you the valve.
Okay, let's check how much minutes we have. How long do we have?
Well, not too much time because Juku is waiting as well. So if you could do it
So we probably need to speed up then.
faster.
During we unqualified valve, we introduced the Venus T valve. The Venus T valve is a self-expanding valve using lithium supporting frame and powered by the posterior into the hybrid configuration. The strength may be using Susan TFT covering. And there was a distal flare and a proximal flare. And there was a six radial tracker to using to perform the precise position of the valve, which you can see in the angiogram. Okay, the size was 28 to 36 millimeters, incremented by 2 millimeters, and the range of the valve is 25 and 30 millimeters. And in the proximal flare, there was 2 hooks to attach the delivery system. And the delivery system is composed with 32 and 24 French delivery system.
And have you already loaded a valve, or is this? No, yeah.
That one is a demo one.
Ah, right.
Right now the valve is the valve is in the tension. As you can see, we put a 26 French chloride on the left PA, and then right now we have the valve ready to deploy. So right now we'll show you the live angiogram. Here from the angiogram you can see that the proximal part of the valve is in the RPA. So we will try to open until the the distal marker, and then decide to pull things down.
If you could just show the angiogram before this, sorry, Cici. Very quickly.
This one?
Yeah. So have you got landmarks sorted out on your fluoro as to where the valve, the proximal flare is going to be, or where the valve dots are going to be?
Yeah, we plan to put the proximal marker at the third sternal wire.
Right, yeah. Okay.
Which is similar to the wedge of the balloon. Let's go back, and then
Yeah. Okay.
Okay. The other one just keyword perfect. Yeah, that's it. Right. So you see the ring, right? So first turn the wire as a signature.
Yeah.
Okay. So two power release the valve.
Yes.
And just to be clear, this is 3225, yeah?
Yes, this is 3225.
Okay.
So you can see that the carrot is coming back.
Yeah, for those who not get used to the ASD, likely that they need two operators. Like now, Cici is the first operator who gonna maneuvering the wheel system. And
Okay,
second
right
operator.
now we are at the digital marker.
Wow.
Yeah, and we see that it's still in the RPA. So what we did is going to move the system down a little bit more, and I will pull the chloride seal until half of it. Yeah, and then we release the valve. Okay.
So just whilst you're doing that, you're keeping the dry seal sheath halfway between the two dots.
Yes.
Yeah, okay, good.
And open the valve until at the mid part of the venous and wait a bit for the flower to spread. Yes. A little bit more. Yeah.
And it does take a while for the nitinol to expand, doesn't it? So.
Yes. Please. I think we are in a good position to pull the long sheet down until proximal marker, which is now close to the third sternal wall. Okay, but yeah, that's good. Yeah, that's good. And then now it's where we wanna release. So release until we reach the proximal marker.
It's probably positioned itself nicely.
Yes. Okay.
But that's one of the things for the audience. You have to be very careful in withdrawing sheets and so on because you can pull the valve too low. So if anything, you have to keep a forward push. Do you want to before you go? Before you go any further, do you want to do an angio?
Okay, so yeah, this is the angio. So we thought we are in the position that we want to deploy the valve. It looks a little bit higher than the ring that we put, but then when it come back to align with the RVOP, it should be okay. So I will pull the chloride seal down and then we release. Okay. So now I'm gonna release the rest of the valve.
Yeah, if anything, you have to keep a little pull rather than push. Yeah, that's it.
And we're gonna open until we see the two ear are completely out of the valve. Yes. I think we see two ears coming out right now. So hold on, please. And this is the RVOP.
Very nice.
Yeah, I think the valve is in the nice position. So next we will remove the carrot. So doing remove the carrot, we will try to let the wire in the middle of the valve, push the wire down, and then push the wire more. Can you push the wire more? Yeah.
Yeah, two places where the carrot messed up, the distal flat, proximal flat. So we centralizing the nose cone.
Yeah, very nicely done. Oh, wires coming back. It was nicely done until then, yes. And Yep.
Yeah, so we exactly land about in the place where we really want to land.
Mm.
So this is a thing that's quite helpful. We're still learning on that kind of using this tool, vessel navigation, but it gives us a little bit more understanding. And that we do. Let's say if I'm if I'm young, like 10 years ago, I may use this tool as my landmark much more common because it's quite nice to guide what I should aim for.
Cici, we need to move you a little bit. You're going to do an angio for us, and then we'll move to. I was just going to add a comment that 32 is obviously worked very well because the anchoring point is the annulus. If people had said, "Oh, use a 30," there would have been a possibility of paravalvular leak, I think, because of that dilated main pulmonary artery. So 32 or 34 would have done a good job. So if we could see an angiogram, yeah, very nice. Okay, all right. What's your next step?
Do the spontaneous pressure to see that gradient across the valve or not? Can you show the pressure, please?
We see the pressures now. Yeah, no. Very nice. CC, super work and well done, brilliant results, excellent case. Yeah.
If we can have just a 5 minutes,
Oh.
I'd like to show the diameter that we measured the valve.
It'll have to be less than 5 minutes, though.
Diameter of the valve. Oh, no, sorry, 10 seconds or whatever. Because approximately 27.3 in the plane A and 24.5 in plane B. So it looks more constrained. I'm not sure if you see it or not. In the pump and zero. Yes. Yeah, so it makes no sense because previously we also discussed whether 30 is enough or not in this particular case. Well, I think 32 is fine. It's very nice, as you can see.
Yeah.
But 30 also, in retrospect, can be usable for this particular setting.
I think 32 gives you more security. 30 would have either gone more distal or proximal, and yeah, you're causing problems for yourself. Dietmar, you wanted to say something?
Super.
Very quickly.
No, I have a question concerning the stress of the valve, the distal part of the valve on the pulmonary artery. Did you see, we have a talk later on concerning erosion. Do we have seen a secondary rupture or a dissection of the pulmonary artery by the stress of the distal part of the valve on this tissue?
Yes, thank you. From now until now, we didn't see this kind of problem for the VMAX patient. I think because the flare of the valve is come inside, not move with the MPA. So it might help for less of the problem of the erosion or aneurysm from the valve. Yeah.
Okay.
But you keep an eye on that also. Yeah.
Sisi, super work, and thank you very much. We're going to have to move to Juku. Yeah, well done. All right, Juku, we're back live with you now, or shortly. Right, Juku, can you hear us? Okay.
So now we have positioned the valve in the left artery. Then we're going to deploy here.
So what size and length did you decide? I've forgotten.
I use half valve 24 and 138.
Okay.
But after understanding the measurement is 32 and the record I maybe 19.7 something. So I think for this stent already there, we don't need to oversize too much. Maybe 24 will be okay for this case.
Okay, just talk us through the position, because unless we can make the fluoro big. I can't see it. No, the images are small. I don't know if you can split them into just two. Because at the moment we've got 5 images, 6, including you. So it's all a bit small, but you carry on, Shuko. Well, we see the carrot very well. No. That's what I was. And so, Juku, do you do check angios, or do you just use the stents that you've got in place and use those as a landmark? That's better now. Yeah, sorry.
Because the pasta valve, the wire is not very much very fat comparing to the CT stent wire.
So, I'm trying to work out where the valve is. Is it fully deployed or?
Yeah, already fully deployed.
Okay.
Because the hook catch the CT stent.
Yeah. Yes.
Mm.
Yeah. Yuko, did you close the delivery system again, or did you let it open?
No, it's not closed.
Yeah, maybe you have to go distally and then close it and then remove it. I think it is a good idea. I have a problem with Horst Sievert in Frankfurt, and then it was solved, this problem. So go.
It's coming now.
Huh?
Oh, no. Well, it was.
I think it's better to push wire more to change track of the wire.
No.
Mm-hmm.
May change the position.
So is it the carrot caught in the distal part of the pulsar valve?
May I make some comment?
Yeah.
Yeah. So, Jugo, this is Jay. I think the problem in this case is that you couldn't see the relationship between the hook block and the valve. So it is not generally recommended by the company, but you can push the wire and centralize everything, and then you can very gently rotate clockwise. Then frequently it separates the hook block from the proximal strut. So, magnify the hook block area to increase any chance to see the hook block and the proximal strut.
So Jay, are you suggesting that he should push the wire rather than pull it?
Yeah, push the wire and centralize everything, and then gently rotate the handle and the shaft.
Oh, you've done it then?
Now separate, you have to, yeah. Where is the valve?
Yeah. Okay.
Okay.
Okay, that's a different way of doing it. I'm assuming that you don't have balloon wedge catheters. Many of them have been withdrawn. Well, the other option is to do either transthoracic echo or TOE if you want to look at the valve. Because what you don't want to do is trap the pig around the stent. Okay. And at the moment, the Pulsar delivery system carrot is still in the right atrium, isn't it? I would pull it down in case somebody accidentally pushes it into the atrial wall. Okay. Whew. Well done. All right, that was an excellent result in the end. All right. And we've got to move to Malaysia next, Juku, but we'll be interested in the pressures. You can tell us next time. All right. Okay, thank you very much indeed. Well done to your team. A very challenging case. So we're moving to Kuala Lumpur, and I think Masni should be there. Is that correct? Marisha, we can't hear you. We can see you. Yes, but not very loud. I can hear myself louder than you, which is not good. Yeah, good morning. Yeah, that's better, but if we can get rid of my sound, because we're getting the echo, but you carry on.
All right. So, thank you, Tim, for the invitation to be part of this Vietnam meeting. So, we have lined up three interesting cases from IBM today. So, for the first case, we have a transcatheter foundry block implantation. So, we have a big team from Malaysia, myself, Marisha, we have MC Leong, and we have Madan and Nizam. And our anesthetist is ASD and Soraya. We have our angiographer, Fahmi, and Hafiz. We have our CBT, Rabbani. And not to forget, we have very, very strong support at the back, Mazni, Haifa, and Gita, and also Ali. All right, so, Karangish, are you ready? Let's hear from the presentation.
So who's presenting? Okay. We can't hear whoever's presenting, but we can see the slides.
Okay, so the first case is Hassan. He is a 14 years old boy from a regional hospital in Malaysia. He has underlying pathology of failure, post-repair. The repair was done on Malaysia back in the year 2011, and now he's referred back to us from the regional hospital for peripheral PR. Clinically, he is an asymptomatic in my class 1. Vital signs are stable on UNAM, SpO2 is 98%, heart rate 60, BP of 130 over 90. On cardiovascular examination, he has a early diastolic abnormal at the left upper sternum. Lungs are clear with no organomegaly on abdomen examination. So this is his ECG done on admission. He has sinus rhythm, heart rate of 74 beats per minute with the right ventricle hypertrophy and also a QRS duration of 174. Chest X-ray shows clear lung tube with mild cardiomyopathy. So this is his echo. On the vital fourth chamber, we can see that the right-sided chambers are dilated. There's a normal LV. RV function is mildly impaired with a TAPSE of 14 mm and an RVS prime of 8.7. On the right-hand side, you can see short axis. There is a T4 PR from the into the RVOD with a gradient across PA of 70 millimeter mercury. So we got a CMR done back in July 2024, which shows the volume RVEPD volume index of 185 ml per meter square, RVESD index of 140 ml per meter square, and RVEF of 40%, and quite severe pulmonary regurgitation
Do a lot of transcatheter patch.
Yes,
How is they do a transcatheter patch with a monocastle?
What is better to have
obstruction or yes, now we tell them please
so these are the
obstruction.
images.
Yeah.
The first, from the fourth chamber view, you can see, just like the echo, RV is very dilated. In the middle, showing the size of the RPA and LPA. The RPA is good size as well as the distal LPA, but there is moderate proximal LPA stenosis. And on the third video, you can see the RVOD
Okay. All right. Marisha, I'm just going to pick on, sorry, I'm just going to pick on a couple of people to get their views. So, Kevin, very quickly. Any thoughts on what you've seen so far?
I think it's probably going to be right pulmonary artery direction for the valve. I'm not sure of the size yet. Maybe I would make that decision on when the balloon sizing has been done.
But would you think about supraannular positioning of a valve, or transannular in this case?
I mean, because it's pyramidal, just in terms of your minimum diameter on the angiography, I think you're going to be fairly high with this implant.
Yeah. Okay. All right. Thank you. All right, Marisham, carry on. You're showing us RAO cranial projection angio.
Jacques, may I ask you?
Mario, yeah, go ahead.
Well, just a big question about a short question about the original LPA. Are you happy with that, or you consider to get it fixed before putting a valve in, or afterwards?
Okay. Question from Mario there, Marisham.
So the thing about this LPA by this MC here, so we noticed that there's no actual stenosis of the LPA proximally. It's more of an acute takeoff of the LPA, and we did a full back effect from the distal LPA to MPA, there's no significant grading. So we feel that by not putting a stent, it will interfere with the flaring of the distal flare of the valve. So we thought, since there's no obvious obstruction, we'll let it be and
So MC, just to get it clear, there's no gradient, did you say?
No gradient.
No gradient. So there's no point in doing anything. Okay.
Yeah, but it's just that, with the acute takeoff, whether you're concerned that the distal flare will be a problem.
Yeah, a bit tortuous. Okay, so apart from this, angio, what else have you done so far? Yep.
All right. So this is measurement from the balloon as compared to the previous measurement. All right. So this is the RBOP measurement before the balloon sizing. The narrowest diameter, and if you see the indentation, that is about 26, and proximal is about 28, 27, and the length about 24. And the flare in the PA is about 26. Next measurement. So this is the balloon sizing. If you see that indentation, the narrowest diameter is about 29, and the proximal diameter is about 32. And then the lateral. So this is the lateral measurement. The proximal part is about 23.5, and the distal part about 30.
So basically, we're looking at a diameter of about 29-ish. So if you look at the morphology, it's bounding very middle. The MPA length is pretty short. And then with the acute takeoff of the LPA, we just want to ask the audience, the panelists, what's your thoughts and how should we mitigate these challenges?
Okay, let's see what.
I just want to show you, this is actually a central sheet. We don't have raw tricycle sheet. And this is actually meant for party, so it's actually straight. So in order to negotiate the ROT, we actually bend it slightly. So we're going to pass the sheet, and as we're going to discuss the optimal.
All right. Let's see what Zaid. Let's see what Zaid is going to tell you. What advice he's got to give.
Okay, so no advice. I'm just going to echo what Mario said. You have to look at this LPA. It's less than 1/3 the size of the right PA, and they have not even opened it up. On top of it, when you see the initial angiogram, you see a big septum going down, and that's one of the no-nos when we do Harmony or Altera valves to how low we need to go. So I really believe that they should do LAO caudal view to open up the left pulmonary artery and see how small it is, and if it can be addressed.
So, just to get it right, so you would stent the left pulmonary artery now?
I
Well,
would
I would
interrogate
have
the
to
LPA.
kindly
Yeah,
disagree.
Zayed, stay on the microphone, but
The
Alison.
LPA kind of scares me.
Hmm?
The highly pulsatile compliant lesion
Yes.
is pretty hazardous, so I would valve the patient and bring him back for the LPA.
Yeah. So you want to make things difficult for yourself by stenting?
No, but there is a big septum above there, and if the valve is high, you may not be able to get to the LPA or may never be able to open the LPA.
Well-
So that's an if, right? I mean, so why not just address the LPA before you address the valve?
Okay, just to make it difficult, I guess, yeah. You can do. MC, you can have a listen to Zayed's advice or ignore
Check.
it.
How would you make it? Tell me, I'm going to talk to you now.
I
How
would
do you
not,
make it
I
difficult?
would not stent this LPA. I would do the valve and then decide if there's no gradient, I wouldn't even touch it.
I said I would interrogate the LPA. I didn't say stand.
They've done it already and
No,
said
they
there's
have
no
not. They
gradient.
have not opened it. You're just looking at it like this. You have to fillet open it. You have to go alveocaudal. view to
Okay,
do
well, I'm
this.
relying on MC to tell us that there was no gradient. Salim.
So I think the other option that I do is I do a perfusion scan prior to the procedure or even after the valve
Good.
to actually see what the flow differential is. And if there isn't one, with the absence of a huge gradient, you don't have to do anything about it.
Yeah.
Yeah.
No, that's a very good point. Or MRI perfusion scan or other perfusion scans, nuclear medicine ones.
Check.
Yeah.
Yeah, we found that sometimes when there is a kink in the LPA and then you put the venous P valve with the upper flare, sometimes it just corrects the kink and then you don't find this again. So I think put the valve first and then see what happens with the LPA.
Yeah.
And
I think once you stent the LPA, you're making it difficult for yourself to do the valve. I mean, I've got some worries about the anatomy here anyway, because this is a very, very challenging anatomy in my view, I think. And yeah, Gareth is pointing to what I was thinking as well. Gareth, why don't you go to the microphone and make your point? I can see it.
Yeah, I hate it. Makes me
Bit nearer the microphone.
This makes me really feel sick when I see the sheath doing this when we're in these cases, and I wonder whether or not you might get round, but whether a right IJ approach here might help you make a curve in the RV, because it's, as the operator, it's always awful to see the sheath and dilator heading over towards the lateral wall of the LV or the RV and not wanting to turn around.
Yeah.
And if this is the best you can get with the dry seal type sheath, it's going to be difficult to know whether or not the valve is going to follow around and get into the RPA. This is tough.
Yeah, no, I agree with you on that. I think either you go for internal jugular, but at the moment I would use a long balloon and try and get a balloon assisted, so 8 centimeter long, 8 millimeter diameter balloon to get into the branch PA and then follow it up with a dry seal. Sorry? Sorry, what did you say? Marisha? The valve. Okay, Bharat?
No, if the sheath is, although it is braided, if it is a little soft before using a balloon, I would give a trial with a loop in the right atrium and see whether we could negotiate the sheath. But if it is very stiff sheath, then then making a loop may be difficult.
It's a very stiff sheath, yeah.
Then in that case, probably balloon is a better idea. What wire was that? Is it Lindequist? No, it doesn't look. Oh.
So what wire is it?
Super.
Safari.
Okay. Okay.
Mm-hmm. I think I would consider using a balloon, 8 mm diameter balloon, 8 centimeter long. That's, yeah, you really need a longer balloon because you've got to get all the way in.
The problem here, Shaq, is of a wire bias. To
Yeah.
get rid of that wire bias, even with a balloon, is going to be a little tricky.
Yeah, yeah. What is it? Which sheath is this, just out of interest? Oh, Centrant.
Yeah.
Okay,
Yeah.
all right. Yeah.
I think the
GT.
Safari wire for Darby is not strong enough. The Safari ES extra support were quite kind of near to Lunderquist. So I think the option would be a backup Meyer wire if you don't have a Lunderquist. Yeah, this because we have a difficulty in getting Lunderquist nowadays. Yep.
Yeah. Any other suggestions? GT?
I think probably it is okay to park the sheet there. You can actually cross with just use the delivery system to go up. I think it's still doable. Yeah.
Okay. Okay, Ahmed?
Yeah, just to learn, yeah. So we are going to use, yeah, they are going to
Oh, Ahmed, hold on. Yeah, go on, MC. What were you saying? Oh, Ahmed, you carry on.
Just question. Yeah, it is a self-expandable valve, yeah, so it is covered.
Sorry,
So
Ahmed, too
do we
many
need-
people talking.
do we
Say
need-
again?
Yeah. Is it necessary to go to beyond the landing zone? Because it is already self-expandable valve. If we put at this position, we can go through with the support of the sheet
Yeah.
beyond the landing zone with self-expandable valve.
Yeah. Yeah.
This is necessary. Yeah.
So,
Yeah, the question for you, Shaq.
Yeah.
Is it necessary to go?
MC, so this is one of the reasons why I use a very long balloon, 8 centimeter long, because you can get it round into the RPA and then track the sheath over it. Okay.
Can I?
Yeah,
So
go ahead.
I think if you don't have a very long peripheral balloon, then the other thing you can use is just a large short balloon and put that in the
Yeah.
RPA, blow it up, lock it in place, and then pull the sheath round. But I think the other thing is, I think you pointed out already, Marasham, is that the sheath's got a really nasty looking kink in it in the right atrium, so you might have to change it out anyway.
Yeah. So MC. Yeah, we're quite a bit behind. We've got a couple of lectures, 3 lectures to get through. So can we come back to you, and if you record everything and tell us? Yeah, all right. All right, thank you. So let's cut away and go back to the lectures, if we could. Yeah. So if you could disconnect, and then we'll get the debate back on track. So it's my pleasure to welcome an old friend, Zahid Amin, who's going to tell you to stop doing balloon sizing of ASDs. Zahid?
Thank you.
If we could disconnect the transmission. Yeah, thank you.
Okay. Well, thank you very much. And please don't forget Dr. Dalby's beautiful talk about the balloon sizing. If you already have, I'm sorry about that. In America, we always cheer for people who are losers. So let's have a hand of applause for Dr. Dalby. Okay, so balloon sizing, if you use BS, so balloon sizing literally in this scenario is a BS, okay? So my suggestion to you is try to forget the talk and maybe the speaker, which may be extremely difficult. He's like a nightmare. A nightmare tends to recur unless you wake up. So if you are up, let's talk facts. Let's not make fun of each other, but let's talk fact. Why was the idea of balloon sizing introduced? And then why was balloon sizing needed earlier during ASD closure? It's not him. He is just ignorant, and ignorance is bliss. So it was important to balloon size about 20 plus years ago when we had non-self-centering devices. Remember, the discs had to be twice the diameter of atrial septal defect, and there was not much wiggle room, and majority of the devices made at that time were square, were never round. So you had higher risk of higher risk of device embolization, device tilting. Okay, so then balloon sizing was extremely important. So in self-centering devices, the waist determines the size of the defect, not the discs, right? I mean, you all understand this concept. So anything that is larger than the waist is a margin of safety. So what the waist will do is, waist is going to sit like a peg inside the atrial septal defect. The 14 millimeter larger disc on the left and 10 millimeter larger disc on the right is a margin of safety. So there is a minimal chance of disc prolapse, there is a minimal or less likelihood of residual shunt, less likelihood of device edge prolapse, and very high likelihood to close very large ASD. That's the reason you can close a 40 millimeter ASD now, because you have a 40 millimeter waist, and then you have 14 or 16 millimeter larger disc on the left and the right side. Otherwise, you would need 80 millimeter disc. You cannot close this. So I say idea of balloon sizing or scourge of balloon sizing. It is funny. In 1999, I was in Pakistan for one of the Asia Pacific meetings, and I suggested that we should not balloon size. And one of the person who totally made a mockery out of me at that time is sitting at the podium. And you can guess who that was. He made fun of it, and now, do you see anybody balloon sizing ventricle septal defect? No.
Yes.
No. Oh, it was you. I wasn't going to name you, Jack. Anyway, so ASD closure started with a very old device, and then it became Starflex device. The drawbacks were it could not close large ASDs, the disc needed to be almost twice the diameter of the defect, there was a higher residual shunt rate, there was wire fracture, there was frame fracture, and device was taken off of the market. Then came Angel Wings, again square device. This was semi-self-centering device. If you see the circle was 10 millimeter, and then the discs were bigger than that. Unfortunately, one of the pointed edges actually protruded through the left atrium and caused pericardial effusion, and the device was taken off of the market. Comes in Dr. Amplaster device, Occlutech device, LifeTech device, Cocoon device, all these. These are all self-centering devices. Keep this in mind. STAD is sitting like in this area. So the waist is occluding, as I know I've said it before, the waist will occlude the defect. You really don't need to balloon size these patients. So several physicians, Dr. Ziad Hijazi, a very close friend of mine, and several other physicians in early 2000 have figured out that balloon sizing was absolutely worthless, except in few cases, and I'll tell you those, as Dr. Dalvi has pointed out. And it does increase cost. It absolutely increases your procedure time. It can make some cases that are closable, unclosable. And size of the defect, size of the patient is very important. If you have a 4-kilogram baby and you're closing the ASD for a premature baby, you will never be able to balloon size it because the sheath is 10 French sheath that you need to go through, and you're going to kill the femoral vein. So here I'll give you one example. This is a 4-kilogram baby, 11 millimeter hole, bike. So I'm going to show you. This is on the left in 94 degrees, a bikeable view. On the right is -1 or 0 degree. That's a 4-chamber view. You can see the coronary sinus rim in that region too. And if I had balloon sized this was a 15 millimeter hole, and there is no way on earth I can put a 15 millimeter device in this patient. So we measured this device as 11 millimeter and put an 11 millimeter device here. So here you see we are putting the device in, deployed, This is another teenager. This case I did last month, actually. If I had balloon sized this, I would have now been able to use a device that is available in the United States of America. Did not balloon size this case, no aortic rim, absolutely bicaval views, sort of short SV serum. If I balloon size this patient, this defect is going to be 40 millimeter or larger. And we put a 36 millimeter device. There you go. One try. And this is a 2-year-old with multiple ASDs. You cannot balloon size this. You have to put a non-self-ring device in this patient. If you balloon size, you're going to just see one hole with a very, very tight waist on the balloon, and there are 35 other holes remaining. So what you're going to do is you're going to measure this. You can see how big and aneurysmal the septum is. You go through the center part of this and put one device, and it closes all of these holes. So finally, balloon sizing is BS without any question. It just gives you a sense of security. There is no change in embolization rate if you look at the data between patients that had device placed with or without balloon sizing. So I'm not sure how it would be effective. It increases the procedure time, it increases the floor time, it increases cost or risk of, and of course, risk of air embolism increases significantly with this, okay? It may be helpful if you have 2 large defects with this tiny septum separating it, and you cannot cross or you cannot tell if you cross the second hole. That's the only time it can help you. You put a balloon in there, you essentially occlude one hole, and then you can go with your catheter to the second hole to close it. Thank you very much, and see you next week at the CSI America.
Thank you very much, Zaid. All right, a couple of questions from either the panel or the audience for both of them. Bharat, if you come up to the stage as well. Dietmar? Hang on.
I have to vote for Bharat, I'm sorry to say, but without sizing balloon, I couldn't close the ASDs in 90% because without anesthesia, without TE, you can do it in 10 minutes. So the question is, balloon sizing is very useful if you want cost reducing, time reducing in 90% of the patient, not in 100%.
Bharat, go ahead.
So, Dietmar, what you're trying to say is that in 90% you don't need balloon or you need balloon?
I need in 100% the balloon, but in 10% I need a TE, anesthesia or whatever. In 90% I do it without anesthesia, without TE, because you can see the ASD before, make a sizing, place the device, and finish.
Yeah. My balloon size or not to balloon size, very briefly.
No, I would agree with Bharat. Balloon size in some cases, yes, because what about floppy septum? I mean, if you have a I just had a case, looked like 6 millimeters. We put in a 10 millimeter device, ended up prolapsing, and then we ended up with a 24. I mean, when we put in a balloon. So sometimes you can't really tell. So if I have a very floppy septum, I would balloon size. Yeah.
Teji, very quickly, balloon size or not to balloon size. Is Zaid talking rubbish or is Bharat sensible?
Yeah, I agree for the heat that I don't balloon sizing anymore.
You don't?
Always, I don't do.
Right.
Because the balloon sizing is incorrect. 3DT, much more punctually. And especially large ASD, is that balloon sizing no.
So Teji, my question to you is, on a TEE, antero-posterior diameter is 37, supero-inferior is 18. What size of device will you use?
Only 38, Amplatza.
So irrespective, without converting an oval into a circle, how do you know that 38 is appropriate diameter?
Let's wrap this up now. So show of hands from the audience now. Those who support Bharat about carrying on balloon sizing. Show of hands. Okay. Those who would support Zaid, who says that is all rubbish. Okay, just a little more on Zaid's side. Yeah. So, I mean, the bottom line, well done, both of you, but the bottom line is that there are some defects, like multiple ones, where balloon sizing, sizing is the wrong word, helps, if you have a balloon inflated, you cross the other defect more easily, or you use balloon-assisted method. So there are some roles for balloons, use of balloons in ASTs. Thank you very much. Well, now we'll move on to a big hand for both of them, really. We managed to do that without a fight on the stage. So we'll move on to aortic erosion in ASD closure, scare or skip. And Teji is going to scare you about erosions.
Good morning, everybody. I'm very happy to come back again. Actually, this topics, Zahid is probably one of the good person to this kind of talk. May I have my slide, please? Yes. Aortic erosion. I personally think about that it's becoming less incidence coming down, but still I'm checking. So the very simple ASD, multiple evaluation of TE, transesophageal echocardiography, maximum diameter 21 millimeter, some part is 18. At this point, I did balloon sizing. Balloon sizing. You see, 24.6 millimeters. Oh, where is my pointer? Oh, left down, 24.6. So if you get this sizing diameter, which device do you use? At this time, I only have the Amplatzer, so I select 26 millimeter Amplatzer septogluta. I think its deployment is not so bad. 26 millimeter Amplatzer septum. And this is not Trebizio system, the Tocqueville system, so the still rigid cable. And procedure was done perfectly. Looks great. And patient is very happy. And we had post-closure echocardiography evaluation the day before, 2 days after, just before the patient going back home. In the morning, 9:45 a.m., she walked to the echo lab, start for the post-closure evaluation. Echocardiography, echo person said patient still something like a funny feeling of her chest. 30 minutes after, my echocardiographer called to me, something, effusion is increasing during 30 minutes. So I go to the echo lab. I just said to the echo person, keep recording, keep recording. I ran into the surgical unit. Patient may have an erosion. 30 minutes after this, 10:40.
What time was this, Teji?
That's the only 1 hour duration. 2 days after the device deployment. So, no way, send the surgery. Erosion. Light atrial disc was perforated for the atrial wall into the aorta. So at this point, after this experience, I recognize for some of the malalignment of the septum may increase the risk of the erosion, especially for the right atrial disc. Shifting after the deployment of the device, the right atrial disc push into the aorta. Of course, you know that this phenomenon, you always know about the mechanism of the cardiac erosion after ASD closure. That's the compression between the device edge and high pressure tube chamber of especially for the aorta. And also you already know about the risk factor, what is a risk factor for the erosion. One is a limb deficiency, especially for the lateral aortic limb or aortic or superior aortic limb. That is a risk factor. And oversizing the device over the 5 millimeter or something is risk factor of the erosion. And also in my case, septal malalignment is a risk of the erosion. In Japan, we recorded for all of the erosion, whole of the country, punctually. 21 cases, 0.1% with Amplatzer septal occluder, similar 0.1% occluded device. In Japan, most of the operators seriously perform for the balloon sizing, except me. But even in such kind of manipulation, erosion incidence is quite similar for the other countries. Fortunately, we had no deaths due to this procedure. All of the complication was helped by the cardiac surgeons. These are all the list for our cardiac erosion. Green lines show the Amplatzer, yellow lines show the occlusive. Some of they talked about some risk factors, something like that, but such risk factor not completely covered for all of this series. Most important message for me, even in the heat, no one has predicted the onset of the erosion. Thank you very much.
Teiji, thank you very much indeed. We'll get some questions in a minute, but first of all, Mario next about skipping. Jay, can you? We'll have questions after.
To Teiji. Question to Teiji.
Yeah, but we'll have the questions after Mario's talk. Yeah.
All right.
So Mario, skip.
Yeah, thank you very much, Chuck. And thank you to Teen for inviting me to this exciting meeting and to talk about the erosion with some kind of debate with Teiji. Well, I would say I'm not going to really do a debate, but share with you some thoughts, some consideration about this problem. That is still a problem. Obviously, before starting, I want to give the credit to this man, Zaid, that did a huge effort, huge amount of efforts in classifying and clarifying, study this topic, and give suggestion to try to reduce this really severe complication. So thank you, Zaid, for having done this. Well, it has been said already that we know from previous studies that there are some risk factors related first to the morphology of the defect, the deficient or absent aortic rim, the atrial septal malalignment, or the dynamic ASD, or the posterior inconsistency, and these risk factors may be present simultaneously in the same patient. And there are also device-related risks, or the technique of the device itself. For example, device oversizing, or device tenting the transverse sinus, or I would say the device type itself. Okay, that's many papers reported in the literature. As you see here, again, the aortic ring deficiency was the universal among erosion cases. That's a strict point. That's another paper where the rate of the erosion with Amplatzer device was 0.3%. And, well, again, it has been clarified that there are many risk factors, but the conclusion was that the risk factors for device erosion were not crystal clear. So we still have some considerations, but not a full solution. Also because all these considerations were actually retrospective. So there is not a real prospective large-scale studies that can be probably clarified this, but it's impossible to achieve. That's another paper published in Circulation in 2016, and again, the oversizing device with deficient or absent aortic or superior rim were the most important risk factors identified in this retrospective study, where compare the erosion cases and the control cases. Again, aortic rim deficiency is constantly considered a risk factor for erosion. But if you consider the reality, the deficient aortic rim is present at least in 70% of the cases. So, should we consider contraindication for the vein closure? If yes, we will send to surgery more than 70% of consecutive cases. So this is not the case. Probably we would agree with that. And again, device oversizing is described as significant risk for erosion. But you have to consider that if you want to close an ASD with efficient aortic rim, you have to some extent oversize the device to counterbalance the risk of device instability or embolization. And again, the concept of oversized device is not crystal clear. Well, how to assess the maximum ASD size? Just on echo findings, 2D echo or 3D echo, or by balloon sizing, by stretch versus stop flow size? So there are still many question marks how to assess what is going to be the maximum size of the defect and consequently to choose the right side device. Another consideration published in the literature, erosion may also occur with non-oversized device. In this drawing, you see that is remarkable percentage of cases where erosion occur where the device was not oversized. So this is not a crystal clear problem. Another consideration, interesting, published in this paper, only actually in 78 cases, describing the modification of the device along the time, along the months following implantation, because of the nitinol that is changing the shape. And well, as the device becomes thinner, loses flexibility, and often changes for a flare to close shape on the aortic side over time, and the edges can start to compress the atrial and the aortic walls. However, that's important, erosion was not recognized in any of these cases. So this is an interesting observation, but is not a solution. And another very important point, erosions may occur early and late. Luckily enough, the vast majority will occur within 24 to 48 hours after implantation. However, there are cases described in the literature shown in these papers, months or even years after implantation. And this is, in my opinion, the most worrisome concept of erosions because, well, in brackets, we don't care a lot, or we care, of course, but we are prepared that if we keep the patient in observation at least 1 or 2 days, if the erosion occurs, we are ready to take care of it. But if erosions occur years later, completely unexpected, this is going to be a big problem. Well, another consideration, again, from Zaid observations, is the device itself a risk factor? While in this paper, he described that the device was oversized only in 3 patients, and the 26 millimeter device was the most common device that resulted in erosion. Well, just coming back to a paper that we published 20 years ago, actually, you see when you studied our experience in closing ASD from 2000 to 2004, consecutive cases, more than 1,000 patients, where in 824 patients, device was implanted. And in those cases, in those more than 800 cases, we experienced 2 erosions. In both cases, the erosion occurred early, few hours after device implantation. And interestingly enough, in these 2 cases, the 26 millimeter device was implanted. And from that point, Amplatzer 26 millimeters device was banned from my cath lab. I don't have any 26 Amplatzer in our cath lab so far. Okay, another point, another consideration, how to reduce the risk of erosion. We may consider alternative devices that are available. Some of those are listed here. You all know that. Some of those are, can be used everywhere. Some are not accepted in many countries, etc. So that's an important observation that using so-called softer devices can reduce the risk of erosion. Well, that's a paper reported in 2014 by using a need-to-occlude device. Well, the conclusion was only done actually in 73 patients. No complications during short-term follow-up with need-to-occlude device. Well, 2 years later, a fatal erosion of an heteroseptal liquid device by using this device. So you see how it's impossible to be sure to say that the complication is 0 with any device. That's another paper published about the use of Gore-septal occluder, and no erosions are reported so far. I cannot progress my slides. Is there any problem with that? Can you do that for me? Well, another devices that has been described in the literature, the Occlutech. In this paper, very nice results were reported with no serious complications. Well, this mouse is not working any longer. Sorry for that. This is kind of a thrill to get on with the slides.
Mario's mouse?
Yeah. Or you can have another mouse, or you go on with the slides. Well, go back, please. Sorry.
Back one slide.
Okay. Okay, so very good result with Occlutech device, but a couple of years later, cardiac erosions after device closure with Occlutech device was described as well. So even with Occlutech device, erosion can occur, apparently with the incidence significantly lower as compared to Amplatzer device. Next slide. So erosion with other devices like Cocoon, Lepo, Seraflex, etc. are not reported. So we don't know. There's a big question mark about that. Most probably some anecdotal erosions maybe are not reported. So you cannot say what's going on with other devices. Next. So erosions, next. is rare, but potentially lethal complication. Next slide. Most commonly, they occur within 24 to 48 hours, but very late erosion has been reported. Next, please. The careful evaluation of ASD morphology, proper technique of implantation, and device selection is important. And the next slide. In spite of all precautions, unexpected erosions may occur. Next. And now I have some case example for our experience. That would be nice if I have a mouse working.
But Mario, we're running out of time. So
yeah, I like to speed up if the mouse is working.
Because they're waiting in Malaysia as well.
Well, okay, anyway, I don't need a new mouse. You carry on. That's a case in 2017, a 5 years old with a rather small defect, as you see here, around 1 centimeter. Probably don't need to size this defect, but next, we did size, and the waist on the balloon was 11.8 in the central portion. So what kind of unplastic device would you use in this case?
Well, 10,
well,
but
remember,
let's speed up. 10.
10. Next slide. Yes, we use 10 unplastic device, and that's the appearance on fluoroscopy and immediately afterwards. Next. Well, that's a transesophageal echo seen in different views. You see the device is certainly not oversized. There is no residual shunt, sinus rhythm. Well, very nice result, I would say. Next. Few hours later, cardiac tamponade and urgent surgery. Erosion of aorta, right atrium, and left atrial wall. Would you have predicted erosion a few hours later in this case? I would say no, actually. Next. Well, next.
Press next.
Well, let's have a look at the appearance of the floor recording when we release the device. What's wrong? Well, I would say, in retrospect, I would say that when the device is released, it jumps forward, maybe towards the sinuses. Then maybe the cause of the erosion in that case. Next. Another case in the same year, 6 years, 23 kilo, large ASD with absent aortic rim. We did balloon sizing, as you see here. With balloon sizing, the size was 21, 22 millimeters. Next. So what to do in this case? Teji, what to do? Forget about sizing. What would you have done in this case? At 24? Okay. We used 22 millimeters, actually, less than 24. So we were happy about that. The device, in spite of that, was straddling the aortic root, and this is the appearance on fluoroscopy. Next. What about the follow-up on this patient? Next. Up to 6 years follow-up, the patient is okay. So that's a very good result, in spite of, let's say, oversized device. Next. Please, next, or give, yeah. That's another case, more recent, with septal malalignment. What to do in this case? It has been described that with septal malalignment, an oversized device can be advised. Well, in this case, Teji, would you have done a balloon sizing or not?
Mario, I'll have to speed you up.
Okay, sorry for that. We did not balloon sizing, but next slide, we've been using a Gore cardioform. This is the partial deployment of the device. Next. The full deployment of the device. Next. you see the device playing the aortic root, but with this device, the risk of damaging is much less. Next. Well, that's a double ASD, as you've seen in 2D, 3D picture. Next slide. In this case, I would say it's mandatory to use balloon sizing. Next slide. So in this case, a 6 millimeter plus a 14 millimeter unpluster devices were used with overlapping appearance, as shown before. And the appearance is very, very nice. Next. Well, the 2D, 3D echo post device. Are you happy with the appearance of these two devices? I was really happy, actually. Next. Well, the echo discharge was excellent, no residual shunt. 1 month, 6 months, 12 months follow-up. Everything was okay, no problem. Next. 2 months later, the patient experienced fainting, urgent hospital admission, and echo large pericardial effusion, and the patient went to surgery. Next. And these are the two explanted devices. There's another case where I would say the erosion was really deeply unexpected. Next slide. That's another case of double ASD. Next.
Mario,
in this case, sizing balloon. Next. Sorry, I just finished.
We're going to have to skip next coffee break at this
Okay, okay. Implanted two Seraflex devices, even larger in these two cases. Next again, we're going to go quick. Next slide. Next slide. What about 3 years follow-up in this case? Very similar, even by using two larger devices. Next. Well, excellent conditions, no residual shunt. Okay, so next, I think is finished. Forget about this. Go on to the end, 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 go on to the end.
Can you erode his slides?
Yes, just a few slides just to show you, okay. Well, the 3 slides were reporting our own experience. If you want to see that or not, never mind. Accurate evaluation of ASD morphology is important. The balance between probability of success or risk of complication is important. And just to finish up, if you are not confident of implanting a device, don't be ashamed of sending some patient to surgery. So thank you very much for our.
Thank you, Mario. That was very, very comprehensive. We might have to skip the coffee break, but we'll come back just for a couple of questions. But the team in Malaysia are ready, so let's go there because they've been waiting. So MC or Marisha, we'll back live with you in a minute. Yeah.
Hi, welcome back. Actually, well, when we give talks, we actually deploying the valve. I just want to run you through the pictures, right? So I needed Garrett advice, change the sensor sheet, and on the bottom sensor sheet, you see the same thing happens. He actually freezes. So we actually get the sensor sheet as deep as possible, and then pass the delivery system all the way to the RTA. It takes a little bit of pulling and pushing, but we managed to get it on into the RTA finally. Right, next one, please. Right, keeping the momentum, allowing the sheet to go in slowly. Right, and then pass it deep into the RTA. Next slide, please. Right, then we straighten the delivery sheet and start unsheathing the valve.
So in this case, the centrant sheath was not really very helpful.
Not really helpful, yeah. Mechanically, it's not really helpful. It's more for cosmetic reasons, I'm afraid. So as we are deploying the valve, we did some check pictures, check angiogenesis to make sure that we know where we are. And then we just gently pull it back. We want to implant it higher in the branch coronary artery, so we don't want to pull back too much. So open a little bit more, allow the flap open. But as you see, as you open the valve, it doesn't flare that well because most of the valve is still in RTA. Yeah, so we
Yeah. Okay. MC, thank you. That was a very challenging case, obviously, for various reasons. Any quick comments, brief comments, or questions? I think everybody's really impressed, so I think that's a great job. Well done. All right, MC Marisham, we're way behind the program, so thank you very much to the whole team. Congratulations. Okay, we'll move on. Right, very quickly, any comments on the erosion scare or skip issue? Did you want to make? Yeah.
Okay. Both speakers had a demonstration from Japan reports about erosion, because our country analyzed every erosions occurred in our country. So, but in recent 4 years, we have no erosions. I think we presume that two reasons. One is we have annual 2 committee meeting for safety management after ASD and PD closure based on the J6 society. We analyze the reasons and the cases of the erosion cases, and it reduces maybe the occurrence of the erosion. And one more reason is introducing the GORA devices 3 years ago. It occurs no erosions, but in one case, the bigger selection of the GORA device resulted in the protrusion of the fractured wire outside the membrane, and it injured the mitral valve and had surgery. No erosion, but it is an occurrence. So,
well, it's still erosion, but different.
Yes. This is my comment.
Okay. All right. I think, yeah, John. Oh, Del.
Yeah. Good morning. 2 questions. One is, since we know that aortic erosion can happen, or erosion can happen even years, so is it mandatory now that if you have a patient who has an aortic deficiency and you ended up putting a device, you monitor them longer? Not being comfortable of saying. And second is, it's always been an issue of, do you flare? How much do you flare the device? The edges, sometimes we're worried about it penting the aorta, but we also do not want to oversize it because now the rubbing of the flared edges.
Yeah.
So
let me pick on Mario. Mario answered Jonas's questions about follow-up, discharge, or keep following them up, and aortic distortion, and then we'll have a coffee break.
Well, based upon the consideration that some late erosion did occur, it is, I would say, advisable to follow the patient for a long time. However, this is not be easy, because if the patient is doing pretty well after 2 years, you advise to make a follow-up after 2 or 3 years, and he come over. But afterwards, because he's doing pretty well, they don't follow up. So that's a problem. That's the reason why the very late erosion did occur completely unexpectedly. But however, if you follow up the patient, let's say 5 years afterwards, you cannot exclude that 2 months later it will erode. So a question mark still there, sorry.
All right, Mario, thank you. So we're going to have a delayed coffee break for 15 minutes, so please come back in exactly 15 minutes on the dot. But thank you very much to all the speakers and live case presenters. Thank you.
Okay, ladies and gentlemen, I think we'll try and get started. I think, oh. No? You want me to give one? You want me to give one? I've got something I can do if you want. You want to take over and then I'll go into, okay. Let's start with the second speaker.
Okay. No, I don't have one. They didn't tell me, so I didn't know. No, Gareth will. He has some.
ايوه، ما انا اللي مش بقول لك عليكي عندك سيشن انت مودريتور وانا بانل.
You have a
لا بس تديش فرصه بقى، ما تديش فرصه بقى.
Hello. I can hear you. Can you hear me now? Hello. Hello, can you hear me? Hello, we can start. Hello. I can hear you. Hello. Hello. Yeah, I can hear you. Yes, I can hear you. Yeah, I can hear you, but I don't know how. Can you hear me now? Can you hear me now? No? Can you hear me now? I can hear you. Yeah, we can see you and we can hear you.
Good morning, I'm Dr. Janet. I'm the first year clinical fellow, Berkeley fellow at Sydney. I'm going to present the first case, the second case from Sydney. This case is a 12-year-old male. His body weight is 32 kilograms. He was diagnosed with ASD since 5 years ago. So now he developed dyspnea of exertion with an ASD functional class 2. His underlying disease was beta thalassemia E-trait. He never received any blood transfusion. His current medication is furosemide. From the chest X-ray shows the proper line balloon.
We can't hear you. There's a problem in transmission.
Can somebody else speak on behalf of the presenter? Because we can't hear you guys. So the questions. Before that, I can't hear you. So I think let's. So first, let's discuss a few issues here. Is this, according to you, a truly perimembranous VSD or it's an upper muscular VSD? Because you see a chunk of muscle practically on all sides of the defect.
this VSD somehow is, extending to the outlet. So according to the definition of the perimeter, I believe that we should have the continuation between tricuspid valve and the aortic valve. So if it is still perimeter, definitely we should not have the rim at all underneath the aortic valve. So that is what the definition of the perimeter is. So this particular case actually is not, because somehow it's close to the aortic valve, but it's a bit away with the muscle access and it's a point out. So again, in terms of definition, maybe you can discuss that for hours without the final solution. But in terms of indication, I think it's quite clear. We need to close it.
Yeah, it's interesting because I think you're right. You have an indication working, but it probably has an impact on what you're worried about and what device choices you have if you define it as muscular or perimembranous. And judging on the echo, if you look at your short axis view where you can see the tricuspid valve, the defect was nowhere near it. And for me, that clearly says that it's not a perimembranous defect; it's a muscular defect that's, in the outlet area. And it just makes you less worried about the things that might happen. So I suppose from a conduction point of view and from the point of view of interfering with the valves, you've probably got more freedom here.
The other question Varakana had was, is it your routine practice in a 12-year-old with a defect located away from the aortic valve, probably from the tricuspid valve, to put a transesophageal echo? Or you could do this case only on transthoracic?
Well, this is a very good question too, because it depends on institution. So for us, definitely, this is the live case, so we actually we try to show you echo navigation as well. So if you have time, we can discuss after. But yeah, so as you said, in some particular center like Teddy or your center, maybe this is not really need for the full-time monitoring of the transesophageal echo. You can go over transthoracic echo occasionally, but well, just for the purpose of navigation, so that's why you do it. And also as a routine for us for the transesophageal echo assessment for VSD, so we try to do because we do GA here, and the team here is quite comfortable to have the full-time monitoring of the transesophageal echo during the procedure.
So let me take this question to the panelists as to how many of you would do this case under general anesthesia versus local anesthesia.
In our practice, we'll do it under general anesthesia, and we will use the TE as well.
Yeah, I usually prefer under deep sedation, under transthoracic echo guidance. In my opinion, transthoracic echocardiography much more give information than the TEE. In TEE, we can use only the four-chamber view for muscular VSDs or long axis view for perimembranous VSDs. But in transthoracic echocardiography, you can see many windows. Another issue, the classification of these VSDs. We can see the VSD on parasternal short axis view, so it means that perimembranous, it is not muscular. Even though it looks like muscular rims around it, perimembranous trabecular extension. You know the perimembranous VSDs can be extended to inlet, can be expanded to outlet, and can be expanded to trabecular extension. In my opinion, I can define this one, perimembranous trabecular extension. I am agree with the Varakana and the team.
Thanks, Samar.
Yes, we typically do general anesthesia, however, transthoracic echo guidance.
Okay, thank you. Okay.
Yeah, I would use GA and transesophageal, but that's because we've very limited experience with VSD closure. We only do a couple a year, and therefore I would want everything possible from an imaging point of view.
Okay, guys, we need to hurry up a little bit. Tell me what you have done thereafter.
Okay, because any device can put inside the
So let me ask the audience, Kevin, in a case like this, what would be the choice of the device in terms of size and type, and also whether you would like to close retrograde versus antigrade?
Yeah, you can do it many different ways. I mean, it's a big child, and you're heading up into the pulmonary artery. So I'd probably just put a Rosen wire in there up in the LPA and bring in something like a Terumo type long sheath, what we call a destination sheath, and then use an MFO 86 or something like that for it. I think that would be an easy way of doing it.
So what size of MFO would you use?
Probably 8.6 rather than 10.8.
Okay. Nageshwar.
Often this is membranomuscular VST or probably anterior upper muscular VST. It's a good idea to see subxified on-pass view or subxified another view. Often we underestimate this size. The size they measured is around 6.4 or 5. So that is very important because in muscular VST, if you undersize it, device embolization will not be there, but there will be some residual shunt. So therefore, that is the concern. Second is this case can be done under conscious sedation. I don't think transesophageal echocardiogram is going to contribute significantly because we are nowhere close to the either aortic valve or to the tricuspid valve, unless they want to demonstrate TE navigation. Antigrade method crossing also is very good. You go to the pulmonary artery, drop the catheter, pressure guided. You can cross it easily and then deploy the device. Otherwise, retrograde, unless they want to demonstrate the AV loop, a retrograde deployment using a 7 guide catheter, it takes 9-7 device easily. Here, I think my choice is 8.6 with this imageology. If you do subxified view and demonstrate if it is a 7 millimeter, then 9.7 is appropriate. MFO 1 because fabric is there in 9.7, 8.6, little bit residual shunt for few hours will be there.
So your choice is antigrade with 8.6 or 9.7?
Now almost more than 90% we go antigrade, go to pulmonary artery, drop the catheter, pressure guided, enter, and you can put the any sheath and deploy the device.
Please.
Yes. So how about the ADO1?
Right.
If you do the AV loop.
Ahmad, what will be your choice of the device? If you use ADO1, what size?
I would probably use an 8.6 or a 10.8.
Okay.
If there is a good rim around the VSD, I always choose double disc device because of the contractile of the VSD, high probability. You should oversize. So it is little bit, closer to the AV to conduction system. So you should oversize if you use ADO1. So I would have choose MFO or muscular VSD occluder because of the length between the LV and RV little bit longer than the usual perimembranous VSD.
That is one of the concerns sometimes with ADO1, that it may not really hold on to the other side of the interventricular septum. Gareth, your choice of the device.
Yeah, I think if I was coming from the aorta, I would probably try and use an MFO. And if I was going to try and come from the right side, if, as was described, I could just drop out of the pulmonary artery, go across, and then put a wire down the aorta, I might just try and put a destination sheath up and put an ADO1. And I think I'd try an 8.6 ADO1. But I think here, because this is not a perimembranous defect, a muscular VSD device would be fine as well. Maybe a 6 millimeter muscular VSD device might work.
So guys, now you have heard all the views from the panelists as well as from the audience. Now you tell us what is your plan. Just one more comment from the panelists. Just 1 minute. 1 minute.
Super, this is Amal. Can you tell me the measurements on Anju? What were the measurements on Anju? Did you measure it on Anju?
Yes, for the NGO, LV is about 6 millimeter and RV is about 5 millimeter, and the length is about 8.6.
Right.
Thank you. Go ahead.
Okay, so one. Okay, so the liver is around 14 millimeters, and also the LV side is 9 millimeter. RV side, here is around 7. Okay. Okay. And they can they have two half, and we can deploy from RV or LV. Either side we happy to do. Okay. So we choose 9. So we already do the did the AV loop. So we will connect the half
So,
and the LV side.
so you have decided to deploy it retrogradely, right?
Yes, at the first we want to go for the retrofitability, but because the delivery sheet is quite steep, yeah, I think if we want to go retrofitability for the 6 phase, maybe better to use another catheter like the guide catheter, yeah. But it's very steep and it's very close to the PA, so we change our mind to go from the anti-gravity, yeah.
All right, maybe a question to Nageswar. I'm not sure if I understand correctly. So from the ISU, they said 9/7 takes up 6 frames delivery sheet. But normally, if we go for the guiding catheter, we should upsize one more frame. So likely that if you're going to use the guiding catheter, we probably need to go for 7 frame guiding. So I'm not sure whether can we go for anything smaller than that, Nageswar, or any suggestion? Because this is a vertical approach, so we have to go from the femoral artery.
Femoral artery and 9/7 device easily go through only 7 guide catheter. So if the child takes a 7 French sheath, then 7 guide catheter, otherwise anti-grade approach and go either with a 7 guide or 6 French delivery system.
Yeah, so the problem here, because as you can see from the angio, that the VSD pointing upward. So when super and T try to push the delivery catheter onto the VSD, somehow it is popping out, not getting through the VSD to the pulmonary artery. So that's why
Okay.
they tried that
Okay.
3 times, and then they decided to just go for antigrade. So that's why after that, also, for the second time it's not difficult to cross, but the third time it takes a longer time. So they changed to the tactical catheter too. As you can see here, with the tactical it's much easier because it's pointing upward. So this is what I've learned from Tizio, that when you point upward like that, better to use the tactical. Yeah. So after that, the next heavy loop.
Go ahead.
And they change to the light catheter to deliver the device. And also you can see as a routine, super hits to angio, just to confirm whether the size of the VSD defect is getting smaller or bigger or not after the change is taken, which is likely to be smaller in this particular case because it's completely covered by the muscular part of the recurve septum.
So at this point, I want to amplify a little bit because that's the big thing. Delivery kits can
So
go close to VSD. So will you change your mind to change the device to smaller side, or you still do agree with the 9/7, or is it something like that?
What can we need to speed up in the interest of time?
Yeah, sure. Yeah, that's fine. Let me answer your question then. I prefer to go for 9/7 as you said too far. Why? Because I think it's muscular part, so I'm not worried on the heart block or whatsoever, and less likely to get trouble with the tricuspid and every valve. So why not just slightly oversizing to make sure it's sealed and unstable? So I probably would go for 9/7 as you prefer.
Yes, I do agree with your point. deliver the device to the tip of the sheet, and she's gonna pull back everything back to the ascending aorta, and you open, yeah, maybe you on this, yeah, okay, yeah, okay. Can you show the, yeah, CE, okay, okay. Now, open one of these first.
Super, please, don't you do on the frontal angulation for better visualization of this VSD? What's the angulation on the frontal?
By 20. Yeah, could, 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 could you magnify the cine angio image? Yeah. Yeah. Can we see the fluoro bigger, please? It is very small.
Now we ready for deploy all of the, yeah, okay. So now from the conceit is already open all of the device. Yeah. So how about the TE? So from the TE, both of the this already open on the left ventral side and right ventral side, and there's no node of the ventral septum. Can you show us in the four-chamber view? Yeah. Now it's on the four-chamber view.
Yeah, looks pretty good.
Unfortunately, this is a 30 kilo boy. Somehow, when we try to register the probe to the body of the patient, it's not aligned properly to the chamber. So we did try that for 3 times. I'm not sure that you guys have this problem or not, but well, I talked to the company's representative, so they said that this software actually made for adults. Well, 31 kilo is to me somehow is likely to be adult. But yeah, we tried that 3 times, didn't work. That's why we could not show you the echo navigation today. If we can do that, so that would be somehow have a good educational thing too. Just in case that you have a problem,
Yeah.
just like we have here too.
Can we look at the angiogram? Yeah. Looks good. Okay. Okay. No question.
but the thing is, not from, it's not leakage, it's literally in the disc.
May I have a question? Super.
Ditma.
Yes.
Fortunately, in the interest of time,
okay,
we will have no questions.
I have to ask Super, great job again, as usual. What is the real benefit to have a TE? We have discussed it before, but I don't know why. Even you need an anesthesia for the TE, but you can do it without anesthesia in sedation, and you have, what is your benefit? Convince me, please. Why?
Supa, can we do the final angiogram? Taiwan is waiting. Sorry for that. Sorry for hurrying you up.
Of course, of course.
Supa, we need to, Supa,
But you
Supa, we
can do
need
it with the
to
TTE.
go on to Taiwan. So we would just like to see the final angiogram.
Good.
I'm really sorry to cut short this discussion. Go ahead. Yeah. Thank you. Excellent job. Thank you. Okay, so we move on to Taiwan for the next live case. Yeah, go ahead. We can see you. Hi, good morning.
Can you see me? Can you hear me?
Yeah. Go ahead.
Welcome to our customer. Today we will show a case. We plan to do the LPA stain translation. First, I will ask my fellow to report the history. Can you please? Ladies and gentlemen, the entity will hail from National Hospital. And now I'm going to present a second live case illustration from our hospital. Okay, the second case is an 8-year-old girl experiencing hardly of alone, receiving PSA and photography with residual LPA stenosis and hypoplasia. A recent echocardiography showed LPA functional stenosis and hypoplasia with steady antegrade growth, and there is moderate pulmonary resuscitation and now residual pulmonary stenosis, and there are RVH or total notice. Cardiac CT shows severe original stenosis of LPA and LPA hypoplasia. Cardiac MRI reveals severe original stenosis of LPA with LPA hypoplasia, and there is also moderate mobility and mild pulmonary resuscitation.
ratio more than RNA line. EKG, your sinus treatment with one shot. So this time we will perform LPA balloon dilatation. Consider LPA stenosis and possible PCI in future. LPA with total stent implantation may be considered. Thank you for listening.
Thank you.
Before moving on, I would like to introduce our team, including my mentor, Professor Wang, and my right-hand side is Dr. Sun, Yong Sun, and also a colleague of a doctor, cardiologist, and also the anesthesiologist and the nursing team. Actually, we have already finished most of the procedure, including hemodynamics. The RV pressure, RV systolic pressure is around 30 millimeters of fluid. And the systolic LPA pressure around 15. And can I show the angels to all of you? Please show the LPA angel first. From the frontal tube, we use so-called four-chamber view that is LAO 30 and cranial 30 degrees. Both views show the significant stenosis at the LPA origin. And then we did a balloon dilatation by using a soft balloon that is high shot, 9 millimeter by 20 millimeter balloon. The current angel demonstrates balloon can be fully dilated.
So this dilatation was done with what intention? To get your sheath across? Okay.
And then you can see the balloon can be fully dilated. However, the follow-up can injected of contrast. The stenotic side is foiled.
So Gareth, is it your routine practice to dilate this stenosis prior to passing along sheath, or you're comfortable passing along sheath straight away?
No, we wouldn't normally do a balloon dilation. I think when we look at the pre-procedural imaging, we would probably know that we're going to stent this, and then the only reason, a bit like you alluded to, the reasons why I would blow a balloon up in this lesion would be, one, to try and help pull a sheath across if it was difficult, and secondly, if it was difficult to work out the anatomy, I might just gently inflate a compliant balloon just to see where the waist is, but I don't think I would have any intention to de-waist the balloon, because I think that may cause problems, and I don't think there's going to be any benefit from it.
Yes, Ahmad.
If it is not to cross the stenosis with a long sheet required for the stent implantation, of course, we should periodilate. But if it is possible, it is larger than the long sheet size. So I don't. No need.
Okay. Go ahead.
Okay. So for the patient, current age is 8 years old. The body weight is 26 kilograms. And also moderate degree of pulmonary regurgitation. Maybe in the future, you need the pulmonary valve implantation. So for such LPA stenosis, I plan to do stenting by using bioabsorbable stent.
So I think what size sheath is across?
Okay, now can we look at the measurements of your left pulmonary artery and the ostial measurements and the length till the first branch?
I have one question, please.
Yes, just 1 minute. 1 minute. Trongfi has a comment or a question.
Yes, yes. In this case, I don't know if the stenosis is short or long segment stenosis. It's not clear to me. And normally, I will put a pigtail with markers into the left pulmonary artery and do an angiogram, so I can very clearly see if it's a long segment or not. Because if you plan to put a stent in, you need to know very exactly the anatomy of the stenosis. So this is just a suggestion from me.
Yeah, so I understand. You put a marker pigtail. Would you also like to change the angulation so as to profile the stenosis better?
Right, right. To take the precise parameters of this stenosis.
But Trongfi, CT showing you lovely the kind of stenosis, its site, everything. So would you want some more information?
But on fluoro, not. I cannot see it.
Okay.
Interestingly, Barrett, they've got Vessel Navigator up in the top right corner, which should really allow them to pick the perfect angle, which I'm guessing is going to be a little bit more LAO. But I'm just interested whether the team looked at Vessel Navigator and used that to try and find the absolute optimal angle to fully elongate the left pulmonary artery, because that would have helped, I think, as well.
So many times, steeper LAOs can help you probably open up the left pulmonary artery origin a little better, maybe going even up to lateral. Ahmad, you had some comment?
Yes, yeah, let me make about the comment of the bioabsorbable stent or future pulmonary valve implantation. Existence of a stent in the LPA is not a contraindication for future PPVI. We have about 10% of patients, about 400 cases of pulmonary valve implantation, already branch pulmonary artery stent. You can flare the proximal part and you can put balloon, especially balloon, even pulsar valve we have used. So I must say about these cases, it's relatively firm and tight lesions. So we can prefer couch stent implantation because we should have at least 15 millimeter of left pulmonary artery branches for adults, even 18 millimeter for adult size branch pulmonary artery. So maybe I would have used couch stent implantation in this particular tight lesion. So we can use, because of the previous surgery, there are a lot of firm scar around the tissue. So we may need high pressure balloon usage in the future. So couch stent may be safer.
So currently they are planning to use a biodegradable stent, looks like. So probably it may not have so many issues when you come to putting in a valve at a later date.
Maybe it's here, but if you need much more expansion, if it is tight, it cannot be expanded with the ordinary balloon. If you need high pressure balloon, maybe safer to use couch stent.
Mario, what are your thoughts? If you did not have a biodegradable stent available, this is a future candidate for a pulmonary valve, how would you approach?
Well, I would put a non-biodegradable stent here. And I shouldn't be very worried about the possibility of putting a valve, a percutaneous valve in the future. I would be, cautious when implanting the stent, try to get it in the right spot. I mean, avoiding too much protrusion into the main PA, that's it.
But do you ever think of bringing it back into the main pulmonary artery to create a landing zone for a future pulmonary valve?
No, I mean, if you put a stent, well, this is a tight proximal stenosis at the origin of the LPA. If you put a stent there, resolving the stenosis, that's okay, probably for a long time, for years. If you need to have a larger access to the left PA, you can flare the proximal portion later on with no problem.
Okay.
Can I have a
Yes,
comment?
please.
What is, maybe they can tell us more about the biodegradable stents, because not everybody has experience with these stents.
So you heard the question and the comments. So what is your plan likely to be if this is a biodegradable stent and if you were not having an access to the biodegradable stent? Okay. So you can proceed. You tell us now what kind of stent is this, how soon or how late it will get absorbable, and what is going to be the length and the diameter of the stent that you're going to use. Is this a pre-mounted stent or you crimp it or what? So what is the diameter of the stent that you're going to deploy? It's a 12 millimeter. Does it foreshorten? What are its characteristics? Okay. So go ahead. Yeah, please. Yeah, I mean, it's covering the ostium, but quite a part of it is across into the main pulmonary artery. I think you'll have to place it a little eccentrically so that you can go a little more distally.
Yeah, you can use the left main bronchus as a good marker.
Well, I would suggest to go much more distal.
Yeah, because, Mario, the question about the stent protruding into the main pulmonary artery when it involves the ostium, I mean, how predictably can you keep it at the ostium? Because you are always worried that you might miss the stenosis without it allowing it to come into the main pulmonary artery.
Yeah, of course, you have to be careful, but I think you can get it there. You need just 3 millimeters of stent at the origin of the LFPA, I think.
Okay.
I find that
Yes.
a steep caudal view is a very, very good view to see the origin of the LPA. I always deploy my LPA stents with steep
The left
caudal view.
LAO caudal.
Caudal, LAO if you want, but especially caudal.
Caudal view. Okay. Yes.
Yeah, but for bioabsorbable stent, I do have a kind of substantial experience on this IBS stent. So I will place it more distally because if you're jutting out too much to the MPA, once it's bioabsorbed, maybe part of the portion can be embolized, one portion of the stent.
Yeah.
So put it more distal. I agree with you, Bharat.
Yep. Okay.
I think
Yes,
the only
Gareth.
thing, I think I agree with what everybody's saying about a different angle, but they've done the entire case with these angles. And the good thing is, if you look at the LAO cranial that they've got here, the origin is right on the edge of the left main bronchus. So I think here, I don't think I would change the angles at this point. I would stick with what they've got and use the left main bronchus and deploy the stent within the left main bronchus, and then they should be okay.
Okay. Go ahead. Maybe should go a little more distally. Yeah. No, I don't think you will miss the stenosis. Okay. Can we make the fluoro bigger? Now we don't need the.
What pressure did you inflate the balloon to?
5 atmospheres? What pressure did you inflate the balloon to? 5 atmospheres? Can we have the fluoro bigger?
Can I ask the audience how many would use bioabsorbable stents in this case? Raise your hand if you would use bioabsorbable stent in a 12-year-old with origin stenosis of the LPA. Nobody?
I think access to biodegradable stents is still not all that much. I think it's quite restricted to very few centers or maybe very few countries.
Will you redilate because there is a waste persistent just at the bifurcation, yeah?
Just regarding your question, Bart, it's tricky 'cause most of us don't have access to it, but you know you're going to be compromising something by using a current range of bioresorbable stents because they're not very well developed yet. And then in a 12-year-old, you would like to think that you could put an LD max stent or something there and just flare the proximal end and keep it out of the way for pulmonary valve deployment. And I'm just not, as you said, confident enough about what I've read about bioresorbable stent technologies. You know, you're putting a good stent in that's going to do a good job.
Right. Please, go ahead.
I had the opportunity to implant 3 IBS angels, not into pulmonary arteries, but into portal veins post-transplant. And my experience is that they have a nice support, they keep it for like a year, but then there's a lot of neointimal proliferation around them. So I had to stand 2 of those 3 cases again with covered stents. And I don't know if it is a good idea in such a kid of this size, because really you can go for other stent, for bare metal stent.
But in case of a biodegradable stent, Adam, how will the growth matter? I mean, it is expected to dissolve. So if the need be, and if there is neointimal proliferation, maybe you could probably go ahead and...
Yeah, but it was enormous. It was like definitely more than in standard bare metal stents. They induce a lot of, like almost cartilaginous tissue around them. So in 2 of 3 cases, 1 case is absolutely perfect. So maybe it is just depending on individual tendency.
Okay, thank you.
I have a question for operator, please, Yuku. Dr. Yuku, do you do lung perfusion scans before and after such procedures, or any of the audience do this practice still? Because we used to do it in the past and we stopped doing it, so I'm not sure if it's still practice. What do you think, Ali?
I think perfusion scan is a good idea for, especially for follow-ups. I think it serves as a good baseline observation, and then you can follow up just with a perfusion scan. At least in our setup, we do it. I know that many centers now go by MRI flows and stuff like that. But we are still doing perfusion scans, more so because we do them during follow-up. They are far less inexpensive and more easily available, more standardized than MRI flows, no matter what the MRI guys say.
It's pretty center dependent, isn't it? Because some places like our center don't have a good nuclear medicine department, so we can't rely on our perfusion imaging where we've got a fantastic MRI department, which means that our split flows we can be very confident about, but we wouldn't have the same level of confidence of a VQ scan that we would with an MRI. So I think it's quite center dependent, probably, which you go for.
Please, Mike.
But 61 and 39 is close to normal, because the right lung should be 60 and the left lung should be 40. That's what's described as normal. So, because the left lung's smaller, so that if you look at the normal data for perfusion imaging, 60-40 is the upper limit of normal difference between the left and right lung, unless the patient is extracardic.
There is a big difference in perfusion if you look at the angio between the right lung and the left lung.
Yeah.
So maybe it's more than 60,
it's
40.
difficult to believe those numbers looking at the angiograms and the way the distal perfusion of the lung is. Yeah.
That's why lung perfusion is more accurate than MRI in assessing the actual perfusion of the lungs.
One more comment. Go ahead, Mike.
Nice case, but just a few questions, because I don't have any experience with the biodegradable stents. So how long do they take to biodegrade? And then if you need to redilate again or put another stent because you have to account for growth. So are they forgiving in this direction?
So the question is whether you can post-dilate this stent.
Post-dilate it, and whether, how long does it take to disappear or to biodegrade? And then if you need to redilate again after I mean, what is the tissue like? Is it fibrotic, cartilaginous? Is it, I mean, it's easy to restent again?
So the question is that are you able to redilate the stent if restenosis were to occur before it got reabsorbed? And the second question is that how simple or difficult it is to redilate even following reabsorption if the stenosis were to occur. Does it change the tissue characteristics locally?
Can I answer? Yeah. Yeah, yeah. Perhaps you answer first. Oh. Yeah, sorry, I probably answered the question to you. It is a very difficult question to answer. This 12 millimeter can post dilate to up to 16 millimeter.
Okay.
Whereas the other smaller stents, you can only like 6 millimeter, you can increase up to 7 millimeter only. So it depends on the size of the stents. So in terms of the absorption rate, it is something very puzzling because the bioabsorbable stent for this angel, I find that if it's a smaller stent, it absorbs faster. And also in a different position in the body, they absorb differently. I put these stents in the LPA, RPA, SVC, aortic arch, and even RVOT. The stent behave very differently. I agree with Adam say that it creates a kind of inflammation leading to neointima proliferations. So most of the time, once it's absorbed, the tissue behave, there's a lot of neointima proliferation kind of thing, but the stent being absorbed, you can actually post-dilate it and put in additional stents. So for me, this is probably not the best case to showcase in a 12 millimeter. I would use other stent, but in a smaller child, you put in 4 millimeter, if you balloon in, resistant to balloon dilatation, you put in a 4 millimeter, you get an excellent result, immediate stent. Then you have to go in again, 6 millimeter, 8 millimeter, growing with the child without putting any mental load to the branch PA. So that's the thing.
Okay, but then when you put another stent when it absorbs completely, I mean, it's easy, it's more stiff. Is it more fibrotic or the tissues are?
You mean the tissue itself?
The tissue itself, yeah.
I'm not a surgeon. I don't touch the tissue, but
I know,
think
but I mean,
you can easily.
Okay, I think in the interest of time, we will stop this discussion here. Maybe we can discuss this later on over a cup of tea or coffee. So I think if you guys are done, would you like to show us any final angiogram with wire out, or you want to make any hemodynamic studies? Otherwise, we move on.
They always alert the IVAS to check the final status. So I also prepare the IVAS for this well. So right now from the fluoroscopy, you can appreciate the IVAS form already there, and then we will start the IVAS check. I would like to invite my adult cardiologist to make some comments for this IVAS. Please go ahead.
A little louder, please.
Show IVAS image to the audience. Start engine, start flow. Okay, so you can see IVAS. And I think the left side distal area, I think distal is not at the system of the stress in the distal, and this is and one optimal path. And I think you say A, that's okay. And a little bit, other extension in the lesion side, I think the area is okay. So maybe we can do post-dilation path.
So are you going to post-dilate based on IVUS?
Yes, I think maybe we can consider. Yes. So I personally, I would like to start here. The other because I'm not sure the sustain can be redirected or not at this moment. Because I already deployed the 5 ADM ratio, so I'm not sure. How about the moderator or panelist suggestion?
I don't think that we have any experience with IVUS in pulmonary arteries, but I think the rules of atherosclerotic coronary artery do not apply to such large pulmonary arteries with pulsatile flow and such large diameter stents. I'm not sure whether we can extrapolate the same data from coronary circulation. So I think in the interest of time, probably we'll have to leave you there and maybe proceed with our talks. So Gareth,
Okay, thank you. We will proceed with the lectures. So the first lecture is coronary fistula, cath or cut. So cath, Gareth.
Okay. Thanks very much. There's a slight change in the program. There was unfortunately a very serious event earlier on when Dr. Dalby's hotel room was broken into by a group of masked cardiac surgeons who removed all traces of talks related to coronary fistula from his laptop. So if anybody does see a group of cardiac surgeons walking around with Dr. Dalby's talks, if they could please let them know to hand it in. So they didn't know that I had a talk on coronary fistulas in my bedroom, so they didn't break in, and therefore I said I'd step in and talk a little bit about coronary fistula closure. And I would quite strongly say this: surely we're not going to do surgery on patients with coronary fistulas. Technology has advanced so much in the last 10 to 15 years, 15 to 20 years, with the improvement in microcatheters, microvascular plugs, coil technology, that surely the vast majority of coronary fistulas are within the remit of the cath lab. And I strain to find any advantage in going straight to cardiac surgery for coronary fistulas. And I'm just going to show a couple of examples. The mouse is still not working, by the way, so if you can advance for me, please. And advance again, please. So there are two types of coronary fistulas that we often talk about: the end vessel and the side branch vessels. The end vessels seem to be, or tend to be, much larger caliber vessels that end in the right atrium or the right ventricular outflow tract. The common exit point is the sort of right atrium, close where the coronary sinus comes out. And these tend to be much bigger and require much larger devices to close. But again, even in the last while, microvascular plugs of 7-9 millimeter diameter can be used to close these without the need for an AV loop. And then you've got the much smaller vessels that come from as side branches from the normal coronary arteries, and these can often be closed much more easily by just advancing a microcatheter and placing coils. Next slide, please. Thank you. The biggest thing from my point of view, and to be honest, the debate here for me is not whether or not we should ask surgeons to close coronary fistulas, it's whether we should be closing them at all. And I'm personally interested at the number of people who close coronary fistulas because they are there or because they are large, rather than having any physiological effect on the patient's cardiac function. I have not in my own head been able to basically get together the concept of you should close a coronary fistula because the coronary fistula is large. If there's no exercise-induced ischemia, if there are no arrhythmias, if there are no signs of large left or right shunt, if there's no chamber dilation, my practice has always been that these should be left alone and followed, because I don't know whether or not we can relate a large fistula to a negative event. So, to be honest, rather than debating whether or not the surgeon should be allowed to go after these, first of all, I think the debate should be whether or not we should close asymptomatic or non-physiologically important coronary fistulas. Next slide, please. So these small side branch fistulas, again, can be more trouble than they're worth. And again, in patients who don't have any indication, it may well be that these should not be closed and should be left alone for follow-up. This is a patient who's got a couple of side branch fistulas, some bigger than others. And as you can see, these can be closed with coils and microvascular plugs with just access to the coronary artery and an antegrade approach, rather than having to produce an AV loop in the right side of the heart and bring delivery catheters and delivery sheaths up from the IVC or RIJ to close. I think it's important that we don't basically overdo it, like I said, with closing tiny, tiny fistulas that have no reason to be done. And my goodness, it would be ridiculous for these patients to be referred to a surgeon for a sternotomy and potential cardiopulmonary bypass for closure of small fistulas. Next picture, please. So these are very different to the end vessel. So you can see here this right coronary artery is enormously dilated, and you can see how quickly the right side of the heart and the right atrium fills basically immediately after the injection occurs, and the right coronary artery is grossly dilated. Now, Alison Kabalka showed me a slide earlier on that she had with an algorithm for which of these patients should be closed surgically and which should be closed in the cath lab. And the argument in the algorithm she showed was that if the proximal coronary artery is dilated to more than 10 millimeters, then it should be a surgical closure. Now, I don't quite understand the logic of that. I know we debate and we talk a lot about the thromboprophylaxis after we close coronary fistulas and the potential for thrombus that forms and basically retrograde moves back up the vessel and can occlude branches. But I don't really quite see how that's different to a surgeon going in and putting a clip or tying these off, because you still leave a big sack of coronary artery fistula behind. So I sometimes think this is one of the things where when we feel that something doesn't look very nice, our default position is ask a surgeon to do it instead, even though what the surgeon's doing may actually be no better or maybe worse than what we're doing. But our default is to back off and allow a surgeon to take it on. So I don't really see that logic, and I think that this type of fistula is one that we should attempt to close in the cath lab. Next picture, please. It's important, obviously, and again, this is where real-time during the case angiography can be useful, and the surgeons do not have access to this. So what we can do, and again, to go back a step, my coronary fistula practice was taught to me by Shaq Qureshi, and we would, as much as possible, do a balloon occlusion test of the coronary artery to make sure that we'd identified the most distal perfusing branch. And if you identify the most distal perfusing branch, then you can occlude anything beyond that without worry that you're going to take out any normal myocardium. And I don't think doing that's available to the surgeons in the operating room. I don't think they can do an angiogram and look and see what branch is perfusing the different parts of the myocardium. We have the ability to do that live during the procedure so that we know when we put the plug in that we aren't going to be blocking off a branch that's coming proximal to the plug that we've placed. So identifying the perfusing branch is very important. And then in these large end vessel coronary fistulas, they usually require closure with an AV loop and then access with the plug from the RIJ or from the femoral vein. I haven't shown it here, but I think with the development of microvascular plugs, which are larger than the sort of more old-fashioned coils, etc., the potential to use a Medtronic 9mm microvascular plug through a microcatheter via direct coronary artery approach is something that we need to take seriously, because it can take away a lot of the complexity of these procedures. Forming the AV loop through the coronary artery can be at least psychologically traumatizing, because it puts a great deal of tension on the coronary artery itself and makes the coronary artery look like it's being concertinaed and squeezed up, which I think always give me at least psychological worries, even though I haven't had a patient that I've been involved with yet where this actually caused a physiological issue during the procedure. So for large plug placement, usually we need this AV loop, which needs to be carefully made as usual. Next picture, please. And again, this is just the coming to the end of that procedure of that very large right coronary artery fistula. And you can see here we're deploying a large AD01 device, which is constrained and distorted in the fistula with the back end of it hanging out into the right atrium, or just where the coronary sinus exits into the right atrium. And then we need to make sure and do some coronary angiography to make sure that we've got near occlusion, and also hopefully identify those branches that we couldn't see previously. Next picture, please. One of the biggest contentions we have is follow-up. Now again, if you ask a surgeon how they follow up a coronary fistula, they probably say, we ask the cardiologist to do it. Whereas we are being intense about follow-up and when we see them and when we get a CT scan and whether they should be on warfarin. And at this stage, the surgeon's on the golf course because they actually don't really care about the follow-up. They ask the cardiologist to do it. But we get very, very wrought and tense about what our follow-up should be after we close a coronary fistula, which is great, and we should continue to do that. And the other truth about this is that nobody quite knows what the best follow-up for coronary fistulas are, whether we should be doing repeat exercise tests, whether we should be doing CT scans on a regular basis, what the duration of formal anticoagulation should be, whether the patient should be left on antiplatelets, whether they should be on a DOAC. Nobody quite knows. But the important thing is that we're taking it seriously and we're thinking about it, which I think is something that cardiologists do. Next picture, please. So in summary, from my point of view, the vast majority of coronary fistulas that need to be closed can be closed in the cath lab. There may indeed be a case where we cannot safely get round the coronary fistula and close it in the cath lab, and then we should not be concerned to go and ask the surgeon maybe to step in and do this. But I think the concept that it's better for a fistula to be closed surgically in the cath lab is probably a little bit foolish, and I think that all these should go to the cath lab first for assessment to see whether or not we can make the loop that's required to get the plug in. And the big debate from my point of view is not whether this should be surgical or interventional. It should be, is there an indication at all to do this? And then if there is an indication and we can successfully do it, then what our best follow-up practice should be. Thanks very much.
Thank you. Yeah, we will do rebuttal after second speaker. Yeah, I want to invite Dr. Kao Deng Hank in the position of cons.
Good afternoon.
Excuse me. Malaysia wants to connect for the live presentation. Okay. I'm so sorry. We'll call you back.
All right, okay.
Thank you. Yes, we go live to Malaysia. Go ahead. Yes, Mazni, go ahead. Good morning.
All right, so can we go ahead with our presentation? Dr. Adam?
All right, sure. So, good afternoon, everyone. My name is Madan from IGN, and we're presenting our second case, the coronary artery fistula occlusion. The boy is a 13-year-old patient whose weight is 44 kilograms and 142 cm in height. Was diagnosed with a coronary cancer fistula with a right coronary artery to a right atrial fistula. This was diagnosed when he was admitted for an episode of infective endocarditis with Staph aureus roughly 18 months ago. Following recovery from the infective endocarditis, he's been well, asymptomatic, with normal vital signs, got a soft systolic murmur at the right distal border. Otherwise, his lungs and abdominal damage were unremarkable. This was when he was presented with Staph aureus endocarditis. He actually presented with pneumonia with cavitating lesions in bilateral lung fields. That raised alarm bells that there may be a cardiac origin of this septic emboli. We further investigated and found he could have coronary artery fistula. The CCG otherwise shows sinus rhythm with no ischemic changes. The X-ray shows no cardiomyopathy with clear lung fields. This was his echocardiogram with 4 chambers, usually no diameter chambers. On the short axis view, you can see fistulous cause of the right coronary artery entering the right atrium. We further investigated with the transesophageal echocardiogram, and as you can see, there is a continuous flow from the right coronary artery opening to the right atrium, very near to the SBC RE entrance. We also have a CT scan which quite elegantly shows the right coronary artery enlargement due to this fistula. And we can see here the original right coronary artery in normal course, and this fistula entering the upper portion of the RE. This is the axial slicer, which also shows the RCA fistula entering the RE SBC junction. These are our 3D virtual reconstructed images which shows the system, and we are planning for a coronary artery fistula occlusion. Thank you very much.
Excellent case and great imaging. Mazni, how was the diagnosis of infective endocarditis made because of non-resolving pneumonia and positive blood cultures? Because I thought that infective endocarditis was only in the textbooks. I had never seen one. Good. Yeah. Some learning. Yeah. Okay. Yeah, I think the images both on echo and on CT were really excellent. So, yeah. No, it's a biplane.
And you can already see that there is the native or the nutrient right coronary artery, quite faint, the distal branches. But then we can see that it roots upwards and in a tortuous path enters into the top part of the right atrium. And then we get a bit further. This is our second angiogram immediately in left. Now you can see better, isn't it? It has the tip of the picture has gone past the origin of the right coronary artery, and it is in that part of the loop where it then turns back and enters the right atrium. Can you see that image? And the right coronary artery?
Yeah, we can see those images. Yeah.
So the dimensions will show you whether from 6 millimeters
Yes.
and the RCA dimension is quite good actually. I think this is because the shunts are big and therefore there's not a lot of space on the right coronary system. So the axis is about 3 millimeters, and that is the acute loop of the fistula after it gives off the branch, after it gives off the origin of the RCA. Next angiogram. And I think once we have put in that, this is going to be. Can you see the images on the top of the screen picture? No, that's only the lower part. So we try to go deeper and cross the exit or the entrance into the right atrium, get a wire and snare it, and then put in a sheath retrograde.
So Mazni, a couple of questions. First question is this fistula a part of the sinoatrial nodal artery? Could this be the fistula's sinoatrial nodal artery? The reason to ask you is that if you close this, are there chances of sinus node dysfunction in the future? While counseling the family, I think that becomes quite important. Alison, can we have your thoughts on this? What do you think is this fistula? Where is it arising from? Are there chances of sinus node dysfunction following closure of this fistula?
I admit I wasn't too worried about that concept. I think it's a very nice fistula for closure.
Yeah.
Bharat, I have a
Please.
question. Would you consider a double closure? Closure at the feeding vessel and then at the end? Because it's a very long vessel, dilated, it can do extended thrombus?
So that is going to be the next question as to what is your proposed plan. 1 minute. There is one comment or question from the floor. Nageshwar, go ahead.
Yeah, Majne, Nageshwar, a very nice illustrative image of TE and CT. My question is, already patient had infective endocarditis. We believe that it is due to coronary AV fistula. When you look at the angiogram, the distal exit point looks very complex. There may be some kind of thrombus or healed vegetation. The jet also is going very narrow. So in those cases, I feel that going retrogradely and closing is a better approach because you have very big landing zone. So as proximal as to right coronary, so that you need not to put a cul-de-sac or a redundant fistula. So that's what my approach in this case is going to be slightly different. I prefer to avoid the AV looping here.
Yes, Dietmar.
I'm Mazini. Thank you very much for. Yeah, fine. I'm happy to see you and hear you and working you. I want make just a comment in addition what Bharat mentioned. So I would even try to avoid a double disc device in this case, not at least because of the sinus dysfunction, maybe over years, or it is, in my opinion, it would be very easy to put an MVP, for example, in the end of the long fistula, and you can do it easily even from the arterial side. So you can advance and 5 or 7 millimeter, I think 5 millimeter is enough, to put an MVP in the distal part of the fistula, of the coronary part, and then you don't need a double disc. That's my comment for this.
So you have two comments. One is proximal occlusion. Nageshwar says so as not to disturb the vegetation or thrombi. And Dietmar says distal occlusion so that even if there is a sinoatrial nodal artery, probably you may not sacrifice it. So you will have to take a call. But before that, one more question from the panelists.
Yes. Would you consider a balloon test occlusion?
So another suggestion is balloon test occlusion.
Does not need.
So now you can take over.
Bharat's idea is not bad.
Okay.
Yeah.
Alice, Masni,
this is
Alison had a
Masni.
comment.
Masni, it's Allison. You have beautiful pictures and great access. I agree with your assessment. I wonder if you have coils such as penumbra ruby packing or things like that, because this is a great case to be able to pack coils even from the retrograde approach and close most of your fistula up into the normal coronary artery so you don't have a sulcus for thrombus.
Yeah.
I would be, if we think that sinoatrial nodal artery is not of any consequence, we would close this fistula as close to the origin of the fistula as possible. And I don't see, although it's a long fistula tract, once you close the proximal end and the flow stops, I don't know what happens to the thrombus within the fistula tract and whether it will ever go distally into any circulation because there is no flow at all. So I don't see any reason to close the distal end as well, but I would be happy closing it as proximally as I can.
Yeah, hi Mazani, this is Ahmed. Yeah. Yeah. How you define this fistula? Is it proximal or distal? So I thought that it is proximal, originating from the main right coronary artery. So in proximal fistula, I always prefer to close as proximal as possible if there is no side branch from the fistula tract.
Agreed.
So it is easy after the vascular plaque area with low profiles, such as ABP4, it works through 4 friends. So it is easy to go to retrograde and to put a plaque especially in this patient, 14-year-old, and who has a good femoral artery. So retrograde easy with 12 millimeter of ABP2. No need sophisticated AV loop. Sometimes may cause.
But I think since they are there with a sheath antegradally, I think
But
they could just.
This is okay. In fact, just now it is okay. You may go on, but in the
last comment,
at
Nagesh.
the beginning.
Sorry.
No, it's okay. At the beginning.
If we look at the AP view, I think we do see the sinus node artery coming from the distal fistula, if we call it a fistula. Could it be possible to do an angio through the sheath so you don't fill your right coronary, and then we would see if there's really a side branch? And if it's a side branch, if you play the AP, I think we see a little branch distal on the distal fistula. Near the you see it? Just under the distal part.
Yeah, there is a
There's
thin
a small
branch there.
Yeah.
I think that is coming from the proximal RCA.
Well, then they should, if they want to know, they should inject through the sheath and not filling the RCA, and then they would see if there's a branch in the distal fistula.
Joachim is trying to make a point that rather than injecting into the right coronary, if you can inject through the sheath, maybe you may be able to differentiate or maybe change the angle. Okay. Okay. Okay, go ahead. Yeah. Mazni, you will have to proceed. I would be happy using AVP2 in this case.
You can use an you can you can use an ADO 2, you can use an plug 4, but you have to cover both exit because the other could become an exit if you are put it too distally. So I would avoid a double disc in the one disc, the distal one in the atrium. So I would close the distal part of the coronary, dilated coronary arteries that is covered both maybe exits. There's only now you have one exit covered by this long sheath, and the other one could be developed over time if it is not even occluded. This is my opinion.
Okay, Mazni, we will have to proceed in the interest of time. So you tell us your decision. What size and what type device you are going to use? Okay.
Is this because of availability? Hi, Mazni, this is Amal. Why AVP1, not 2 or 3?
Okay. Go ahead. Really, in this fistula, any device would work probably. Somebody is keeping a watch on ACT because this is a large fistula. A lot of time has been spent in discussion. And there will be some fistulas tracked proximally. Yeah, so keep a watch. Yeah. Excellent. Excellent. Yeah, very well. We can see it coming out of the sheath. Yeah. Excellent. Yeah, looks good. Yeah, I think there is a residual shunt, and the issue is AVP1 is without a fabric, am I right? Or it has a fabric? So, yeah, so now with the residual shunt.
Can I just give a quick?
Yes.
Madhini,
Nageshwar.
the AVP1 is a single disc device which doesn't have any fabric, whereas AVP2 has got a trilobed device. The occlusion rate inter-disc space will facilitate the occlusion. Therefore, if you are using AVP1, it's a good idea to put coil also. If you put coil, the occlusion rates are very high. Otherwise, 3 to 6 months, the shunt will be there passively for this. So always we put a coil if you are using it.
Yeah, maybe.
If you are putting second device, that is effectively, yeah, that's a good idea. That is effectively like a AVP2. It will act like AVP2.
Maybe using, because the problem is you don't know what will happen to this residual shunt. Most likely it may close, but you can't be sure when you don't have a fabric. And you know, sometimes flow can beget flow. So I think it may be a good idea to put another small plug so that you get rid of as much flow, and maybe with a fabric or a triple lobed.
Just a quick question. Is it too small, the size? The size too small?
No, I don't.
No, Dr. Masni. So just wondering, the size you put in is a bit too small for AVP1 in this particular case? Okay, all right. Yeah. Okay. I think it's a good idea. Yeah.
So Masni, what we can do, we can finish one talk, you can finish the device, and we come back to you to look at the final angiogram. Is that okay? Okay, thank you. So we can, yeah, please, we can talk, we can begin with the surgical talk, and then we'll go back to Malaysia. Can we go off the cath lab and on to the speaker, please?
Oh. Yeah, please go on. Yeah.
So actually, from the point of view of surgeon, I'm eager to see how the outcome of the intervention that Dr. Majini and his team are doing right now. I asked to give a talk about the coronary artery fistula from the surgical point of view. Introduction that the coronary artery fistula is an abnormal connection between the coronary artery and cardiac chamber or ray vessel. It is about 0.1 or 0.2 of congenital heart disease. But recently, with the recent cardiac imaging, there are more and more fistula detectable. And we have to remember that from 4 to 15% of young cardiac student death related to the abnormal coronary artery. And most of the fistula are congenital, and many of fistula are asymptomatic, but there's still many complications during long-term follow-up, such as heart failure, aneurysm, ischemia, endocarditis, and arrhythmia. And because regarding the physiology, because it is the range from the high pressure blood of coronary arteries to the low resistance venous system, and it bypass the natural capillary network. So the characteristic type of fistula is to the right coronary artery, like the case that Dr. Majani is doing right now, and the other range size like right atrium, right ventricle pulmonary artery, and the HVC. And actually, there's still blood phenomenon, and until now, even the chest imaging is very difficult to diagnose that still phenomenon. For diagnostics, there are some key imaging techniques like echocardio, like initial screening tune, and coronary angiography is a gold standard for defining anatomy. And recently, the CT, MSCT scan can be very helpful for the interventionist and the surgeon before doing the intervention or surgery. And I'm sure that many of us know well that the lecture of Dr. Dario Pucciari that if the fistula is asymptomatic and it's a small fistula and no risk of complication, we can follow the patient every year. But if the fistula is symptomatic and it's a large fistula, and we consider to give the closure even by surgery or by the cath lab. And the indication of intervention or surgery depend mainly on the anatomy complexity of the fistula, its origin, the destination, single or multiple fistula, the drainage site, and also the adjacent vessel. And the other factors like patient age and concomitant cataract anomaly can be considered too. So there are many reports about case series of surgery for coronary artery fistula. Most of them that the short-term outcome and the long-term outcome are very, very good. And recently, also the interventionist has published many case series outcome, and also that they give the very good result. One of the landmark paper published in JACC in 2021 from Mayo Clinic, they review on the largest case series of transcatheter closure of the fistula, and even we see that the success rate of the transcatheter closure is very high, but there are still many complications, dangerous complications like myocardial infection, coronary dissection, AV block, and ischemia, arrhythmia. And that team from Mayo Clinic also classify that if the fistula is from the proximal coronary bed or from the distal coronary bed, if the proximal is from the distal coronary bed, and if there is a large fistula or a risk of significant myocardium ischemia, they recommend to do the surgical other than transcatheter closure. And there are some key points for comparison between the transcatheter and the surgery. Of course, that if you can close it by transcatheter, it's less invasive and shorter recovery time. But actually, that the complication related to the device migration, ischemia, residual fistula, and ischemia is still there. And actually, that I believe that the intervention can do the case just for the simple fistula, and the surgery is I think the surgery is we see that they're more invasive, but actually they're more durable for the complex cases, and we can have many techniques to close the fistula, like under the direct vision. We can close directly, or we can patching the fistula, and especially if the fistula is very large, complex, and aneurysmal, we can close safely by the surgery. And recently, one of the paper, a very good paper from China, they compare the transcatheter closure versus the surgical closure, and actually they found that if even the success rate of the transcatheter closure is high, but there's still many the complication during the long-term follow-up is higher than the surgical follow-up. And the author, they recommend that if there is fistula, a large fistula and distal, so they also refer that the treatment for the surgery. So because I know that there are many interventionists in this room, so just one question that we do close the fistula by the transcatheter if it is very large fistula and multiple communication, talk to us pathway, and then multiple branch side, and the branch is very proximal to the any important coronary artery branches, and if there is some very large aneurysm of the coronary artery, and of course that if the patient had other concomitant anomaly like severe TR, severe MR, or large VT, I do think that we can the repair on the defect during the surgery. So finally, I present a case a few years ago of our team. Our team, we have few very strong interventionists. Few years ago, we got one boy around 1 years of age, 6 kg. He came with us with the symptom of shortness of breath and the sign of heart failure. Echo, we found that very dilated proximal RCA and possibly the fistula between the RCA to the RV. Can you turn the CT scan? So we do the echo and the CT scan and found that there lack fistula between from the distal RCA to the right ventricle. Okay, and after discussion between the surgeon and interventionist and our interventionist, he wanted to try to close by transcatheter. So in the cath lab, actually he can go with the guide wire from the coronary artery, go through the fistula and to the RV. And we can see is there aneurysm of the proximal right coronary artery, and actually the fistula is not very large, but short, and there is at the distal the mid part of the right coronary artery. And during the intervention, when the interventionist try to handle with the guide wire, the cyst and the device, there were arrhythmia and some ASD changes, so they had to stop the procedure. And we few years later, we have to bring that boy to the OR, and actually we found that because the fistula is quite small. We are trying to do on beating heart without the heart lung machine. So I think during the surgery we can find easily the dilated proximal right axial right coronary artery, and also we can find very good the locate exactly the fistula, and at the same time you see because the fistula is very near the distal ICA, that explains. That's why when they try to handle with the fistula and they put the device, there's some ischemia symptom appear. And now we dissect and found out the fistula and just ligate the double ligation of the fistula. So based on discharge later on and without any complication. So my conclusion is we don't have one side fixed on approach for the coronary artery fistula, and the intervention by the cath lab can benefit in small to moderate size single fistula, but the surgery is the gold standard for the significant and complex coronary artery fistula, and the best outcome can be achieved through careful patient selection, individualized treatment planning, and collaborative heart team approach. Thank you so much.
Thank you, Dr. Dao. Maybe we
So are there any questions or comments? Yes, please.
Thank you for a wonderful surgical talk. One question is, what are the other types of surgeries? How often do you have to do a coronary bypass?
I think like the case that the video show, I think that's not very complicated cases, but the other complicated one, very large fistula. So usually we have to run the bypass, and I try to occlude the proximal and the distal coronary artery, and it's depends. We can close directly, or even we can use the patch to patching. And I think the other thing that if the fistula tract is long, we try to occlude. I mean that we ligate the proximal tract and the distal. We try to occlude on the fistula pathway. Yeah.
Thank you.
I just answer the same question. In the cath lab, we don't use cardiopulmonary bypass for these in the cath lab.
Maybe get it.
Coronary artery bypass grafting.
We don't have to do that in the cath lab. Yeah.
So Gareth, one question for you. In your practice, when will you send your patient for surgical intervention on a coronary AV fistula? Suppose if you have a neonate, 3 kgs, heart failure, large fistula, would you still take him in the cath lab, or would you be comfortable sending him to surgery?
No, I remember when I was a fellow, I remember Rajiv Chakravarti closing one that was an infant, but I have to say that would form for me the exception to the rule. A 3 kilogram patient heart failure with a large fistula, I would send to surgery. But again, I think our surgical colleague demonstrated it in patients where the interventionist fails to close the fistula, then the patient gets sent to surgery.
Yeah, I think, in current practice, really a few years back, I had to debate on this topic. So I sent a questionnaire to the surgeons in India. All the surgeons of my generation also, they have hardly done 1 or 2 fistulae in their lifetime. So even the surgical experience with closure of coronary AV fistulae is extremely limited. And even surgeons are very happy if we can deal with these fistulae in the cath lab.
Yeah, you have many questions on your one slide. Yeah, do you close the tertius ones? Do you close the multiple axis? Of course, we can close multiple axis from the merging point, maybe from the exit point as proximal as possible. But what about you? You should close the fistula from the end because you cannot see the minor side branches because of the high flow. How can you close multiple exit points? I mean, like Swiss cheese in trabeculated right ventricle, for example. But we can close them from proximal part in the cath lab.
Yes, Nageshwar.
Just want to share our experience very briefly. Extremities of age, as you said, that a neonate with a large fistula, we send for surgery. Other two indications which we saw in our practice, the fistula which is opening below the tricuspid wall in the right ventricle, it's extremely difficult to close by transcatheter mechanism. Second is fistula which is opening into coronary sinus, where it is generally very tortuous. So these are the three cases in our practice. We sent close to around 36, 37 cases we did over the period of 20 years of time. So
Thank you for sharing your experience, and I think we'll move on to the next talk. So it's the next debate.
Thank you.
Thank you, sir.
So our next session of pros and cons, we have the perimembranous VSD closure, device or divorce. I guess divorce means go to surgery. So I'd like to introduce Dr. Swishi Kwek, talking about the divorce aspect of perimembranous VSD closure. I guess that's doing surgical referral.
Thank you very much, and good afternoon. I'd like to thank Tim and the course directors for inviting me to Ho Chi Minh. It's great to be amongst friends again. And as you have heard, today's topic is on perimembranous VSD closure, divorce or device. And not quite sure what that divorce means, but I've been asked to talk on that, and I gather that it would be against the motion of device closure. I have no disclosures to make. Before we talk about treating ventricular septal defects, maybe we should revisit the intent of why we do so. And the chief indication is in babies, which large ventricular septal defects were in congestive heart failure from a large left to right shunt. And these babies usually have failure to thrive, difficulty in feeding, are at risk of multiple hospital admissions from recurrent chest infections. And do we routinely treat these small babies with devices in the first few months when they need it the most? And the answer is no. Maybe because they're too young, too small, technically challenging. It's not a standard routine of practice in most cath labs. Although later on in my talk, I shall be presenting a paper on the device closure in infants weighing less than 10 kilos. And as we get better with time, we can do more and more things as management evolves. The second question that we need to ask is, do we need to treat all VSDs? And again, the answer is no, because majority of the VSDs are small and hemodynamically insignificant. And just because we can do it doesn't mean we have to do it for everyone if the indication is not there. And also because most ventricular septal defects can change and evolve over time. They may reduce in size, and some may even close spontaneously. If we look at this paper that was published in the American Journal of Cardiology in 2019, where they followed up 113 cases, only 18 patients went on to require some form of treatment, either by surgery or device. And this was because there was a high spontaneous closure rate in the perimembranous group, more than half of it, and a large majority in the muscular VSD group. Of course, some people may argue that closure of the VSD reduces the risk of infective endocarditis, but we should also remember that the management or the risk mitigation for that is not closure of a VSD that is small and there's no good indication for it, because what we should be teaching our patients to do is to keep good dental hygiene If we put in a device and there is a residual shunt, that actually in contraindication increases the risk of infective endocarditis. If we had to do it, what are the various options that are currently available today? Surgery, device, hybrid, and conservative for the small ones. We know that surgery is time-honored. As we heard the debate between the surgeons and interventionists for coronary arterial venous fistula, surgery has, for VSDs, have good results for all sizes, all ages of babies, although I should concede that there is still the need for general anesthesia, cardiopulmonary bypass, a longer post-operative recovery, an unsightly scar, and more utilization of hospital resources, including costs. And if we were to do device closure like surgery, are there complications? Yes, there are complications. And in a systematic review that we published some time ago, we looked at 37 publications comprising more than 4,000 patients. The most common complication that was identified was a residual shunt. And again, if the indication for closure is not there, and we think that we want to close it just to reduce the risk of infective endocarditis for the small VSDs, this is one factor that is against it. Other complications would include valvular defects and arrhythmias, a whole spectrum of arrhythmias, and as we know, the complete heart block is one of the most feared. When we did a meta-analysis on device closure on perimembranous ventricular septal defects, again, the same spectrum of complications, including residual shunt with a pull estimate of 15.9%, a whole spectrum of arrhythmias, complete heart block in 81 patients out of the 6,000 that was pulled together. 48, thankfully, were transient and did not require pacemaker, but 33 needed pacemaker insertion. And again, there were other complications of valvular regurgitation. Another publication on a pooled number of patients who had device closure, 773 patients. 24 of these patients ended up with surgery. If they hadn't gone for the device, they may not have required the surgery. And 14 of these cases were for worsening aortic regurgitation. 4 were for device migration, and then surgery had to be undertaken to remove the devices and close the VSDs, and 2 were for complete AV block. In another paper that was published and looked at 633 patients, there were rhythm and conduction abnormalities identified in this group of patients with complete AV block in 2, one needing a permanent pacemaker, and the other one died of a cardiac arrest, which was secondary to a reversible complete AV block, and that is a shame indeed. Of course, we understand that there is now a whole wide variety of devices that can be put in, and with improved techniques, better expertise, this has led to a reduction in complications. Is there a device for device closure? And the answer is yes, but not yet a standard of a routine for small babies and in infants, but we can do that in hybrid procedure, for example, in a combination of a teamwork between the surgeon and interventionist for the small babies. This is a paper that was recently published in 2023, which showed the safety and efficacy of device occlusion of ventricular septal defects in a group of 52 patients using the ADO2 and the MFO at median age of 11 months, weight of about 7 to 8 kilos, and fairly good results, but 2 patients did develop complete heart block, one of whom developed the block 3 days after and another 6 months later. So it, again, is one complication that does not always, like we talked about, erosions in ASD does not occur immediately, but may occur sometime after device implantation. This publication is from Joko's group and Mingtai's group from the National Taiwan University, and it shows the risk factors for complications of aortic regurgitation. Whilst they had a high success rate of more than 98%, they identified that large defects of more than 4.5 millimeters in smaller children implanted age less than 4 and of the outlet
Professor
type
Quake, can we hurry up a little?
were independent risk factors for aortic regurgitation. And this is one of the latest publications on 30 patients who had a fully degradable ventricular septal defect occluder that was put in. They concluded that the novel fully biodegradable occluder is safe, effective, and perhaps the perfect alternative for treatment. And we'll be hearing a lot more about the biodegradable devices later. So I would suggest that not all VSDs need to be closed, and those who require closure are the small babies who probably will be more suited for surgery with good outcomes, and we can consider the hybrid procedure. But moving forward, more flexible devices, lower profiles, greater expertise may change the paradigm in which we treat ventricular septal defects. And clearly, the introduction of biodegradable device adds on a new dimension that presents us a further option to our evolving practice in the management of this condition. Thank you.
Thank you for that comprehensive and excellent overview of VSD closures and the scope and limitations of device closures. Thank you very much. We move on to Kuala Lumpur for the last angiogram, which they are going to show us, and then we'll come back to the last talk of this session. Hi, Mazni. Yeah, we can hear you. That's right. Yep. Yes. That's right. I think that's a great result. Excellent. Thank you very much. Okay, so now we move on to the last talk. Yeah? Live? Okay, we go on to one more live case. So, can you hear us? Yes. So let's go on to the last talk. And
Now, for the on-site device closure, Nageshwara Rao is going to talk on. Please.
Good afternoon and thank you very much. My debate session is perimembranous VST closure, the transcatheter device closure. So these are my disclosures to MFO 1, 2, and 3. They did not remove some of the slides for some reason, but these are all discussed already. The natural history showed that some of the defects may close naturally. However, even small defect can cause AR, infective endocarditis, or outflow traction, obstruction. The current management options are surgical, device closure, some of the selected cases, hybrid procedures. If you look at the outcome, long-term outcome of the surgical closure of the perimembranous VST, it is not that it is once you do surgery, it is totally free from the complications. There are patients, they develop late residual problems, late arrhythmias, late aortic regurgitation. Some of the pulmonary hypertensions also progress. Therefore, surgery, even though it is a gold standard, you need to follow them. And you don't know how long you are going to follow also, based on the residual shunt, based on the tricuspid regurgitation, so on and so forth. Whereas the device closure, you have initially got the eccentric device, muscular, ADO2, all these devices, but all these complications based on the device specific. The advantages of EST device is minimally invasive, less number of days in the hospital, low complications, and the family is very happy, less psychological trauma, quick return to the work. The exaggerated things by the literature is the heart block. Everybody got apprehension, afraid, as if this is going to be very serious issue. I'll tell you why it is overestimated. Device embolization, and of course only one point we should agree is the limited application in some of the cases. There are many studies which showed that a device is superior. The first device started by Jim Locks in 1980s, then subsequently large data published and showed superiorly. Unfortunately, few cases they developed complete heart block, and then people started stopping the eccentric device. We studied the eccentric device, which is number one is a less interdisc space and lot of shear stress, and also the fabric reaction. What about surgery? Is complete heart block free from the surgery? No. There is a significant risk of complete heart block with surgery, which is 1 to 2.3%. You look at the Professor Anderson meta-analysis paper, all these things, there are significant number of patients, even as high as 3.5% complete heart block. There was a mortality, there was a needing of a pacemaker. The reason for that is the conduction system, which is close to the ventricular septal defect. So Professor Anderson and earlier Latham and all, they described variability of the conduction system. We also studied on 15 patients prior to the device closure, found that some of the conduction system left bundle type D and E are close to the ventricular septal defect. So it's immaterial whether you put a device, you do a surgical closure, the complete heart block is going to happen. Unfortunately, the devices which were used in the past, because of lack of thinking of shear stress, fabric reaction, all these things cumulatively cause some exaggerated heart block. So whereas the transcatheter closure is superior to surgery in one of the randomized trials which showed that the less number of blood transfusion, less hospital stay, and minor complications which were significantly present. You can see that many complications happened in the post-operative period. So the data which is supportive is clearly showing that the transcatheter is better than surgical procedure in avoiding some of the complications. There are many systematic review papers. I'm not going to go through all the literature, but if you look at the evaluation of the perimembranous VST, eccentric device is no more available. We are still talking about that, which caused heart block, which is removed. Then ADO2 came, less number of complete heart block. ADO1 people use, again literature shows less than 2%, 1.5%. Now you can see the multifunctional occluder, which has got a double disc device with a narrow central waist, low profile device, less shear stress on the conduction system. You can see this is the patient with a large defect here, more than 2.6, and this is a part of electrophysiological study, and successfully closed using a 1210 device without any hesitation, patient discharged next day. This was another patient referred by surgeon in the surgical meeting. We discussed that high risk for the surgery with multiple VSTs. You can see the PA pressure and FA pressure. The PVRI was 5 wood units. So in this patient, there are multiple defects. We have to close some of the defects using the conar multifunctional occluder, a method through foramina uvel. You can see two devices are being closed. And follow-up data after 1 year showed that there is a substantial fall in the pulmonary artery pressure with a small residual shunt. So this is the ideal case. These are the cases that cannot be done by the surgeon. Look at this case. Neonatologist failed to extubate the baby. We went to surgeon to close it because we also worried about the closing by the device closure. So very high risk for surgery. Therefore, my colleague actually closed using the 8-6 conar multifunctional occluder, only venous approach in this patient, and successfully extubated after 3 days. So there are many, at this point of time, 35 publications are available worldwide from Argentina, from Turkey, from Greece, and East. So all these data support that the conar multifunctional occluder has got a high success rate. Major complications are very minimal. There is only one case report of complete heart block reported by Majni LV group in a Down syndrome baby where left axis was there in inlet VST location. So my argument is when you have a device which is less clamping force, shear stress, fabric reaction, and if it is ideal case, I don't think we should have hesitation to close the defect. So transcatheter closure of perimembranous VST is minimally invasive, safe, and effective. So I'm not going to come back for the rebuttal, but these are some of the cases actually referred by the surgeon. A child underwent PA banding for DORV with multiple VSTs, underwent device closure of the apical VST where it is not accessible for surgeon. Then he has to close the subaortic VST. Similarly, this is a small baby, 4.6 with respiratory infection on ventilation, underwent the VST device closure. So these are some of the examples of DORV child undergoing a surgery, multiple residual VSTs, undergoing transcatheter closure. So I had a doubt whether my argument is correct or not. I asked AA opinion. AA opinion, I asked honest opinion, please give. Nowadays, we all check it. The AA opinion, honest opinion was device closure is a good option for a carefully selected patient and favorable outcome. However, we need to be careful. However, Dr. Tin is very aggressive. He organized this meeting. He is eagerly waiting to put a VST interventional meeting A to Z next year. So I think VST has got, transcatheter closure has got a major role in VST device closure. Thank you very much for your contribution.
Thank you, Dr. Rao. Maybe we can have several questions or comments. Any question or comment? No.
I have a comment. Thank you so much. I'd like to commend you on a very crisp and short and to the point presentation. What are your institutional preferred devices that you personally like, or many of your cases, what would you opt for?
Sorry, the voice is not clear. Would you mind to repeat that?
Institutional preference of the device.
Yes. So I think it is a major important institutional preference. Our institute, we prefer conar multifunctional occluder. Earlier we were using ADO2 and muscular VST. Now all cases will go through the scientific review meeting. If the scientific review meeting accepts only, we do the procedure.
Yeah, I can make a comment about it. Has been already divorced, I mean perimembranous VSD closure in the US and in Western countries. So we have been going on to transfer closure of perimembranous VSDs in Eastern countries, in Middle East and other side of the world. So, of course, not all cases, only selected cases in perimembranous VSDs also. MFO was encouraging devices, but also heart block has been reported with MFO too. So some slides in your, about 4% of block, in, for example, 2 AV block in 50 patients. 50 patients. So means that for near zero of heart block in surgery. So also the title of the article is safety and efficacy, but 4% of heart block, near zero in surgery. So another issue that if transcatheter can be performed, everybody decrease the indication, even in small VSDs. The intervention means that higher rates of, totally higher rates of complication. The problem is the indication, I think, in transcatheter closure, not the complication. If you select appropriate cases, where small amount of complication may occur, but the problem, if it is occurred in no indication patient, it is disaster, I think.
That's a very important message. If it is indicated and if you do the procedure, either device or surgery, you will be willing to accept that complication because no procedure is without complication. But doing a procedure in a VSD when it is not indicated, and if you end up with a complication, that is something we should be careful about, and that's a very important message to take home.
That's absolutely acceptable. And we carefully thought about Conar MF fabric and no fabric in first version because 86 device up to 86 are used for the small defects where physician feels that there is an indication. If you look at the causes for the heart block, fabric reaction is one of the important late complication of the heart block. That's why the fabric is removed intentionally. If you are doing a small defect for any indication, should not have complication.
Okay, I think with that we come to the end of this session and a loud round of applause to all the speakers and all the live case presenters. Thank you very much, ladies and gentlemen.
Then, Kevin, could you and your team come straight up and we're going to go ahead with the next live case session without a break?
Hi, Tin. We can hear you. We can hear you. Are you in a hurry? Can you wait for some? Okay, should we start with the live case? Okay. Yeah. Okay. Okay. Welcome. Welcome to the session step by step in VC closure. We will start with the live case. It is Dr. Tin, Children's Hospital in Ho Chi Minh City. Yes, can you please introduce the case and tell us what you are doing? Okay. Nice case. Yeah. I would like to know how many perforation you have. Is this only one exit? Or normally, in aneurysmatic VSD, we often see more than one perforation. What is about, what is the number of perforation in this case? Yes. And, and it looks like a long tunnel at, at the exit point. I would like to see the tricuspid valve separated from the defect in echo. Okay. Okay. Mhm. Okay, very nice. Good. Any questions here?
It looks, quite a favorable defect for transcatheter closure. The on-fast view was extremely helpful, isn't it, really, on the 3D? You really get a good appreciation of how it narrows from the LV orifice down to the RV hemodynamic orifice. And that maybe, something like maybe an A686 MFO device would work nicely here.
Okay, this is the first suggestion. What about you?
Yeah. Tin, this is Masood here. How are you? Good, good. I was just wondering, is tricuspid valve making or contributing to the aneurysm formation or the tunnel at all? Because that would also influence your decision as which device you would like to take, because the most likely thing is that you would bring it into the aneurysm.
What ideal
Yeah.
2 or ideal 1?
Yes, we can see the angel. Yeah.
Yes. And can, uh, then, what is the largest diameter of the aneurysm? The angiographic profiling is very good. Do you have any measurements from the angiogram? Yeah, I mean, it's quite a complex aneurysm, isn't it? But so essentially, you're just going to have to see how the device fits. Then can I see the diameter, the largest of the aneurysm on lateral view?
Jane, another issue will be the length of this aneurysm. It's fairly long and has an awkward shape, like sort of aneurysm in the center, and then you can see it tapering down towards the right ventricle. So I think the choice of device would depend whether you would really be bringing it into the aneurysm, and is the aneurysm strong enough to hold it?
Yes. Yes. If, yeah, I have one question. If you look at the lateral view, you can see the profile of the defect quite well. And you think there are more than one perforations, or? Yes. In this case, I would prefer to use a device which is soft, but which should cover up the base of the profile of the defect, because otherwise you can end up with a residual shunt, because you cannot close the other perforation using only small device. Yes, better. Yeah, above the valve. Uh, yeah, Tin, I have one question. Are you sure that you are not going under the moderator band? Yes, look better now. Yeah. Mhm. Yeah, I think.
Tin, Tin, I have a suggestion. Why don't you do an RV angiogram while your pigtail is in the right ventricle, and that might actually, because you're across the VSD, that might give you a better profile of the aneurysm and the morphology of the defect. You could do that either by passing a sheet through the VSD, or just the pigtail would be fine. And if you can do another RV angiogram, that might help actually. I don't know, what is the largest diameter of the MFO? 14, 12, yeah.
I mean, 10.8 would be fine. I think Sal showed that the orifice on the RV wasn't particularly big, so I guess you want to see what way the disc is going to end up looking like, either in the aneurysm or on the LV or on the LV aspect.
I would use a bigger one.
What size sheath is it in? 6 French. So you are going with a 10.8 MFO?
Yeah, can you can you show us fluoro at the same time? Both, please. Can you zoom in the echo? You see the, yeah. The, yeah. The, okay, it's look better. Mhm. Now it's look better. Mhm. Yeah. Okay. Okay. Can you zoom in the echo? Yeah. It's nice. Very nice. Can you focus on the tricuspid valve? Okay. Yeah, I think that is. I think this is a second perforation. Yes. Hopefully, because
Looks very nice, Tin. I think.
Can Tin, can you show us left ventricular outflow track in long axis?
I think once it will be released, that that what looks like an obstruction is not actually an obstruction.
Okay. I'm not sure if the left ventricular disc covers up everything, but we'll see. I yeah, I have Tin, I have one question. If you look at the location of the devices, look quite well, but there is still some shunt. Would you for the next patient, would you prefer the integrate approach? Because then you can better control the shunt. Right. Right. Okay. So you are ready? You are about to release? Yeah. Echo, please. Okay, perfect. Very nice.
Looks very nice, Tin. Do an LV angio, and I think we can.
Okay. I think there's no shunt. There's no shunt because we can not see any turbulences on the right ventricle.
It looks very good. Does the repetitive interaction of the tricuspid valve with the RV disc that's really quite stretched out worry you at all? The device is quite stretched, and there's a repetitive stretching on the right ventricular disc by the tricuspid leaflet. Is that concerning at all, or you think it's going to be fine?
I think. Mm. I think uh, the I think the cause for the not perfect shape of the right ventricular disc at first, it was because maybe you cross the apparatus of the tricuspid valve, and it is something which is very important to know. Okay, very nice. So I think it's perfect, and I think we do not need. You need an angiogram in this case? No, I don't. I don't think. Okay. Okay.
Tin, at the end, it looks very nice, actually.
Okay,
The left ventricular disc has totally occupied.
Is Dr. Yen Ho in the room? Dr. Yen Ho? Is not there. Yes, yes, please. So we start a session with talks, and welcome Professor Yen Ho. I think it's very important for us to be aware of anatomical issue if we close defect and so on. And I think normally we look at the echo, we see the shunt and so on, but maybe we are not aware enough of all the aspects of the anatomy. And I'm very happy to have Professor Yano here, and she will give us a lecture on anatomy of VSD, please.
Thank you very much for having me. We're going to look at the variabilities in ventricular septal defects, but as you have already seen this very interesting case, there are actually a lot of variabilities in ventricular septal defects, not only in terms of the number, the size, the locations. We really need to have an idea of where we are or where the defects are, so to put these things in some sort of system, we consider the outlet, inlet, and apical parts of the ventricle. So in terms of borders, which is kind of important, and you know about the muscular borders, and you know about the perimembranous borders, and you know also about the doubly committed and juxta-arterial defects. So I'm just going to show you some examples. And these defects, of course, in the past have been given various names. So we have 4 examples here of muscular VSDs. So what you are looking at are holes with complete muscular rims, and in the top video, you can see that you can't actually see the VSD from the right side because of the heavy trabeculations. Whereas I turn the heart to the left side, we can see that VSD actually crossed by a muscle bundle, isn't it? There we are, muscular kind of VSD in the trabecular part. In the lower panel, we have a 4-chamber cut through a heart, again with a muscular VSD, but this time, the VSD is traversing obliquely through the plane of the ventricular septum. In the third video there on the top, we can see a muscular inlet VSD. It's not round, is it? It's more or less oval in shape. And on the back there, you can see quite nicely where exactly it's sitting. It's free from important structures, free from the major conduction bundles. The muscular inlet VSD. In the bottom panel here, we have a muscular outlet VSD because we can see the aortic valve behind the VSD, and we can see the rim of the VSD is completely muscular, meaning that the conduction bundle is further back towards the tricuspid valve. So you have good muscular margins, in other words. So in terms of conduction bundle, muscular VSDs kind of protect, as it were, or distance the major conduction axis away from the immediate rim of the defect. And you can see in this example, again, not perfectly round defect, is it? Now moving on to perimembranous defects, they're so termed perimembranous because they are in the region of the membranous septum. And for me, as a morphologist, a membranous septum means proximity to the atrioventricular conduction bundle. So in this diagram here, we can see on the back of the orange coloration, depicting a perimembranous VSD, I've drawn a red line indicating the atrioventricular node leading onto the His bundle, the common atrioventricular conduction bundle, etc. And as this is the right ventricular aspect of the septum, the right bundle branch. So then, example here, we can see a kind of aneurysmal formation of the tricuspid valve already. It's kind of redundant looking, and we're peering into the VSD from the right side of the heart. We seem to have very good muscular margins around the top of the VSD, but at the back of the VSD, now we're in the left ventricular aspect, we can see on the back of the VSD, the posterior inferior margin, is actually a remnant of a fibrous tissue of membranous septum, indicating to my mind that we're very, very close to the atrioventricular conduction bundle, and therefore I have drawn in my perception of where the atrioventricular conduction bundle is, and I've colored in the left bundle branch. As you can see, this bundle is coming through the region of the remnant of the membranous septum. White coloration means for me fibrous tissue. And I've got an arrow there pointing to the aortic valve leaflet of the right coronary aortic valve leaflet. And note that the upper margin of this VSD, although it looked like very muscular on the right ventricular aspect, is actually very close to the margin. And the margin of that VSD is actually very close to the aortic valve leaflet. So looking at a VSD on the morphologic specimen on the right ventricular side may give me a very false impression that we're nowhere near the aortic valve, whereas it's not the case when we look into the left ventricular aspect. So these are the variations to look out for. And these still images just show you I've plotted in the AV conduction bundle, a membranous flap, indicating a remnant of the membranous septum, the proximity to the AV conduction bundle. In this example, a perimembranous outlet VSD. And in this other panel here, I've cut through longitudinally through the ventricles and up to the aorta, just to plot in where I would imagine the AV conduction bundle is. Well, the AV conduction bundle is not always right on the crest of the septum. It can be a little bit off towards the left ventricular aspect, maybe 2 or 3 millimeters off the edge of the defect. And here's an example of an inlet VSD, where you see the upper margin would be the fibrous continuity between tricuspid and mitral valves. And again, I've plotted in the AV conduction bundle. Again, in this case, I've drawn it on the crest, directly on the crest of the ventricular septum, but it may not be. It may be more to the left ventricular side. The third type, the doubly committed and juxta-arterial VSDs, are those that are roofed by the aortic and the pulmonary valves. So I've colored green in that depiction, in the depiction on the diagram, but the posterior inferior margin can vary. And these are two examples. On one panel here in the movie, you can see that we have a muscular posterior inferior margin there, but the roof of that VSD is the conjoined leaflets of pulmonary and aortic valve tissue. So the forceps pointing to you a thick muscular posterior inferior margin, meaning that the AV conduction bundle is far away. Whereas on this other example there, you can see that we still have the roof of the VSD with aortic and mitral and pulmonary valves, whereas the posterior inferior margin is the fibrous tissue or fibrous remnant of the membranous septum, meaning proximity to the conduction bundle. So the two variants here, but still the upper border of that VSD is pulmonary and aortic valve leaflet tissue. And in terms of parasternal long axis view, this is what you would find, the conjoint proximity of aortic or semilunar valve leaflet tissues. In septal malalignment, you may have inlet outlet malalignment. In this case, we have an atrial septum and ventricular septum malaligned with some straddling of the tricuspid valve leaflet tissue. Again, I've plotted in the conduction bundle. It's veered to the right side of the right atrium, or atrioventricular junction. And just to finish off, we can see that the membranous septum itself is very small in this right ventricular and right atrial right ventricular aspect. We can see that the membranous septum is crossed by the insertion or hinge line of the tricuspid valve, dividing it into an atrioventricular component and an interventricular component. There are terms such as Gervodi defect, which means that it's supposed to be a defect precisely at the site of the deficient atrioventricular component of that membranous septum. But in most cases, in more recent decades, the description of Gervodi defect applies to this sort of configuration, which is actually a kind of perimembranous VSD accompanied by some deficiency of the leaflet of the tricuspid valve. So some distinction between these two. So I think in summary then, location, number, size defects, margins, proximity to important structures, all very important, and of course associated malformations in each particular patient. And not to forget that holes can have different shapes and sizes on right ventricular and left ventricular aspects. Thank you very much.
Thank you, Su Yan. Wonderful talk. Brilliant elucidation of the anatomy. So we'll probably skip questions if that's okay. They can ask you in the break. Oh, I think we're well behind time as usual. So anyway, it gives me great pleasure now to introduce Trong Phi Lee, who's going to tell us about how he does a standard procedure in 8 minutes. Thank you.
Dear colleagues, I'm very happy to be here again and happy to have the chance to share my experience with you concerning device closure of VSD. First slide, please. Okay, we all know that device closure of VSD is one of the most sophisticated procedures in our daily work. So I think it is important to listen to Professor Yen Ho to know how complex the heart is. So we are closing VSD using catheter technique, and how can I move? And it was my first VSD closure. It's a long time ago. That's at the time the Amplatzer ASD occluder just came onto the market, and they used 2 devices to close post-surgical zero shunts, you can see in this case. But today we have a wide range of occluders, and some of them are specifically designed and developed for VSD closure. But however, we have a lot of devices and occluders. I think the right choice of the occluder to implant, to use, is decisive for good result, acute result, and long-term result. This is very important to keep it in mind. I think the preparation is very important for the rest of the position in my practice. And in many cases, we need the arteriovenous loop, and it is not always easy going. So I like to spend more time on this issue. You can see here that it's a loop wire, but you cannot use it because it was entangled with the moderator band. You can see this. And in the other case, the course of the loop Y is okay, but the Y have been pushed through a small mesh of the tricuspid valve apparatus. So we cannot advance the sheath. So we cannot use the loops here in this case. So I think there is a rational and effective way to build a safe loop, AV loop. So my material list is quite short. I need only the pigtail, normally. I need the J-tip soft guide wire, a long one. Of course, I need a snare system. And first, I advance in-hole balloon catheter or a pigtail catheter from right ventricle into the MPA. And I replace this catheter by a snare catheter and leave it there. Yeah? So on this, by doing this, you can avoid crossing a small mesh of the tricuspid valve apparatus. And you can see how easy it is to conduct the pigtail catheter from right ventricle into the upper artery. It's very easy. So then you exchange the catheter against a snare catheter, can you see here? And in majority of cases, we can use a J-tip pteromer guide wire to cross the VSD. Of course, you need a very good profile on angiogram to see the defect. And as soon as you cross the defect using this wire, you can conduct the wire directly upwards to get into the MPA. It's very important because here is the motor band. So if this maneuver is not successful, you keep the guide wire far enough in the right ventricle and you move the pigtail slowly over the wire just to enter the right ventricle. And as soon as you carry free pull the guide wire back, the pigtail will straighten up and conduct the wire directly into the primary artery. So I don't snare the wire in the vena cava. I snare the wire only in the MPA. So if big snare waiting in the primary artery, the wire cannot escape. And by using this technique, I have no problem at all forming a V loop. I think it's very important if you need a V loop to practice like this. So we are closing restrictive VSD. And I think all VSD have more or less pronounced conical shape. Or you have a sac, like in perimembranous VSD. So my conception is to see the space, very well, and to fill the space with the device, to close the defect effectively. So you see here, how can I, so you see here the base of the defect. You see here the exit. And in the muscular vis, you can see here a nice cone shape. So I would like to fill this space with the occluder. So according to the closure mechanism, I would differentiate between two types of devices. The one is a standing device. With this device, you try to safely anchor this portion of the device into the defect. And this is normally difficult to avoid overspending because you like to be very safe inside the defect. Here, this is another one. And in my practice, I don't use this device if the margin of the defect is fragile or if the defect is located near the structures of the conduction system. I don't use this one in my practice. The other type of device of occluders is the non-stenting one. You can see the non-stenting occluders have a small flexible part. And to close the defect, you have to take care of the maximum diameter of the device on the left side to cover up everything. And that is the difference to the stenting occluders. So if the defect is not very big, like less than 5 millimeters, you can go this way. That means anterally. In this case, you can see there is the ALO2. And according to the conical shape of the coil, you have to place the coil using the antegrade approach. You can see here the windings are configured in the ascending aorta, and you pull everything back, crossing the aortic valve, and you can see that the device turn the position to get into the defect. And the pressure gradient will stabilize the coil inside the defect. You can see in this very nice example. This is a perimembranous VC with multiple perforations. And you can see the diameter of the coil corresponds to the largest diameter of the sac. And you see the remaining perforation will be closed if you have you succeed to place the coil like this way. And this is another example. This is muscular VST, also with the cone shape. You can see that the coil adapts very well into the defect. There's only 1 or 2 loops on the right side. So similar to coils, in our practice, we implant the arm plaster very similarly. That means we open partially the left ventricular disc in the ascending aorta, and we pull carefully everything back. And as soon as we cross the valve, the aortic valve, we expose or we push the whole disc out. And it is much easier than to do it in other way. And in infants, if the indication is to close using a device, I prefer the jugular approach. I don't use the transmitral approach anymore because there's a large risk of impairment or damage of the mitral valve, because you can see the delivery cable is quite stiff. I don't use it anymore because some of my patients had some mitral regurg afterward. If you leave residual shunt behind, you can end up with mechanical hemolysis. Of course, this could disappear if there is no shunt anymore. But in my practice, I think the miscoloration of the urine is very frightening to some patients. So I try to get complete closure in the cath lab. Yeah, so you can do this if you don't succeed to close the defect completely with one device. In this case, you can use an arm plaster to finish the work, or you can use a second coil, because I need to see a complete closure in my cath lab. So we are closing also VC with aortic valve prolapse. And you can see here, because of the anatomy, you cannot cross the defect using other techniques, but only with a cut pigtail. You can see here, because the defect is very low, very close to the aortic valve. And if you do an angiogram, the shunt can be misleading. You can see a very small left to right shunt in this situation. But you have to place the long sheath in crossing the defect, and you can see that the prolapsing aortic valve will be lifted up, and you can see the real dimension or the real size of the defect. And if you decide to close such defect using a device, it can only be a non-static device, in my opinion. You can see here to example one, in one case, we use the coil, in another case, we use the ADO2. And that means you have to use the integrate approach in such cases. So two things I like to mention. Normally, you don't need echo for the whole procedure because you can see almost everything on the screen on fluoroscopy. But before you detach the device, you have to look at the AV valves, especially the tricuspid valve, because it's the only way to be sure that the valve is functioning well. This is mandatory. And no device is free from EV block. No device is free from EV block. So, but I think that if you use an oversized device, which is stiff, I think the risk for development of EV block over time is maybe bigger than if you use a flexible one. And if during my procedure, EV block occurs, I stop the treatment. This is also part of my standard procedure. Thank you very much.
Thank you very much, Trong Phi. If you have a seat, I think we're going to go live to Thailand now, who are keen to show a live case before they go to the airport. Hello? Hi. Hello? I think this is the video. Yeah, no, they haven't. I think we're just seeing the promotional video. Without the soundtrack. Hi. Warwican?
Hi, so welcome back to Queen Sirikit National Institute of Thai Health. This is our third case for today. So I would like to introduce the team first. So on my right-hand side is Dr. Warwican, and we also have the Dr. Man from Ramatipati Hospital join us from today. And also we'll have Dr. Pai from PSU Hospital join us today. So next I would like to introduce Dr. Art to present the case.
Thank you, Dr. Sisi. Good afternoon, everyone. My name is Art from the concept of pediatric radiology. Hello. I will start the third case at Quickness. So the third case is a 15-year-old Thai male. He was diagnosed with double outlet right ventricle and underwent total correction with transnasal with no cut valve in 2014. Now he has NYHA personal transfer with no familiar medication. His ECG was shown normal synaptic with complete right abdomen block. His QI estimation was 186 with no QS fragmentation. His echocardiogram showed right ventricular enlargement, moderate to severe pulmonary regurgitation, and no accelerated flow at complete valve area. There were also good flow of PA branches without any obstruction. The left ventricular systolic function was there. The LVEF was 50%. Normal RV systolic function and CAPC is 18.3 millimeters. The 3D echo was done to evaluate RV volume, show RV EDVI 141, RV VSCI 74, RV EF is 47%, and RV EDVI 90. The cardiac MRI showed moderate to severe PR with regurgitation fraction of 42%. RV EDVI was 124, RVF 46%, and no RV penetration, MPA dilated stenosis. We have done the three ratio from ECG-gated CT shows tubular shape of the alveoli and no PA obstruction. The laterally artery from the reconstruction was close to the communicable annulus with C5 balloon interrogation to evaluate the compression. The MPA angiogram in iocrania and lateral view shows severe pure and no coronary artery dilated stenosis. There was no LV to PA gradient. The measurement of the distal MPA was about 19 by 24 millimeters, with MPA diameter was 20 by 21. Proximal MPA was about 22 by 24 millimeters, and the alveoli was about 28 in lateral view. Then the balloon interrogation simultaneously with RV angiogram using TX exciting balloon 30 millimeters to complete occlusion of the alveoli. There was a weight just above the terminal wire. The measurement of the alveoli was approximately 22 by 24 millimeters, and the width MPA was about 25.5 millimeters. This is an aortic root angiogram with no aortic root or no pre-compression. We put the balloon higher, and there was the second weight at the second sternal wire, and the measurement at the previous low was 26.7 millimeters. Then we exchanged two legs from my X balloon, which was close to HD sizing balloon 34 millimeters. So one wedge at the annulus and the second wedge at the second sternal wire with the similar measurement. So the next, we are going to the trimethyl. Dr. Francis?
Yes, thank you. If we can our vessel navigationที่นี่นะครับ just a quick review on that. Unfortunately, for the CT, you couldn't see the coronary artery well. Mongไปที่ IO ครับ IO. Yeah, just to have a look on this. This is kind of a typical view for the alignment. See the long, longitudinal axis of the NPA, which is actually fine. But when you go for IO cranial ครับที่เซฟไว้ครับ Yes, and this one you can see the annulus is somehow relatively bigger than what you see from the RO view. Lateral cut. Yeah, also lateral you can appreciate that it's much bigger compared to the RO view. So we know from the conventional things and also the vessel navigation that the working view for this particular case probably you want to see the largest diameter of the annulus. You probably go for the cranial and also lateral view. Now, this is this.
Okay. What we did for today, the first one we did is the right femoral vein angiogram, which is show that we have very nice, huge patent right femoral vein with the measurement of 15.5 milliliter.
But Warwican, it would be fine. Warwican, it would be fine for venous valve anyway, wouldn't it?
Yeah, of course. Of course, definitely. But it's different case also. We thought that a balloon expandable valve should be fine too. So that's why we would like to show also another option of the DPVI.
From the
Kevin?
balloon echolocation with the epic load angiogram show no epic load compression and we're not sure about the LAD. So we change to selective left pulmonary artery by doing the balloon. So the first one not good engaged. The second one we are not well seeing the ADP flow. So any suggestion on this particular picture?
มันไม่เลื่อนนะครับภาพเลื่อนไหม Can you see it moving? Of the ceiling?
No, we can't see it moving at the moment.
อ่าภาพมันค้างนะครับ
Yeah, now we see the coronaries, yeah.
Kevin, just to share with you, this is quite tricky part for us as a field cardiologist because we engage that quite nicely and we're quite happy, but unfortunately the RAD is not specified well. And that was quite difficult for us to say whether any compression possibility or not. Also because CT is not very clear. So luckily we have MAN. So what MAN taught us is actually the RAD is coming anterior, right, man? So can you share with us how you can delineate both RAD and circumflex in that particular system?
For adult cardiologists, we do lots of coronary angiograms. I think part of it is that the curve of the catheter may be a little too long, so it points to the circumflex more. If you have, this is a 3-5, right?
Yeah.
I think if you have a 3-0 might be better, but I think it depends. This one had a very short left main or even almost separate upstream of the OSD insert. And I think if you just push it forward, it will point towards the cert. But the area of interest is actually LAD, so we will just add a minor manipulation of the tip of the KL. Maybe you can show the picture.
Okay, we see it now, yeah.
A little bit better. Yeah, and the next picture. Next picture.
We try many times to get
Man doesn't come in that time. He's not coming in that time.
Okay, so you can see
Very nice.
of the selective LED angiogram with the balloon testing, and we are quite confident that the coronary will not be compromised with the PDI in the meantime.
Yeah, so I think that's all, right? What we would like to show. So the question for you probably will be like, in fact, the balloon expandable, okay? So as Kevin said that we can do any kind of valve, but
Yes.
today we're going to focus on the balloon expandable, so please.
I have a question first. For those who are implanting pulmonary valve, is this an option to do a high flow angiogram of the aortic ascendens or aortic curve using the lead back angulation to see clearly, the anatomy of the coronary arteries instead of having a lateral or AO view. You understand me?
Yeah, no, we often use maybe this spider view or LAO caudal to try and see it. But in the tetralogy, it's a bit more difficult to predict. But often an aortogram is enough rather than selective. And particularly if selective ends up being selective down to circumflex.
Yeah, I think we feel the same that the aortogram is the first way to use it. But in this case, with the aortogram, we could not see the LED very well because I think the advantage of the aortogram is also to assess the LEU compression. And
Yeah, thanks. Can I just, I mean, it might be a little bit more of a nuisance, but what we are regular now is to look at the CT scan carefully. If qualitatively and semi-quantitatively we're happy that the coronary artery is miles away, then we don't worry about it. If there's a concern about the coronary artery, then we'll do a single plane rotational angiogram and look at how the coronary interacts with the balloon dynamically during a rotation. And we find that very, very useful from the point of view of getting a really true 3D understanding of where the compression might be and what the problem is. But the majority of cases, when we look at the CT scan, provided the CT's been done properly, we're able to say this coronary artery is not going to be a problem, and then it takes 30 minutes off the procedure and stops you worrying about something that's a distraction.
Yeah, I agree, Gareth. It's hard to want to do these sort of valve procedures without having a CT scan done beforehand. Okay, carry on.
So now we decide to use balloon expandable valve with the wedge measurement right now 24 by 26 millimeter. So what kind and which size of the valve that you think is suitable for this patient?
Well, I think at those diameters, we probably go, if we were going to do just a simple short valve, then a 29 Sapien 3 with maybe a little underfilled. I think once you have a 26 millimeter measurement, I don't think we'd go with a 26 valve.
So for today, we plan to use my valve implantation. So next, I will ask Dr. Pipe to show you the valve.
Thank you, Dr. Z.
Could you zoom in, listen, and show the slide specification, please?
For the my valve, at first we will see that the leaflet is have a side leaflet that came from the mobile polyclinic. So it has a good function after we implantation to the patient, have less overall regurgitation, and hopefully we think that in long term we have less of the evident endocarditis. And for the flares, as you see, we have the honeycomb appearance that have combined with the proximal part of the cross cell that have increase of the little pores and the distal part of the open cell that have more flexibility. And the material that create the frame is the cobalt alloy that is increase the little pores and easily see under the fluoroscopy. For the size of the valve, for the my valve have a lot of size that available. It is smaller 2032 that increase 1.5 millimeter for each of the increments. The last is the delivery system that is very soft and easily passed to the public anatomy of the patient. So now, Dr. Pitti, can you explain about your procedure now?
Okay, thank you. So what size valve is this you have?
So we now have 29 valve.
And do you use rapid pacing for the deployment? What diameter sheath did you use to deliver this valve? Did you use a dry seal sheath to introduce the valve?
So my valve has their own sheath.
Okay.
So now we use the 15 French sheath from their company.
15 French.
40
16. 14 French.
14 frames for all valve sizes, and the valve is already crimped on the balloon. Now we in the RVOT position that is above the landing zone. Can you show the angiogram of the RVOT? Any EP can show that where are we landing or what's the target point?
The target point is the annulus area, which is we want to be one third below, I mean quite close, I mean the lower part of the valve, just below the monocut valve area.
And the third center wall, right?
And the third
Can you make
center
sure
wall.
the video is moving so that the audience can see?
Yeah, if we can see live fluoro.
PO is not moving.
Yeah, it's still at the moment.
Are you still right? Yeah, we'll make it, can we make it moving?
Okay, we can see now.
Can you guys see where the water cut is?
Sorry, say again.
It's pretty much, can you see the motor cut?
Um,
At the tip of the pigtail, right?
okay, yes. Yeah, no, we can see that. Yeah, so
I think we can use that as
That's a landing zone. So, yeah, anchor point. So now we above the landing zone and we try to inflate the valve first a little bit and then do the angiogram and then adjust the position of the valve.
โอเคนะที่ขึ้นตรงนี้เนาะก็ครับอันนี้คือผมจะใส่เต็มถูกไหมเราท่าทีทีก่อนนะ
so you're going to make a dumbbell and then just pull it back into position.
Yeah, exactly.
Yeah.
Okay.
So I say the balloon and we manipulate this, okay? Right? 5 cc, 25 cc นะนะครับนะครับ
Okay, we see that.
Angiogram, please. Yeah, angiogram. Yeah. Okay.
Go down a little bit more.
I think we're quite all right. Just inflate a bit more.
ผมขึ้นอีกข้างนะครับอันนี้เป็น20ครับ60ครับ
Okay.
You-
Very good. Okay, keep
ตรง
going.
นี้เลยนะไปก่อนเลยนะโอเคไหมโค้ช
ครับลงมาได้เลยนะ
ขึ้นมาเส้นนะขึ้นครับขึ้นหมดนะครับ
ลงมาขึ้นครับครับผมได้ครับขึ้นก่อนครับ Yeah, thank you.
1 2 3 4 5นี่เสร็จนะครับ
Okay, very good. Did you go all the way? So nominal, right? Okay.
Yep.
You take it. Okay, good. Okay, I think we get into the intention position. What do you guys think?
I mean, it looks very good. I must admit, I would have placed it lower, but it looks very good.
Yeah, so actually I've learned too, Kevin, that this balloon cycle valve somehow, when it's flat instantly first, and like the balloon, when it's flat, it will push the valve down a bit. So that's why you aim a little bit high, and allow the balloon to flare more, and then you try to adjust by pulling back just a bit. So that is likely to be in the right position.
Chair, please.
Very stable. I think
I mean, it was a very tubular structure.
But you see, there's a gap between the valve and the MPA distally. Would that be okay for you? Yeah, on lateral view, you see, looks like a flare. I mean, distal valve cage is somehow slightly larger than the MPA there.
Yeah, it sort of created its own shelf to hold it in position. Gareth, go ahead.
Yeah, I mean, Warwick and CC, this looks great. Your final result looks really great. I think there's clearly a difference in the way you deploy this valve compared to an S3, because I don't think anybody would deploy an S3 the way you did this, but it's very interesting that this worked out beautifully. Do you have any comment? I mean, obviously this is an S3 valve made somewhere else. There's some rumors about the fact that the leaflets haven't held up well in the long term. Do you have any experience with early degeneration, and are you worried about that? Even though it's obviously significantly cheaper than the Sapien, are you concerned about that?
What?
Okay, we have another question over here. Just a second. Go ahead with your question.
No, actually, we got the large experience of MyVal, 5 years of data. So far, we have about 90 valves deployed. And as we see the good results, actually, the larger valves, more than 24.5 up to 35, have shown that good results. The smaller the valve, there's a sort of, you have a residual stenosis happening. Hi.
Okay, thank you for that. You're going to show us the final showing us the hemodynamics.
Are we the end gradient after deployment? Yeah, there's no significant gradient. So next we'll do the last angiogram.
Okay, go ahead and show us that. Yeah, it looks perfect. Well done. Congratulations. So, yes, so thank you very much. Well done to the team, and I think you're probably going to make your flight now, aren't you? Great. So we're gonna move on with the. If you've got done all you need to show us, we're going to move on with the lectures then. So thank you very much to the team, and thank you for wonderful cases. Okay, look forward to that. Okay, thank you very much. Bye-bye. Yeah, so we're gonna I think if that's, let's just see. Yeah, I think we'll try and get a talk in before we go live. So Joachim, Miro, will you come and tell us about your problems with VSD closure in your practice? Thank you very much.
Can I have the presentation? So while they put my presentation.
Can we put up Joachim's slides, please?
Oh, I have it here.
Oh, we're going to go live now, are we?
You're going live?
There's Dr. Tin. Are you you're ready for us, are you?
we see that very well with the color, like so. And then when we measure that, we're getting about 3.5 millimeter size. So here in the angiograms, if you can show the angios as well. Let's see if we can get them.
Basically, see into the angiogram.
So Sal, Sal, do you think there's much cusp prolapse?
Sorry, if there's do you think there's prolapse? No, I don't think so. No, she doesn't think so. There is a little bit of override and a little bit of malalignment of the septum, but I don't think the cusp is prolapsing. And this is showing again, this is the angiogram. You can see the small, it's like at the mouth is around 5 millimeters. With a length 4.6, it's very close to the aortic valve. This picture you can see better on the lateral. And then we can see next how like seeing the stipple across the VSD and then snared from the PA side towards the and externalized the terminal live wire. The tricuspid valve looks very good without any more replication, so we know that we're clear from any of the proliferations from the tricuspid valve, and that's where we are at the moment.
Okay. Yeah, we have one question from Elizabeth.
Yes, Dr. Tien, this is Bezad. I think that in the pictures that I see that we have some degree of non-coronary cause prolapse. And on echo, as I see, that the VSD, as was told, it's 3.5 millimeter, but I think that the exactly VSD is much more larger and is more covered by the prolaptic cusp. It may not so prolaptic in the pictures on echo, but on angio you can see that it's completely prolaptic. But what is the most important thing, that the VSD is covered by the prolaptic cusp, and so the exactly size of the VSD cannot be measured in this way, I think. And you have no any degree of AI in the pictures, in echo pictures especially.
Yeah. Chen, can you give some comment on choice of device again between ADO2 and MFO?
Dr. Lee, I want to add something else. On the first angiogram, the size of the LV and the size of the heart is normal, it's not enlarged. And before everything, I want to ask you have no AI, and you have no, the children is 12 years old. And I want to know, is there any indication for the closing of this kind of ESD at all?
You like to comment on this, Tin? Yeah, I agree. Yeah, Tin, can you give some comment on the choice of device again? If you use a FMFO device, how should it look like in the defect? Yes. Mhm. I think we don't have enough space on the left side for the MFO. I think I would go forward to use the 802 only, or the coil, but I think you don't have the coil in the room.
Tin, I had a question. Tin, if you look at the echo, you can see that the cusp of the valve is not normal. There is, we know that it's not completely prolapsed, but it's not of a normal shape. Wouldn't you worry, or what is your experience from last many years, that if there is a metal sticking to that valve, what are the chances that we will iatrogenically produce aortic regurgitation in the long term?
Can you show us color Doppler? Yeah, this is small.
Tin, the sheath is almost closing the defect, so it's really small. Yeah.
So, but I think in this case, the size of defect is not important. I think over time, aortic regurg could develop, and I think it's indication to close.
Yes, so we're hopefully stabilizing the aortic valve long term, but we're doing it by putting metal on a significant proportion of the leaflet. So it's a bit of a leap of faith, isn't it, long term?
Yes, but it's a very soft device, the AO2 Oracle.
Yeah, can we see echo from Sal as well, please? Oh no, we can see it now. So, Tin, the device is 6 mm diameter and 4 mm length.
Yeah, can I ask about the tension concept? Because this was deployed from the RV side to avoid that tension, right? So this disc is free floating in its position of release.
On the left side, yes, but the right has some tension still that this is pulled by my cable.
Right, but you were commenting on the disc on the aortic valve. That will not be affected by releasing the device, will it?
I think
Really,
a good.
hate to say it, but you have more shunt now.
No, I think it's better to look at echo because you have a lot of pressure if you do angiogram. Yeah, on echo there's no shunt. Yeah, I think.
Can is the pigtail catheter still in the?
Can you please move the
remove
color
the
to
pull
right
back the
front?
pigtail catheter?
Yes, I think there's no shunt at all. This a flow between the disc, but it's no shunt. But then, is the pigtail still in the left ventricle?
So I think this is for me this is very interesting because obviously technically that was a really beautiful device deployment, very interesting to watch from the point of view of how you got it across and stabilizing the LVOT. But it's difficult. I work in a very different environment to you do, Tin. But I think that you've got a disc that's riding up along the leaflet of the aortic valve that is moving along the aortic valve, and you have AI where you didn't have AI, and I just struggle with this from a concept, from the point of view of comfort and leaving the device there.
Tin, I want, Dr. Tin, I want to add something else. You know, the concept of going for this procedure in this kind of patient by you was that you want to support to prevent the future AI. In this concept, you have to support beneath the leaflet, not up on the leaflet. So if you want to support this leaflet to prevent the future AI, you have to do something beneath the leaflet on the septum, not on the leaflet. So in this view, I think that sometimes if you want to go, you went to ascending aorta, descending aorta. Sometimes it's much more better if you have this concept to go inside the LV and pull it back and go all the part of the except the disc of the LV disc and the stent and also the RV stent in the RV side. I think that's maybe it works much more better.
So Tin, you're happy enough from your experience that this is going to work well in the long term?
I think the concept of this kind of treatment is you give some the leaflet or the aortic valve some support. Yes, that means I think we can accept this minimal aortic regurg with support of the aortic valve, rather than waiting for for possible development of a real aortic regurg in the future. I think we can vote.
Or we can, if you, oh, go ahead.
We have one comment.
Go ahead, Amal.
Yes, hi, Tin. This is Amal. You know, for the past 10 years, we have this discussion each time you close one of these small VSDs and the same questions rise up and you don't answer them and you just go ahead. So what happened to your patients over the same what Kevin says, over the past 10, 15 years? Why don't you show us some of these patients 10 years later? What happened to the aortic valve? What happened to the aortic regurg? So we are convinced, all of us, and we go ahead and do the same. Thank you.
Yeah, I think talking as a situation really created in Vietnam, we expect to say in 2005 and almost 20 years. We studied our PhD with BFM course and IDU2 until now, the first patient until now more 20 years. And really, we have just one or two cases with aortic regurgitation. New onset regurgitation, but it happened very soon, immediately in the platelet, and we see the mortality not acceptable, and since we remove the device and we change the surgeon. Some cases not aortic regurgitation, not due to the device, but due to the technique. During the procedure, at first, my technique is not so good, and I use detail and first and something like aortic regurgitation. After putting the device, I remove the device, IR still there. And but out of my follow-up, I don't have any cases. No further long-term IR after device closure.
Yeah, at this point, I'd like to ask Dr. Wong, he's waiting for his opinion because he has a lot of patients with VSD, with aortic valve regurg, and he has closed a lot of them. Please. Wong.
Yes, thanks. Thanks, Dr. Ling. Actually, we started our first case back in 2008 with Dr. Lei, and that was a very large one. And that boy is now 17 years post device closure, and it's actually doing very well. The other thing is that, like Dr. Tin's case, we actually, most of our outlet VSDs, we actually use the PFM coils. I still do. I still much prefer the PFM coil to the rest. But anyway, in our follow-up, in our series of 107 cases in Kelantan alone, we only had 3 that required surgical removal. And it was because of the device still rotating, actually the PFM coil is still rotating within it and catching part of the aortic valve with a loop. So they modified it and curved it in. Of those, 2 were like that. And 1 was because I undersized it. I undersized it thinking that, we can do it like the surgeons, but obviously we cannot.
Thank you.
Great. So, Tin, are you going to release it? Because I think Malaysia are standing by and want to show us a PDA stenting case in a small baby.
Tin, can I ask one quick question before you release? Any degree of aortic regurgitation after device closure, when there wasn't any before, is unacceptable. What is your experience that after releasing this device, would it still stay? And because we can see, although it's a trace AR, but there is an AR which wasn't there before we had the device there.
Dr. Tin, just Muthu here. We have about 200 cases of similar cases presented here, 6x4 device. And what we, in our experience, have done is we undersize the device also. It's only 3 mm to 4, what we measured. You could use in a 4x4 device also. This disc is slightly protruding into the aorta. You can see trivial AR. When you release it, the AR will get worse. In our practice, if the AR gets worse after release, we send for surgery. We don't send them home with an AR. So,
thank you.
Jin, before you release, what is contradicting against to pull it a little bit more to the right side, 2-3 millimeter more? What is your concern to do it? Do you think so? I don't believe it.
I think there will be no effect because we don't have so much space on the left side. And we have to accept this or not. But I think, Tin, you should decide yourself.
Tin, can I have one question?
Yeah. Okay. Can you zoom in the echo, please? Show the echo, big, color. Can we see the echo big and fluoro small, please? Can we see the echo, please? Yeah, it's a bit more. Let me forward.
Tin, this Ponte. You also have the case of PFM coil to cause the defect like this. And I think for the PFM coil and ADO2, you have the same concept, but very, very soft disc. Sit on the aortic cusp. Can you compare the outcome of the PFM coil and ADO2? Is the same, I mean that no AR or very, very small case of AR.
Okay, Tin. Yep. Thank you. Maybe we'll try to move on to Malaysia if they're ready. So thank you very much to your team. Well done. Really interesting case. Case. Yeah, if Malaysia are ready. Here we go. Hi, I'm Asni. How are you? Fine, thank you very much. So we've Trong Feed, Maseed. Oh, we have a bit of an echo, a bit of a delay. So we'll let you talk.
Good afternoon, Kevin, Masood, and Conrad. And let me introduce my colleague, Mr. Ali, here, who's next to me. He's doing the main part of the procedure. Tisha, chief of the department, and our fellow, Calvin. And I think initially what we wanted to put up from this session is the IDS for heart operation, but unfortunately it's not incorporated because the procedure still has a very big PDA infection. And so we are substituting a patient with an Epstein who we think requires additional flow to the lungs by big extension because I think if breakthrough sinus when the prostate is taken out, and a part of it is probably involving functional from the stimulation is getting better, but we don't know when it's going to get better. So that is why we put it up for the video extension this afternoon.
Okay.
Presentation by author.
Okay, thank you. Yeah, we can see the slides.
Okay, morning. Go ahead with the presentation. Okay, so hi and good evening, everyone. I'll be presenting the third case. This is a baby girl, 5 to 4, with a weight of 2.8 kg and a body surface area of 0.19 meters square. So was born at term, SFAT, with normal delivery. Had cyanosis at birth, was started on prostaglandin, and the echo confirmed the diagnosis of FC anomaly with the PGA. Prostaglandin was tried to taper off, but we could not do it, and baby developed issues of desaturation and distress. So currently, baby is on 8 nanogram per liter per kg per minute of prostaglandin. On examination, mildly cachectic with cyanosis, and the saturation fluctuates between 75 to 85%, and you can hear a soft, very soft, continuous murmur. This is the ECG of the child. It shows the right atrial dilation, tall period, and the rhythm of sinus release. X-ray, you'll be able to appreciate its right atrial dilatation with the beginning plug B. So these are the few of the clips of the baby, and the first clip on the left clearly shows that the septal region of tricuspid valve is apically displaced with intra-atrial septum bulging towards the left LA. The second view, the middle clip, shows you the RBOT view, in which you can see the anterior region is more towards going towards the RBOT, and there is some poor expression in the across the pulmonary valve. Third view, you can see the regurgitation. So this is the left side view clip shows you the ASD shunting right to left, and you can see in the short axis the pulmonary valve. The pulmonary valve size is about 6 mm. The B score is minus 2.28. It's showing some power flow across the pulmonary valve, and you can see a small PGA also supplying the pulmonary artery. So these waves show, the first one, the left side one, shows you confluence on pulmonary artery and the PGA flow going towards the left pulmonary artery. And this is the arch. You will be able to appreciate the PGA, which is originating in the proximal part of descending aorta. It's a straight type of a PGA. Width is about 2 mm around, 2 mm. So our diagnosis is the 30% FC anomaly, and we are planning the PGA extension procedure. Thank you.
Okay, thank you. Yes. I mean, it's surprising you didn't manage to wean off the prosin because there seemed to be a good bit of antegrade pulmonary artery flow. So maybe it's the pulmonary resistance. Did you use sildenafil or anything like that in the meantime?
No.
Okay.
Yes, that's the surprising thing because I was expecting that there would be much of emphasis flow, but
So where are you up to?
yeah, we done the EEG. Can you see the angiogram?
Oh, Dietmar, Masni, Dietmar has a comment.
No, question and comment. What is the current gradient across the PDA? Did you, Masni, okay. What is the current gradient across the duct?
What is the gradient across the duct? Yeah.
Or in relation to the tricuspid rigor?
It looks like it's a continuous flow. It was
And did you use NO for testing the pulmonary system? Okay.
Oh, I know.
Okay, okay, okay. Nee, I want to know before you stand it to make the decision. It is clear. I think you have to do it.
Can I ask a question, Dr. Masni Muthu here? The echo showed some PR, right?
Okay,
Pulmonary
so-
registration. Echo showed some, so I'm just wondering, if small PDA, you have pulmonary registration, you're going to open up a PDA, you will create a circular shunt, like, you know, it's going to PR, a TR, and you got a PFO. So it will create a more of a problem, I think, if you put a stent now here. I think, you know, we need to manage with nitric for some time and see. That's my opinion, because if PR is already quite significant echo, you're going to put a stent across, and then a TR, and it'll cause circular shunt.
Kevin, we need to move.
Yeah, we're sort of we're way behind, so maybe we'll just hold the questions a bit, and you tell us what you've done and are about to do.
Okay, so these are the angiograms that preliminary angiograms that we fail. The PDA, as you can see on the lateral, that it has a mass central, it comes off from the descending aorta, and at the tip, halfway down, because the dominant tip is very constricted, PDA is curvaceous and very acute, and that will be the challenge of trying to cross the PDA. The dominant artery close to the PDA is not long, but still you can see some contrast going across, and there are some small collaterals that have been developing.
Okay. So, Masni, how far have you got? Because we just need to move you on faster.
I've got the wire. I'll give for this one. Crossing the wire. It's quite good method because this is a very conscious method. And we use the softest part of the wire you have, the roughly copy of 1 gram in a kilo. And after a bit of stimulation, managed to get that wire across into the dominant. And that's it. So that's where we are now. And I think they've got 5-frame graft connector for the stent. So we are almost there. Just a matter of putting the stent onto the wire and delivering it into the PDA.
Okay, go for it.
You can see the pictures. Yeah, let's go. So we are using
He hasn't told us the length diameter.
3.5 millimeters diameter shoulder diameter, and the length of
12.
Okay. Right. Keep going, Masni.
The PDA measures about 10 millimeters from aorta to the pulmonary.
Sorry to speed you up, but we're going to miss dinner as well this evening. Yeah.
So because this is an exercise normal non-involved, so the wire goes right into the heart. No, on the three pictures that we have, with the wire across the sorry, with the wire across the two picture. Roadmap. Yeah, please. You okay? Okay. Now, roll. Contrast, sorry, contrast. No, contrast.
Okay, a bit too far, isn't it? It's just a little bit more in the aorta than it should be, but you have to.
Yeah, maybe a tiny bit more into the PA.
Yeah.
Ready to do so? Okay.
She hasn't had lunch either, has she? Okay, Mazni, if you could do an angiogram, and hopefully that should be the final bit. Aha. Yeah. Sorry? Yeah, so have you got an length of 8 or not? Because the pictures you showed suggested that the initial length selection was not adequate. So that's where this reliance on straightening the ducts doesn't always work. Joachim, brief comment and...
Yeah, what's the saturation of the patient now? And personally, I'm not sure this patient needed a stent, so I would leave it like this and let it stenose. And I think this patient will have enough forward flow.
Yeah, I think that's... yeah.
This patient will develop, you know, as the resistance comes down, is going to develop more for. I don't think
that's a reasonable option, I suppose, rather than embolizing this current stent. And if you get a few weeks out of it, that may be good. But to me, that stent looks a bit too short.
Yeah, like it's probably missing both the pulmonary and aortic ends. So maybe just measure there, and maybe it's a 15 that's needed. Just go straight in.
Yeah. All right, Mazni, what are you going to do? And then we can cut away from you. Yeah, very quick. Okay. So why don't we come back to you when you've made a decision, and we can carry on with the lectures?
It was Joachim's lecture that we interrupted for the valve from Thailand.
So Joachim, a briefer lecture than before. Let's put Joachim's slides on, please. Can we disconnect the transmission and put Joachim's slides? Yeah.
See you.
We'll come back to you later. Oh, there we go.
Okay, okay, thank you. So thank you, all the Vietnamese friends, for this invitation. It's always very interesting. They asked me to talk about problems in VSD closure in my practice. Oh, okay. That's not. Can you put presentation mode again? Okay. Sorry. Okay. How does it work? Okay, here it is. Sorry. Okay, so my 3 problems that I want to discuss is finding patients in Canada, getting access to dedicated devices for VSD closure, which is a problem in Canada, and technically avoiding AV valve damage when we deploy devices or push a sheet. So this is very touchy. Okay, so finding Canada. In Canada, finding patients, the indications for percutaneous closure remain very scarce compared to Asia. All patients are discussed with surgeons, and the North American guidelines are much more restrictive concerning indications. And the patient either has a big VSD when he's born, and these ones are intercepted literally by the surgeons because they don't want, they want to intervene early, and the patient, has no chance to eventually close a little bit as VSD. And I must say that the surgeons do closures of VSD with excellent results, very little complications. So getting in a situation of non-inferiority for percutaneous closure is kind of difficult in big VSDs in small patients. That's a long time ago. One of my first VSDs I closed was a very small kid with a big VSD. It did work, sorry. Whoa. Well, the patient is in VTAC. It did work, but many of those patients now are rather sent to surgery or get hybrid or intervention. So percutaneous closure, we don't do it, we don't attempt it in patients smaller than almost a year and smaller than 6 kilos. I want to just show the Kevin and Damien approach, which is very interesting. I haven't tried it yet, but the carotid approach, retrograde closure, this is going to allows them to close bigger VSDs in small patients. So the other indication would be to leave the patients who are not in florid heart failure at birth. We let them grow. Many of them will close their VSD, so they won't even have an indication. Some of them at 3 or 4 years old will persist with left chamber dilation, so we would close those ones. Of course, previous endocarditis is an indication, but we don't use it as a prevention, as a primary prevention in Canada. And the prevention of paradoxical emboli is another indication, especially when patients need a transvenous pacemaker. If they have any residual shunt, we will close it, including VSDs, because as this paper shows by Paul Carey Paul Carey is from Montreal, but it's a multi-center study. Having any shunt at the heart level is going to increase your chance or your probability of having a paradoxical emboli of a twofold. And finally, there's some cases where athletes just want a VSD close. I have one teenager who wanted to play professional hockey, and he had not a big VSD, but left chamber dilation. He was an athlete, so this is normal. And another lady was doing a marathon, so both of them asked to have the VSD close, even though they were not exactly indications. My next problem is getting licensed devices. There's two ways, dedicated devices. There's two ways to get devices in Canada. Either they're fully licensed by Health Canada, but this is a very difficult and costly procedure, and Canada is a small market, so most of the companies won't want to go into licensing devices. However, once a device has been approved for any indication, like ASD, you can close it, you can use it off-label for any other malformation. The other way to get devices is our special access program, which is very permissive compared to the USA. Almost always the authorization is going to be granted, but it's a lot of paperwork, and companies, for a small market and few devices, they don't want always to put that energy. Worldwide, there's a lot of devices, symmetric, asymmetric, eccentric, soft and stiffer. However, in Canada, we don't have that many now. For symmetric devices, we have the muscular VSD that we've been using since '98, the Amplatzer ADO2 that we've been seeing today that is available since 2006, and we used briefly in 2017 some LifeTech devices, but LifeTech now pulled out of the Canadian market. For asymmetric devices, which means LV and RV discs of different sizes, we use the ADO2. We had the LifeTech until last year, and we still have, we have the Occlutech PDA, which is very useful, and again, we use some LifeTech devices. And for eccentric devices, we basically have nothing now because the initial and the second version of the Amplatzer membranous VSD device are no longer available. And again, we use some eccentric LifeTech devices, but we can't now. So what are my current choices? For muscular VSDs, as I showed you, we still use, of course, the Amplatzer VSD device, and we use the ADO2 device, which are very useful for multiple little VSDs. And I haven't used the Occlutech Longshank for muscular VSDs, but I think it's going to be a very good device because you won't have the right ventricular disc, which could which could interfere with the tricuspid. And again, I'm waiting for LifeTIC to bring back the MFO in Canada. For PMVSDs, we just have the ADO2, the ADO1 that I use sometimes, but now more and more, I've switched, more and more. I don't use the ADO1 anymore because the PDA, Occlutech PDA long shank is it's the same concept, but much better because it's longer and the minimal diameter is just, under the aortic disc, so there's less radial force, especially for the AV node. And then you end up with with no disc in the RV side, so basically it can be in the tricuspid and you won't have any regurgitation. It's available, the long shank is available up to 8-10 millimeters, and then the bigger devices, they're not long shank, but they're long enough that you can use it the same way. As I said, there's much less radial force in ADO1, so less risk, I think, for AV node, for AV block, sorry. No RV disc, as I said, and it's much better, to my opinion, much better. It has completely replaced the ADO1. The disadvantage is it's a stiff cable. The sheet sizes are a little larger than equivalent MFO devices. It's definitely stiffer, so again, for the AV node, MFO would be better. And again, if we put something in contact with the aortic valve, the Occlutech device is definitely too stiff to get into, to get into contact with the aortic valve. Cannot be delivered retrograde like the MFO could. And again, I would never use this with too close of the aorta. So I still need the MFO back, and we need to develop an eccentric device which is going to allow us to close VSDs like the one we saw before with TIN, with no damage to the aortic valve. My third problem that I wanted to discuss, we've discussed all the steps of the procedure with trunk fee, but the one that I find the most critical is avoiding the AV valves. And in my 30 years of experience, I think so most of my complications have been this. One tip is if you're concerned about the tricuspid implant retrograde, I don't cross with a guide wire. I always cross with a JR catheter. Don't push it too much inside, and then turn it counterclockwise and go directly to the pulmonary artery and snare it. Like Trunk Fee said, I never cross the tricuspid valve with a multi-purpose. I think one of the purposes of the multi-purpose is to damage the tricuspid valve, and this applies to any intervention. We want, for membranous VSDs, we really want a straight AV loop like this. And this is a muscular VSD. If you're really concerned about your tricuspid valve, you can do a balloon interrogation. In this case, you see very well that the balloon doesn't want to get into the right ventricle because the wire is across chordae. And in this case, you can see that it could easily go, it's a muscular VSD, it could easily go and even cross the VSD. Again, don't advance a sheet across the tricuspid if there's unusual resistance. This sounds stupid, but you can really injure your valve. And don't deploy the device too close of the mitral valve because you can get stuck, like in this case. And eventually I had to leave this device. I had to deploy this device because the patient was very unstable, and he ended up with a surgery for mitral valve repair. In conclusion, my practice is much less fun than my Asian colleagues. I have less patients and less devices, but even with the devices available, I still can, especially the Occlutech, I still can close most VSDs in patients larger than 6 kilos, and we need improvements, of course, to get better. This is a picture that I've been showing for years. This was in 2003, and these are my kids 20 years later. Thank you.
All right. Joachim, thank you very much. We really haven't got time for questions. If there are any questions, pick on him during, it'll have to be dinner break, won't it? Not during the coffee break. Okay, let's keep moving.
Yeah, next, Jin Young Song from Korea is going to tell about his problems of VSD closure in his practice as quickly as he can.
Thank you very much for your nice invitation. And specifically, I would like to talk about the closure of angioedema VSD in my practice. As you know well, there are various sites of location and morphology of aneurysm in perimembranous of VSD. The most important thing is if you want to close at every site, maybe one device might be enough, but the device could be close to the AV valve. But in the other hand, if you close the RV sites, you need multiple devices, and there are some difficulties in device delivery. The first case for your female, the first problem for me is it's very difficult to define how many exits in RV side that there are. So we couldn't define exactly previous to the procedure. From the angiogram, you can see the aneurysm, and the one device is not enough. I found that. And the more big device, same things, but I confirmed another significant leak. And finally, I used the two device, 81 and 82. And finally, I confirmed the no residual leak and no AR after the device closure. The case 2, 3-year female, same things, aneurysm and multiple exit. And you can see the small VSD, and we put a cocoon device, but I confirmed some leak, but I expected after the deployment. It could be appeared, but persistent small leak after the device deployment. Actually, I put another ADO2 for this patient. After all, I confirmed no residual leak and no problems afterward. The case 3, 4-year female, the same things, multiple RV exit and aneurysm. And here you can see the multiple defect with aneurysm. And I put the ADO1, only one device for this patient, and put the left ventricular disc inside of the aneurysm. I was satisfied with this figure, but afterward I confirmed some tricuspid regurgitation due to the device. The 21-year female, aneurysm and VSD. Fortunately, only one device was very enough for the complete closure. We can confirm that no problem after the device. The fifth case, big shunt with aneurysm. And for this kind of big device, I confirmed some significant leak, and I was not satisfied with this shape of the device. I tried to reposition the device, and finally I confirmed the good device position and very satisfactory shape and image. The last case is a 4-year female, the big aneurysm and VSD. One device was not enough for the complete closure. I put another device that was the vascular plug 4, but anyway, finally the big residual shunt. So for this patient, I should send this patient to the OR. The last patient, my upcoming cases, the parents want to device closure for this patient, 20 months of female. I should know if you have some idea or tips, let me know about that even after this session. So my problems in closing aneurysm VSD, it might be usually multiple RV exits, and we cannot predict exactly prior to the procedure. And we should consider one device or versus multiple devices, and we should consider as well the closing completely or almost completely. Thank you very much.
Thank you. Din Young, thank you very much. You highlighted many problems related to aneurysms in particular, a lot of points for discussion, but we'll have to keep moving.
Yeah, we move on. The next talk is by Dr. Muthu Kumaran from India. I hope there is no problem with the patients, finding patients, which we had earlier on. But I think let's hear from India, because you have devices as well.
Good afternoon all, and I thank Dr. Tin and the organizing team for contacting us. Regarding the problems in India and the subcontinent, there's no surplus of patients are available for us. funding is a big issue, and we got a huge.
Muthu, sorry, hold on. Looks as if we're back to Kuala Lumpur, so if you just, you could stay there. Mazni, can you hear us? Yeah, a little bit louder, but yeah, go on really quick. What length? 9. Okay. Okay. That's what you needed to do in the first place. Okay. Okay. Yeah, very good indeed. Good highlight of issues related to the ducts. Thank you very much. Well done to the team.
I would like to take this opportunity to thank Teen and the team.
Oh, who's this? Oh, Marisham. Yeah. Oh, sorry. Yeah, I thought we'd disconnected. Oh, you're there. Yeah, go on very quickly.
So I would like to thank Teen and the team for the opportunity to be part of this live transmission. So, and of course, I would like to thank the whole team in IBM for the support and the nice case demonstration. So, see you all tomorrow morning.
Yep. Okay, well done. Once more. Right. Let's find Muthu's slides.
Thanks, Shaq. Actually, the important problem what we have.
That's Malaysia clapping you now. Yeah. So can you speed up then, Muthu?
So basically, in India, the problem is basically we have been pushed to frontiers where we have to do a procedure by a device because the surgical cost is much lower than a device cost in the government sector. So sometimes we are pushed into some frontiers, particularly this kind of patients I want to discuss. So, quickly going through this child, 3-year-old child, 10.5 kg, trying to have VST, which they came up with. They usually come up very, very emaciated, hypertonic chest, and pulmonary hypertension. You can see a large VST. So it's more or less an inlet VST, muscular. And then if you go towards the short axis, you can see that there's no gradient, severe pulmonary hypertension. And there's also one more VST in the anterior part of the septum, just below the aortic valve. So it's a multiple muscular VSTs. There is also one more VS in between, which wasn't profiled well by the echocardiography. So it's basically a large VST, inlet muscular VST, a moderate antimuscular VST, and we are unsure of an intervening small VST in the between, severe pulmonary hypertension. And here we want to diagnostic angio, but we are pushed into doing a device closure here because of factors of all the finances involved, and we felt we could do also. So this is an angiogram showing you the inlet VST, which measures about 11 millimeters. And then we usually cross all VSTs antegradally. We don't usually cross retrogradely. We cross the VST from the jugular, the inlet VST, and park the sheath across 9-French sheath, and taken a muscular VST occluder and close the VST. And then what happened after this is, right away after deployment, there was a slight drop in blood pressure, and the TR was more than moderate, and we pushed the device in and to the trachea valve and released the device, and then the device was good. Actually, whenever we do this, we make sure that that TR is not more, but in this case we didn't have time, so we released the device thinking that we'll see what happens after releasing it. After releasing it, the device dived in and there's TR became moderate. Then we went on to close the anti-defect. The child became stable after releasing the device. Then we cross again the defect from antegradally. You can see from the femoral vein we cross the defect. It's an anterior muscular VST. We put another muscular VST device. the top, there is one intervening small VST was there, which we thought we should leave it alone. And so we closed both the VSTs, and this is the final picture. Immediate echo showed as a huge shunt in between these two segments of VSTs, the first post-op day. But child was quite stable with that. You can see that defect there, but there's both the defects are quite close. Devices are close to each other. We thought we should need to observe. After 1 week of follow-up, that VST got closed, and TR was only mild, and the child discharged. Next case again is a multiple aneurysmal septal defect in the femoral area. You can see there at least 2 major and 1 minor is seen. And again, the child is about 9-month-old baby with significant pulmonary hypertension. And 2 major VSTs are seen, one anterior, one is the inferior region. The one more small defect in between. So we thought we should close with simultaneous device closures. So we cross antegradally the inferior defect. And initially I thought I should close the defect close to the aorta with the ADO2. But when we did deploy it and see, the device wasn't conforming with each other very well. And there's a lot of residual shunt. So we took it off, and ideally we should sandwich both devices together. So I took one more, this is basically a cocoon perimeter VST devices. We sandwiched the entire two devices together, and that's the final position. You can see the devices have been sandwiched. There is no TR, and there's no aortic valve regurgitations. So in a country like India, we do face up with situations where with a lot of patients comes towards us with this sort of situation, but we can definitely manage them, but we need to have a careful evaluation of septum. You need to understand the devices in clear, which device to use where, and particularly large across tricuspid valve. If in case you have an issue, you should be able to have a surgical backup also. And choice of device, again stress, because none of the devices is universally can be accepted. All devices have got uniquely some advantages, and you should choose the device for your patient. Thank you.
Well done, Muthu, for highlighting all the problems related to multiple VSTs. Let's keep moving.
So next and last talk in this session, Fazad Alizadeh from Iran is going to tell us his problems with VST closure in his practice.
Well, good afternoon, everybody. I know that everybody is tired, but this section is always debating, practicing. Taking the time, I have no disclosure, but I have to thank my cath lab team every time. There are lots of problems and lots of things that many of you have encountered, but I want to just speak about the PMVST when mostly covered by the prolaptic aortic valve, just exactly what Dr. Teen showed in the live case. I want to show you a case that Amal asked that what happened after 15 years. I want to show you what happened and what I decide for these kind of patients. It was a 12 years old, 50 kilogram, a small size PMVST, but it was mostly covered by prolaptic aortic clasp. Size by echo was 0.45 centimeter with left to right shunt. Normal PAP, mildly LA and LV enlargement, no AS, but mildly I. So this is one of the concept that maybe in these kind of patients, I can help to prevent the more AI. As you can see, this was the case, and you can see the VST is just beneath the aortic clasp. Just doesn't work. Yes, in the closer pictures, you can see the VST, like always, going within the loop. Yeah, making the loop. And in this time, I decided to use a retrograde approach, but I knew something about the prolaptic cast, but I decided to go because it's much more easier from the retrograde. Doesn't work. Yes. I used an ADO2. It was in the size 6x6, well situated in the VSD. And as you can see, easily deployed, and just a residual shunt was sent. Next morning, this was the echo. There was no device at all. And this was what I found the next day. The device, as Dr. Tien told us, that in sometimes when we have prolaptic covered VSD by the prolaptic clasp, they usually use the soft devices, but the soft devices has also disadvantages that they may be dislocated or emboli very easily. So it was the VSD again, so it yes. You know, as it was very deep in the lung, I had to snare it, and it takes about 3 hours time to find it finally using a 0.14 wire to catch it and finally retrieve it successfully. So always you are not dead. The patient was sent to the OR. In the second case, it was a 3-year-old girl with 11 kilogram weight, moderate sized VSD. It was also mostly covered by prolaptic aortic clasp. And this time you can see it was a moderate to large size VSD. The patient was only 15 kilogram, making again the AV loop, crossing the VSD, and we tried to close it by the devices. The device that we had at that time was Occlutech PMVSD occluder. It was not successful. So the patient sent to OR once again, but post-echo showed significant residual shunt after the surgery. This is after the surgery. So this time, after 6 months, we decided to go once again to close these residual shunt. We decide to use a PFM Lee coil as it is again much softer and very easily we can use it in this situation. The procedure was very, very smooth. Everything was okay. And as you can see, it was deployed easily, but we have residual shunt again. We let him time about 1 year. The residual shunt did not resolve in a year. So after 1 year, once again, we went to cath lab. And now, approaching from the retrograde, crossing this PFM coil, and using another ADO2, the device was ADO2 5x6 with a retrograde approach. And it was completely closed this time. So, as a residual, In conclusion, choose the right patient, choose the right device. I'm so sorry because I'm more rapid speaking.
Behzad, thank you very much. Excellent final message as well. So thank you for helping us make up a little bit of time. Thank you to all the moderators and panelists. We're going to keep moving. If you need any coffee, you can go out, get the coffee, and come back in. And so it's a working coffee break in order to catch up. We're way, way behind. I'm going to ask Alison Kabalka, Omar Galal, Trongfi, as moderators for the next session, Sui Chai, John Antonio Villarreal, and Mulyadi Jer to come up as panelists. And then we will carry on. And just to request all the speakers to keep either to time or, if even better, a bit shorter. So, the other panelists don't seem to be here, but you can carry on, yeah. Yeah. Okay, Alison, go on.
Okay, we're going to just get started with the live cases and debates on PDA intervention. So as we're waiting to go live, we're going to go to PDA closure in prem babies, bedside or catheter.
Yeah. Thank you very much, Alison. I think they are going to rush me through this debate. Thank you very much. Today, my topic will be PDA closure in premature babies. I am the pro bedside or the bedside camped. Yeah. How do I move this? Okay, I have no disclosure. And as a preamble, I just quickly go through this. Presence of PDA in premature babies occurs in more than 80% of extremely low birth weight infants. And we do know that hemodynamic significant PDA is associated with multiple, as you can read here, by BPD, IVH, ROP, and pulmonary hemorrhage and renal impairment. And we know that in hemodynamic significant PDA, the risk of mortality in neonates is way much higher compared to infants with closed duct. And as for the treatment option, expectant management was also shown not to be non-inferior to early ibuprofen treatment in Benedictus trial. And our neonatologists would like to treat with ibuprofen or acetaminophen at least 2 or 3 courses before referring to us. Surgical ligation is traditionally a standard mode of treatment, but now the pendulum has swung into a transcatheter PDA closure, and today we are basically want to debate about whether to do it in a cath lab or the bedside. And a little bit of historical perspective. Transcatheter PDA closure was first described by Portman in 1967, and bedside PDA occlusion or closure already first reported in 2010 by the New Wilson team, solely under echocardiographic guidance, but that was a femoral artery puncture. So again, the major milestone will be the FDA approval of Piccolo device for transcatheter PDA closure in premature infant more than or equal to 700 grams in 2019. So this is debate about bedside or cathside. It is not about who is more handsome, Joachim. It is, I think, when you were younger, I think you are more handsome, but now you are not. And it is also not about the prize money of 45.6 billion won, like in a Squid Game 2. It is also, it is not a life and death situation of a game of Squid Game 2. Player 001, Joachim, and versus player 456. So it is about, the debate is bedside or cathside. As you can see, I was in cathside camp before, and you can see the photo there is a bit vintage, as now we have moved towards bedside PDA occlusion, as you can see on the left panel. So I think the best experience will be Dr. Sham from Memphis, but currently the largest public bedside series was done by the German team between July 2019 and November 2023 with the 58 neonates. And you can see only 5 patients done in their own center, but the rest is a respective neonatal unit in 12 towns. And the median duration of the procedure is only 40 minutes. Bedside echocardiography, solely on echocardiography. And look at the no procedural deaths, one pericardial effusion requiring drainage, one device-related aortic coarctation, one device embolization, one late migration. If you look at 58 patients, comparable to a Piccolo clinical trial, which are 100 patients less than 2 kilograms, it is more or less comparable. Device embolization, 2%. This is 1 out of 58 patients. Device migration, 1%, same, 1 patient. And the rate of obstruction, LPA or aortic obstruction, 2%. So this patient also have 1 aortic obstruction. So look at it, it's comparable. What about my personal experience? I only started in November 2023. Up to now, December 2029, done 15 patients solely on bedside. No fluoroscopy at all. So my mean age is 46 because most of my patients will require at least 2 or 3 courses of pharmacological treatment. And procedure weight median 1,100 grams. Successful in 14 out of 15. One is because after redo, successful, 93.3%. And the first patient was unsuccessful because I think it's just a case selection. We managed to do under echocardiography bedside. I put in a Piccolo with significant residual and then AVP2, 6 millimeter, also with significant residual. So I abandoned the procedure because this patient is the largest patient, 2.1 kilo at day 33. So I have 1 patient with LPA stenosis, 25 millimeter gradient, and 1 patient we have probably a perforated and causing hemopericardium, but not requiring drainage. I will get back to you in this patient. So I want to show you an example. This is doable, definitely doable. 756 grams, day 26 of life, given 1 course of ibuprofen and acetaminophen. So you look at the echo, this is huge PDA, length of 7.9 millimeter with a PAN of 3.1 and 3.8 millimeter of aortic end. And you can see we puncture the femoral vein by ultrasound guided, and then you can see this is a thermoglide wire, and I put it in the IVC on the left panel. Middle panel, you can see this is a glide cat. In the bicable view, you orientate into the tricuspid valve, and a subcostal view, and you can see the wire crossing the RVOT. And the wire crosses the PDA easily to the descending aorta, and meter echo, I'm sure you can see there's the wire in the descending aorta. This is a thermoglide wire. Sometimes it inadvertently go into a celiac artery. And you can exchange the glide cat into a top view LP for French and in the descending aorta. And then you open up the aortic disc of the Piccolo. You can see is in the descending aorta, and you pull the system up to the PDA and the ampulla. And the right hand side, you can see we deploy body and the pulmonary artery disc as well. So most importantly, after your assessment, you have to look at the descending aorta obstruction or the LPA. So no significant gradient and the velocity is good, and with a good result. So it's definitely doable bedside unless you have a poor echo window or patient on HFOV, sometimes can be difficult. So the patient number 2 is the one that I show you. This is a LPA gradient. We put in a Piccolo 5.2 millimeter, or even a very short device. This patient developed LPA stenosis at the moment on surveillance. And the third patient, this is the one where they're complicated with hemopericardium. I drove all the way 3 hours to my center and did this patient. Problem is the most important person you have is your echocardiographer. I don't have an echocardiographer in this particular procedure. We only 2 of the PIS cardiologists doing the case. So I think that therefore, when we assess this patient, PDA is suitable, 3.6 mm with a length of 9.4 mm. And we put it at the standard way that we did this. But however, when we want to deploy the device, I saw this pericardial effusion. So I stopped the procedure and I retrieved, actually, in fact, the top view LP was twisted. And we kind of repeat the procedure 9 days later under portable fluoroscopy with good success. And this was the result. So another thing we have to understand that we're doing in cath lab, the radiation exposure in children, especially in preterm newborns, shouldn't be underrated. Now, there has been a positive correlation between tumors like childhood leukemia and brain tumor. And also in a very patient with immature kidneys, in PREM, with large PDA, patient on fluid restriction, diuretics, you want to put in contrast and add another major insult into the kidneys. And although there's been report that there's no contrast-induced nephropathy in the published data on the 59 patients. So this is even more risk. The transport risk, whenever they want to refer you from one NSI unit to your center, they have to, this is a major nightmare for the logistic nightmare to transfer this patient to your NICU and from your NICU to your CAT lab and your CAT lab to back to your NICU and back to the referring hospital. During the transport, tube dislodgement, I'm sure, secretion, blockage, and hypothermia, bradycardia, thermoregulation, instability, everything. It is a huge major risk. And if you go to the respective referral hospital straight directly, you can cut off all this transport, you mobilize the whole staffing and your oxygen tank, portable ventilator, and even your CAN lab is not equipped to handle this 1 kilo or less than 1 kilo baby. The GA machine is not suitable for this particular procedure, and there are more things. So a CAN lab is really not an environment for a very small premature baby. So in conclusion, I think if you look at different aspects, transport risks, none if you do it bedside. Environment, it is a baby-friendly environment for premature baby. Cost is way cheaper, easy to set up, and if you're not familiar with echocardiography, you can always do it in a setup where nowadays you can have a portable fluoroscopy, and patient stability is maintained by doing bedside rather than sending to and fro from CAT lab. So in conclusion, bedside PD occlusion offers significant advantages: avoid transport risks, ensure timely and efficient intervention, reduce cost and staffing while maintaining safety. And I must say that please support bedside procedure as a standard of care. I'm very soon to think that if you want to ask the patient to refer you and send the patient to your CAT lab, it is a class 3 indication, because maybe expectant management will do better by not doing anything than sending it for your transcatheter closure in CAT lab. So next time, class 1 indication, bedside transcatheter closure rather than CAT lab procedure. So my little dear sweetie Premi, would you like to do it bedside or CAT side? Let us know. Sorry, no sound. Bedside, please. I can say to you. And as for Joachim, if based on my compelling argument, I'm sure you will also vote for bedside occlusion. So this is player 001, and I wait in anticipation to see what you vote. Oh, thank you very much. I think, Joachim, you are also our strongest proponent, also voted for bedside procedure. And I would like to thank Dr. Sham and my hospital team, Sultan Idris Shah Sedang Hospital, and the rest of the hospital. With this, I thank you for your kind attention.
Thank you, Dr. Ko. Now to Dr. Joachim Miro, and see what he says.
Okay, so I have a conflict of interest. I'm by nature in favor of progress, and I think bedside is really the progress. And also I'm an admirer of Chiteko. And I'm also an admirer of Neil Wilson, who actually started this bedside closure. He published his first series in 2011 with very good results. However, he was performing the cases by arterial approach, so he had some expected limb problems. But however, he inspired multiple teams to perform echo-guided bedside, and with or without, as Ko said, a backup portable fluoroscopy. And this is the same article that Ko showed you. Definitely, it's a very impressive achievement. Almost every patient went well. They were doing this in very, very small satellite neonatal units. It's really a, I mean, it's really a very, very interesting and inspiring article. So this is clearly is becoming the standard of care, and probably other interventions in prematures like pulmonary valve dilation, aortic valve dilation will also probably become bedside eventually. Now, how quick the centers will pivot to bedside PDA occlusion will depend on their individual context. My situation in Quebec is that there's no small neonatal units. The prematures are all concentrated in 4 or 5 big hospital, university hospital. My hospital has 80 NICU beds, and most prematures actually will be born in the hospital because the mother will be transferred and not the baby when she's starting a premature labor. So inter-hospital transportation of small prematures is very rare in this setting, and I don't think there's a need for a mobile PDA closure team going to, I mean, small neonatal units that don't exactly exist. In my situation, transportation from the NICU to the cath lab is not a very big issue, where there are 2 floors up or 3 floors up, 1 elevator away, and it's a very quick transportation. And again, we have a very big neonatal unit, so the anesthesiology team is very comfortable with dealing with extreme prematures. Another thing is that we don't close that many PDAs in prematures because I have a neonatology team that is still PDA septic. They don't send patients to surgery, but they send maybe 3 to 4 cases a year. Typically, it's old prematures that have been, ventilated for time and time and time, and most of them have done 1 or 2 episodes of NEC, and they have a bronchopulmonary dysplasia with overinflation, so many of them actually have very bad windows, so it's going to be another problem doing them bedside. And for now, my energy is more focused on convincing my team to refer more patients to the PDA closure. How do we do in the cath lab? Of course, the patient will stay in the incubator as long as possible. We are very maniac about central temperature control. We have, of course, a probe, and we're preheating the cath lab before the patient. We use the bear auger or any other warming device that you have. And of course, we avoid getting the patient wet because he's going to lose a lot of. This is my technician, Denise, setting the. She's always cold in the cath lab, so she's very happy when we have premature babies so she can eat the cath lab. Of course, we are very, very concentrated in hemostasis of the patient. We do baseline, like anybody would do, baseline blood assessment, and we will repeat it as necessary and controlling metabolic abnormalities very quickly. And of course, we draw microsamples, less than 1 cc, so the patient doesn't get exsanguinated. Of course, it's very important to communicate with the anesthesia team. We always tell them to be very permissive in hypercarbia and hypoxia, so they will maintain elevated PA pressure. And very important to tell them that once we touch to the ductus in those very sick patients, again, all of them have bronchodysplasia in my experience. So as soon as you touch the ductus or you put the device, the patient is going to desaturate because he loses his recirculation in sick areas of the lung. And the philosophy is less of everything, less blood loss, less fluids, less contrast, less time, and less X-rays. Actually, most of the intervention, even though it's done in the cath lab, is done under echo guidance. And we will never rely on an angiographic measurement because the catheter is across the ductus, so the ductus can spasm. So we always will use the pre-cath or the per-cath echo measurements. And oops, sorry. So you can see that we actually do our patients under echo guidance. You see the hand of the echographer, and that images are very comparable. This doesn't play. But it doesn't matter. I mean, we really rely. And in the recent cases since 2014, actually, we do exactly what Dr. Ko was showing is we do it by echo guidance, and we will use fluoroscopy at low intensity and 3 frames per second, basically most of the time just for deployment. And if we can't access the doctors, but we use less usually than 1 or 2 minutes of fluoroscopy. And again, it's important to be in the cath lab because even though there's very nice series and people have always very interesting initial experience, there's no way nothing will never happen. And if it happens, you're very happy to be in the cath lab and to resolve the problem while the patient is still stable. So in conclusion, I know it's a debate, but honestly, I can't disagree with Dr. Ko that bedside echo occlusion is going to become the standard of care. It avoids, like he said, instability, it avoids X-ray, and frankly, it's very elegant to do it bedside. But as a vintage interventionist, I think that we can mitigate the negative impacts of being in the cath lab, and that working in our controlled environment also has its advantages, especially when there's a complication. I will eventually switch, but I'll always keep my cath lab and team available. I wouldn't do it, definitely, I wouldn't do it in a unit with no cath lab around or no material around. And that's it.
All right, thank you. We won't take questions, but we could take a show of hands for those that would favor number 1, bedside closure of preemie PDA. Show your hands. Okay, not too many. How about cath side closure of preemie PDA? There's a lot of hands that didn't go up. How many never want to close a preemie PDA or play Squid Game? Okay, all right. We may make up a little bit of time here. So are we going live? Are we ready? Good. We are going live? Okay, we are going live. I think we are going to Tin. Are we going to Tin? Okay. Hello again to number 1 Children's Hospital. Hi, Tin. It's Allison and Omar. Oh, okay. You're tricking us. Okay, I see Tin now. Do you want to introduce your case? All right, thank you. So you're planning for pulsed valve. Would you like to review the sizing for us?
Yeah, so we have done some volume testing. There is no CTA. Usual no CTA. So we have done the volume interrogation using 25 millimeter Zenith balloon. This is the compliant balloon. We have 34 millimeter compliant balloon, and this is the balloon interrogation using Zenith 25 millimeter with at least 4 ATM. There you couldn't see any weight there. And in the distal angiography, you can see the distal anti-dilated in the frontal projection as well as the lateral projection. And from the RV angiography with the full balloon inflation, 25 millimeter balloon is occluding at least the para-annular area. So what is it? Which valve? Which size valve?
So I'm not familiar with pulsed sizing and not having a CTA either. So both of those concepts are foreign to me. So maybe you can just go with what you're selecting for sizing since we are time constrained here.
Yeah, okay. This was 25 millimeter, and we have seen that these are anti-dilated. So I usually add 4 millimeter to the weight, but there is no weight. Add 4 millimeter means 28 millimeter. So I think that either the 28 millimeter pulsar valve and the 30 millimeter pulsar valve will go in this RBC. What do you think? Finish.
Yeah. Can you change with the little bit downside, but the valve of 28 is okay, but say we make sure that 100% the 30 is suitable for this patient.
Yeah, I think that 30 is also good. Good size. 28, 30, both of them.
Okay, what is the length of that valve?
So the length of the valve is 38 millimeter. However, if you oversize, then it is a little bit elongated. And if you see the RV angiography, initial RV angiography, if you see, you can see some holes, some thinking of this NTA in the RV junction. Can you see?
Yeah, we can see that, but that's compliant.
Yeah, yeah. If we can cover both with narrowing, it would be good. But size-wise, even though we use 30 millimeter valve, we couldn't fully dilate that hole. And anyway, that hole doesn't make any special reason. So we can implant the valve in the para-annular area.
Okay. So can you show us where you are now in the procedure?
Bigger picture here, yeah. So this is the first valve, the 30 millimeter valve. You can see the three. Oh, little difficult to see.
No, no, it's they know how to.
You can see three reflex here.
Yes, we can see that.
So this is the posting sectile valve, and this is the delivery system. So with 20 French detachable, and this is critical. We are gonna load this valve on the delivery system into this critical. So Jackson will be
Jay, here's Omar. How many sizes do you have of the Polestar valve? Or it's only one size?
18 millimeter to 32 millimeter.
I was wondering, this valve, you don't need to put a stent before you implant it because it's a huge area, or you don't need to.
This circuit extending valve is designed to implant in the native RBC. The beauty of this valve is that if you put the valve in the irregular RBC, if you follow the patient 1 year later, you can see the very nicely remodeled RBC, just like irregular part of the RBC becomes a very regular surface after some removal process.
So, Jae-young, I saw how you crimp the valve down in size, but how does it actually connect to your delivery system? You know, Harmony, you have your little threads, eyelets that you put on this coiled delivery system, and you have magnetic connection for other valves. How is this connected?
I did not do this, but there are 3 hook blocks, and the 3 hook blocks go inside the 3 struts, hook nut struts.
Oh, okay, gotcha. And do you typically use a long delivery or long protective sheath, like a dry seal if you have it available, or does it just delivery system through the skin?
I have done more than 80 cases without professional sheath, but there was no case in whom I felt some difficulty in advancing this system. Very softer, much softer with a good axial force. So it is much easier to advance the system to the even irregular RBC without difficulty.
I don't remember whether you told us what size of sheath you need for this large.
This is actually until up to the 28 millimeter valve. The 8 millimeter is the profile of the delivery sheath, and for 30 millimeter, more than larger than 30 millimeter, 20 French is the profile of our delivery system. So you can you maybe 5 French, maximum maybe 6 18. Yeah, so you can see 1 hook block here, 2,
Yeah.
and 3 hook blocks in the strut.
Yeah.
This is the assembly.
Okay.
Like that. And this is much flexible. And the length is also shorter. Now we have set up some seamless ready transfer valve.
So how many countries is pulsed valve available in now?
How many countries? Commercialized in 10 countries, but all the countries, including some, commercialized in 10 countries. And we already have done nearly 600 cases, 740 cases so far worldwide.
Thank you. Looks to advance very nicely.
So as everybody knows, the implantation, during the implantation of the self-expanding valve, frequently angiography on the RBC is very important to put precise positioning.
So do you always start so distal? Is it able to be retrieved at a certain point, or is it?
While you are rotating, it is the valve is open about 30% until then it can be achieved.
At 30%?
More than 20%, yeah. More than 20%, you have to use the slider. At that point, you couldn't lift it. However, some operators reported that it can be gently pulled back and it can come out through the iliac vein. Down. Down, then stop on for angio. On motor angio. Then you can actually the position, you can come back a little bit more, yeah, and open more. Don't push. Until the end of the then come back 1 to 2, come back 1 centimeter. 1 millimeter, 1 centimeter, 1.5 millimeter. Oh, yeah. Millimeter. So that's it. Now we testing the valve system. Yeah, now.
There you go.
Yeah, you can imagine the proximal end of the valve there. So you can come maybe the distal, we don't need to cover the distal limit. So you can come 1 centimeter and angio and 1 centimeter angio, the 5 millimeter angio, something like that. Just precise position. Now what we do now? A little bit come back, okay? A little bit.
Do you come back just a little bit here to get all of the leaflet?
I think we, what do you think? Can we leave open more the valve? I mean, you don't need to open more, but come back. And go now. No control? Yeah. Would you show us the previous angiography?
I'm not sure your co-registration is helping us. I think the angio is more helpful there.
So I think the distal tip of the valve can be come down until the first sternal wire. Then valve cushion may cover the annulus. Yeah, so you can come a little bit more down to below the first sternal wire. Slowly, slowly. Here it's okay. Okay, a little bit more. We wait for the contraction. And come back. Ready for the yes. Angiography. We the injector there is no contractile. Yeah.
So you're trying to come back just a few more millimeters, right?
Yeah, 1 more millimeters. But I'm quite sure that it can come down. The distal part of the valve can come downwards to the first channel. So
Yes.
Because the distal valve ideally positioned at the junction. It may take some minutes.
Gareth?
Yeah, I was just going to ask. I've never used this valve, but it seems as you're pulling it, all that's happening is it's tightening onto the inner curvature. Do you think you need to push the wire a bit to try and free it up and get it to come back a little bit more? Because it seems to be pretty nicely wedged in above the narrowing. I just wonder whether by pushing the wire, you'll actually get a little bit more traction backwards on the valve. Because I agree with you. I think the top of the frame needs to be on the sternum, or the sternal wire, excuse me.
Usually my, can you show my hand? Usually my practice here is two hand technique like this. The push the wire and coming back a little bit by release your line here. Yeah, so two. You also do the same. Yeah, but two hands, yeah, two fingers. I control the wire. Yeah. Oh yeah, okay, this one. Okay.
We'll show Jay's.
From the company in 1995, when he visited my youth. Thank you, Trumpy. Trumpy is there?
Yeah, Promfy's here.
Yeah, hi.
Yeah. I learned from Trumpy there.
Thank you.
In 1995.
Tin, that was an excellent demonstration of how to flush and connect catheters and flushing system. And you used two hands.
Yeah, looks okay, but you can come. Look at the RK junction. The extra part is still in the RK, middle of the RK. So you can come back more to the below the first wire. Oh, you depression. Yeah. Did you catch that?
So was that a?
Question should would be, do you need to put
Was that backwards tension that deployed it?
It is supplied for implantation, but
Or the two-handed technique.
a little bit oversized, so I think
I think you got away with it, yeah.
Yeah, I think you've got.
actually it is the really excellent release.
Oh, the two-handed release.
No, the couple of the operations, collaboration was really unique. This look okay. So the lesson from here is that if you develop more than 90% of the valve, and if you come back without any tension on the wire, then it can spontaneously release. So if you the reason why I'm pushing the valve first before I further progress with the slider is that this is they are working on some reaching a new system, but that it may take some time to get some approval.
Yeah.
So in the meantime, my usual practice is that position the wire, or the bell in the perfect position, then advance the slide. But it is not too bad.
Yeah, Chong. Yeah, Chong and Tin.
But
I have
Jay,
a question.
sorry.
Is there a chance to move the stand back using something like a pigtail to pull the whole system back towards the right ventricle? That means, can you correct the position now?
Trongfi, you don't need to do that. This is a very good result in the end. And all you can do is, if you're going to pull it back with anything, it's going to be difficult to control how far you pull back, because they'll be using their four-handed technique in order to retract it.
Yes, I agree. I agree, because the branches are not, covered, and the valve is functioning very well. But optically.
Jay,
The description that the team would like to position the valve in the supraanular portion because of that, some
Jay, can I? Huh? Yeah, Jay, can I ask you a question? This valve will take some time to expand more than it's now. I have the feeling somehow, sorry, this is now the final size of it, or will it expand more?
Actually, I have experienced in some patients that the valve is finally have the hourglass shape because of some constriction in the middle. But on the follow-up, the hourglass disappears, just like a tubular transformation. That means the self-expanding valve is continue to expand. If it is the limitation of the tissue, if the physical property of the surrounding tissue is allowed, then self-expanding valve
Okay.
can approach to further dilation.
Okay. It looks very good, and thank you very much. I think we have to move on to the speakers news. That's
Very nicely done. We're going to move on to our pros and cons. PDA stenting with stenosis of the PA branches. Stent or not, or stop. In favor of stenting, Behzad, welcome back for round 2.
Well, good afternoon once again. Yes, PDA stenting with the stenosis of PA branches when I do stent. Once again, no disclosure. This is on my team in cath lab. You may all know that the management of small neonates with duct or systemic circulation dependent to the duct, the choice of intervention is crucial for ensuring optimal outcomes. Traditionally, surgical palliation is the treatment of a standard, but recently we, the cardiologists, do many things with PDA stenting. But do not forget the fragile patient condition. This is the patient that you may encounter. It's a very small neonate, has an unstable hemodynamic in most of the cases, with different level of cyanosis and hypoxemia. So pulmonary artery or bifurcation stenosis is not a limitation, but it is a critical condition that it impacts the hemodynamics of neonates. And something that is very crucial that you have to know about your abilities, your cath lab team, and also the surgical sector. Anyway, stent or stop. I do stent because it is minimally invasive procedure. For sure, it reduces the trauma and the stress to the infant's body. Everybody knows that it reduces recovery time, and this allows for the earlier extubation, quicker return to baseline health, and it has a low risk as complication. Everybody knows that surgical interventions often carry on higher risk of complications. You know that infections, bleedings, and longer hospital stay because of that. So in intervention, we have immediate hemodynamic improvement in a few hours. This immediate affects life-saving for most of these infants because most of them have other treatment options, and potentially for future interventions, the stenting is a bridge. So if even a surgeon wants to go for surgery for these babies, it takes time for the baby to grow up. And preservation of the ductal flow. You know, most of the times when we are doing stenting, we have the flow and patency of the PDA. So it is very adequate for these fragile patients. I want to show two cases. The first one is a 5-day-old boy with 3-kilogram weight with pulmonary atresia with TF anatomy. It has a small and complement PA branches with degrees of bifurcation stenosis with a long PDA, or sometimes we call it MAPCA, and right aortic artery. And the room air, the saturation was 67. As you can see, the field of the pulmonary has no vessel at all. It's a very small baby, and you cannot find any duct or any RVOT on these RV injections. From the venous side, it is easily and more safer to go from the venous side in these kind of TUF patients to ascending aorta to find the PDA. It's a vertical, long PDA, and it is much more easier to wire it. Most of the times I use 2 or even 3 wires for more stability. And using a stent very easily from this side, more controllable. You know, my patient is not intubated during the operation. Everything is on control, but I have a bare portion at the proximal part of the PDA, so I decided to go for another stent. Another coronary stent for 4 millimeter. And this is the result. So in conclusion, the preference for the PDA stenting over surgical palliation is a small neonate with pulmonary artery bifurcation represents a significant advancement in our field, and the preference of PDA stenting over surgical palliation is small neonates in duct or systemic circulation dependent to duct is supported by minimally invasive nature, reduced recovery time, lower risk of complication, and immediate hemodynamic benefits. I think that my second case has been omitted in the operator room. Thank you very much.
All right, to debate the stop, Gareth Morgan.
Okay. Is the mouse working, or did Mario really just totally destroy it this morning? It's like Mario totally destroyed it. Okay.
Do we have the slides, or are we going to stop here? Well, Gareth, what do you think?
I can tell some jokes.
We can't vote yet.
Does anybody want to hear my Christmas joke?
Bezan. I thought maybe you hit
only
his
one of
slides.
my cases was omitted, but all of yours omitted.
Okay. Okay, so my part of the debate is stop. So don't stand across patients with branch pulmonary stenosis. It's always good fun being given a debate topic that you don't necessarily agree with. Next slide, please. Okay, I can't advance the slides myself. Is that correct? The wheel? Yep, there we go. Okay. So I think like all debates and like every lecture, people tend to give advice and tips and commentary that they actually don't really carry out in day-to-day life. So I think it's important always to listen to everybody with a little pinch of salt. This is not working, so these are not advancing. Yeah, it's nothing's happening. So next slide, yeah.
I think you use the arrow, Garrett, the arrow button.
Yeah, it's not working either. It is now. Okay, I'm going to skip past these to save time. So I think we just need to ask ourselves, based on the pre-procedural imaging, is the PA anatomy appropriate to do a PDA stent? And if not, then is there a better choice? And I think that's all I would argue. I wouldn't say yay or nay to stenting across branch stenosis, but I think we need to ask what the other options are. But of course, in order to do that, you have to have a good quality pre-procedural image, which is normally done by having a CT scan. There are options, and I think no matter what, we have to recognize the fact that the BT shunt has been around for many decades, and although we are all trying to move to a different era and to be more modern about our decision making, there are still some cases in where surgical BT shunt and arterioplasty are the right way forward. I think this is important because as we develop PDA stenting, which we're doing, it's important that we don't end up giving it a bad name. If we're careful about case selection and careful about only picking the right cases, then it'll encourage everybody in our multidisciplinary forums and meetings and our surgical colleagues to trust us to stent more PDAs, rather than us being gung-ho and trying to stent everything and getting into trouble on a regular basis. And I know we say this very often at meetings, but the enemy of good is better, and that is not only related to deciding whether to put a PDA stent in, but also when we stent at the PDA and we see a narrowing in the branch pulmonary artery, whether the best thing is to do is to pause and see what happens, or to crack on and end up in trouble because we've tried to improve something which was good enough to start with. So here's an example. I don't think I'm going to be able to make this play, so maybe you can make a play from there. Play the video, please. So this is an example. This is a patient who you can see has got a particularly tortuous, as in it's got a 180-degree bend in two directions. There's a tiny stump of a main pulmonary artery, and there's a narrowing both into the right and left pulmonary artery. So I think this is a patient that should make us pause and think whether or not the right thing to do here is to try and use a PDA stent. Or if we are using a PDA stent, should we just avoid the stenosis, try and get the stent done into the main pulmonary artery, and then see what happens? But if you look at this from two different angles, you see that the PDA itself is very tortuous. The PDA itself is very tortuous, and if you get past the PDA, the branch pulmonary arteries are very abnormally positioned, probably have got duct tissue in them, and there's narrowing associated with both branch pulmonary arteries. So this is why when the COMPASS study, which is currently what we're trying to roll out in the US, this is a study which is directly comparing PDA stenting with surgical BT shunt in the US, and it's a randomized controlled trial, which as you can imagine is quite slow to recruit, but is moving ahead. And one of the exclusion criteria from the COMPASS trial is concern that there may well be significant duct encroachment into the left or right pulmonary artery. So which would put the branch pulmonary arteries at risk. So significant narrowing of the left or right pulmonary artery would be an exclusion criteria for putting a PDA stent in. And the authors have reason for this because there is data that says that basically that is not going to give you a good outcome. So I think there is evidence out there and there's data out there suggesting that distal problems with the PDA and with the branch pulmonary arteries is a problem. This is an algorithm from a paper that was written quite recently. This is from Pediatric Cardiology last year. And you can just see, without getting into too much detail on this algorithm, that the predictability of branch pulmonary artery stenosis is not easy. The fact that there's so many branches in this decision-making tree suggests that your ability to predict easily whether or not the branch pulmonary arteries are going to be compromised is not easy. I also think we need to be very careful not to try and destroy the surgeons. So we need to make sure and be collaborative and thoughtful about our decision making. What we don't want to do for many reasons is have the surgeons not doing any BT shunts because we're going to cause ourselves a problem. So this is not a surgeon, but a chef talking about the use of sous vide machines, taking away surgical skill or chef skill sets. And if we just replace chefs with surgeons and sous vide machines with interventional cardiologists, I think there's some parallels here. So basically, the more and more we stop surgeons from operating on simple cases, we're going to get into major problems in the years to come when you need something quickly and the surgeon says, well, I'm really sorry, I haven't done a BT shunt in 10 years, and now you want me to run into the cath lab, open a patient's chest, and do an emergency BT shunt and arterioplasty when I actually don't even know how to do a simple one. And I think de-skilling of surgeons and pushing them to the periphery of decision-making is probably not something we really want to do. Plus the fact that if we go ahead and stent and put the stent across into the branch pulmonary artery and leave stent material into the branch pulmonary artery, particularly after the upper lobe branch of the left pulmonary artery, we're going to make the second stage much more difficult and turn what would have been a relatively simple Glenn procedure into a much more complex reworking of the branch pulmonary arteries. And I think we really need to think about this when we've got significant stenosis to one branch pulmonary artery or the other. If we leave stent material there, then the surgeon's job is a lot more difficult. So back to the original case here, this is the patient with the quite nasty looking branch pulmonary artery stenosis, and I did actually take this patient at the cath lab against what I'm saying here, and in trying to basically improve things and manipulate, could we play the video please? Manipulate the stent and get across the narrowing of the branch pulmonary artery. Can we play the video please? So trying to do this, you can see that manipulating a wire and a buddy wire here, we eventually dislodge the distal stent and push that distal stent into the right pulmonary artery, which meant we ended up with a big gap between the stents, the duct closed down, the patient had a cardiac arrest and needed an emergency BT shunt in the cath lab, and ended up having an incredibly treacherous course after that. So I do think that we need to be careful. So let's try and be selective and sensible of our case selection. Let's not give PDA stenting a bad name. Let us have the surgeons come to us and ask us to do PDA stents rather than us forcing the issue. We should consider that there still is a place for elective BT shunt and PA plasty in these patients. We should allow the surgeons to have skin in the game and allow them to have a role so they don't de-skill and that we don't end up having problems if we have to call them in emergencies. And I think in order to predict this, you don't want to go into the cath lab and do an angiogram and realize that you've bitten off far more than you can chew. So very high quality CT imaging and very good quality analysis of the CT imaging beforehand should be done in order for us to basically have a good idea of what we're getting ourselves into rather than getting stuck when we get into the cath lab. Thank you.
All right, thank you.
Yes, may I?
Rebuttal.
Yeah, no, it's not in counter. I just want to insist that, honestly, not all the patients are candidates for PDA stenting. And it's not fair for all the patients to go for the surgery. So decision on this depends on many things. It's not 0-1 decision. You have to think, you have the good team, and you have good collaboration with the surgeons. Sometimes it is very, very crucial to have a good surgeon. If you have not a good surgeon in your team, it is your responsibility to do something. But sometimes you have good surgeons more than you, and they are more expert than you in the cath lab. So at that time, these are their turn to do that. Thank you.
I believe personally what Gary said, shared decision-making is essential. And of course, if the surgeon doesn't have good results, some of them, the new surgeons, sometimes they tell you, I don't do BT shunts. They do TOF repair like this. And so obviously then you have to do stents even if you think it's not helpful. Because at the end, both decisions, they have problems. It's not like one is much better than the others, but you have to keep a shared decision making.
I have a question, Garrett.
We'll have a short comment from Dietmar, and then I think we'll wrap this up.
Maybe. Your 3D model, what is the elective alternative to a stenting of the duct? It is you need BT shunts on both sides, or you need some surgery in a newborn with a bifurcation and an AP shunt. That's the highest risk for a surgeon, and the mortality is 10-15%.
Yeah.
So if you, particularly in your model, I would, ever, you have never to say ever, but I would try in any case to stent this duct because nature tells you that is the best access to this both pulmonary arteries. And if you have one side pulmonary artery stenosis, it is not a problem when the patient is operated in 3-4 months later, not in 10 months later. And then the surgeon, the patient is quite different for the surgeon, and the outcome is nearly less than 1% mortality. So for me, I would recommend duct stenting, but what you have shown is if you have problems, technical problems, but it is not related to the morphology, then stop and say to the surgeon, I have a problem. Do it, please. But it is not the same, it is another comparison. Very, very. No,
Thank you,
we have
Dietmar.
to differentiate between technical problems and the indication what you have to do.
Yeah, I mean,
Okay, no doubt this is a difficult patient problem, and we will talk about it probably every year until we are long past retirement, Dietmar. Gareth and Jenny can continue on, but I think, are we going to next live, or are we? We're going to the next session. We made it. Congratulations.
Whilst Mario's walking up, if I can ask Martin Schneider, I saw him somewhere, Teji, Abhimanyu, Jonas Dell, and Parag to join Mario. Very quickly, please.
Okay, we eventually reached the end of the day with the last session, and I'm happy to chair this session together with Martin Schneider, Teji Akaje, that probably can join me on the podium, together with the panelists Abhimanyu Upal, Jonas Del Rosario, and Parag Barbad. So please, co-moderators and panelists, join me to the podium. Well, we will start this session with the slide modification. We will start with the coarctation in the neonates. And I invite Kevin Walsh to come to the podium and give the first lesson. Please, Kevin.
Thank you very much. So we need to put up just put up my slides. Be here shortly. Coarctation. Yeah, the order's changed. To cath or cut. Disclosures. Will he go into Canada or won't he? And do we mind? Neonatal coarctation, primary therapeutic option is still surgical repair. Everyone knows what that looks like. It can be via left lateral thoracotomy or through sternotomy with or without bypass and repair of other lesions. We wrote this many years ago, 20 years ago, saying that coarctation worked really well in Dublin experience of 181 patients, and that balloon aortoplasty is left for recoarctation. Everyone knows the limitations of cath intervention in newborn would be high rates of recoarctation for plain balloon angioplasty, for stents, lack of growth potential, and stent material issues. We still view balloon angioplasty as the main use for neonatal coarctation is for recoarctation, and that includes recoarctation after Norwood type procedures. However, some of the Norwood type recoarctations are really quite complex, and as surgery often, surgeons don't want to go back in on these patients, and we would end up using stent implantation, which is really going to create a lifelong problem, but is going to be probably the lesser of many evils. In terms of stenting of critical coarctation, it's really been left for premature, critically ill, complex, early recoarcted neonates. This is from Garnflow, 15 neonates, had bare coronary stents, femoral artery preserved in 13 out of 15, and surgeons were able to cut out the coarctation segment with the stent in 8, but patched in 4. With further follow-up, 26 neonates, surgical repair at 4.2 months of age, body weight of 5.6 kilos, end-to-end for most patients, patch reconstruction in 15 patients, and the results were similar when they compared it to 76 neonates operated on with native coarctation from the beginning. In terms of the long-term outcome, then when they followed up to 5.2 years, all children were NYHA1 without hypertension. Still early days for that. So one of the more useful things for angioplasty of native coarctation, this is a 480-gram infant with very low birth weight donor twin-to-twin transfusion with balloon angioplasty, 3 by 18 millimeter coronary balloon on a patient who wasn't suitable for surgery. More recently, we have this Renata stent, which is specifically designed as a stent that can be made bigger as the patient grows. It's quite expensive in terms of its pricing. Foreshortening isn't so bad, but really does become very significant at big dimensions. The minimal early feasibility study looked quite reasonable. 2 transient diminished leg pulses. You can see none of these patients were actually neonates. In terms of absorbable metal stents, we've been looking at this for years and years. It's quite significant complexity in terms of tiers of development. You've got material selection, processing and geometry, surface conditioning, and applications. So the IBS stent, we're going to see more of that tomorrow. That may give some hope, but it's still early days yet with this technology. But the concept of iron corrosion comes from Gerd Hasdorf in Germany from years and years ago. But anyway, the indications for initial stent angioplasty would be, in my opinion, cardiogenic shock, neonatal infections, necrotizing enterocolitis or other types of ischemic organ dysfunction, and concomitant complex cardiac malformations. So to conclude, surgery remains the primary therapeutic modality for most cases of neonatal coarctation. Angioplasty or primary stenting is reserved for special cases. Subsequent surgery is usually required, and advances in stent technology may change this paradigm. Thank you very much.
Well, thank you very much, Kevin. We carry on with your antagonist, Nguyen Ly Thien Truong, and then we will have the discussion afterwards. Please.
Good evening, ladies and gentlemen. So let me explain my gratitude to the organizing committee for the invitation. So my talk today is about the coarctation in neonate, surgical repair versus catheterization. I have no disclosure. So when I got the email from the organizing committee, I just read the top, just a few words. And I thought in my mind, oh, they gave me a huge headache because I need to prepare. I thought that I need to prepare the lecture of the to compare between the surgical repair and cardiac catheterization in the whole picture of the coarctation, including neonatal, infant, and adult. So this gave me a huge headache because of a lot of articles comparing the long-term outcome between the surgery and cath lab, with the debate is still going on. But today, when I look at the title again, so it gives me a breath. So I just take a quick look here in the internet resource, and I just found just a few reports about the catheterization for the patient with neonatal coarctation. So this is just a new publication from in 2024 for the neonatal between premature baby, and the number case is only 3 patients underwent intervention in neonatal. So 2 patients after standing require operation about 2 or 3 months later, and the other patient is awaiting the operation. So the second article for neonatal coarctation, including 3 patients and 4 patients is and 4 patients. So and actually after surgical after catheterization, so patient also require surgical repair. And as my previous speaker talking about standing for critical coarctation in premature critical complex, so in the stand almost need to remove after almost 2 months or 3 months old, and even for the in the complex cardiac malformation, the stent is finally removed after implantation. So the indication for, I think we all believe that the transcatheter intervention in the critical ill neonate have our indication. So as mentioned by the previous speaker, is in the live picture, or in case of severe cardiac decompensation or the cerebral hemorrhage or liver dysfunction. And the role of the surgery in neonate is, I think, is all proved by the practical guideline from the Society of Thoracic Surgeon. So we can see that the recommendation for neonatal coarctation, so the surgical repair is recommended as the first choice. And for the patient with neonatal and infant premature baby, low birth weight, and the patient are in the risk factor for the surgical intervention, the medical optimization before intervention is reasonable. So in the recent article from we have seen a lot of patients underwent surgery safely and with a low mortality and a low morbidity. The number of cases is quite huge, and the long-term follow-up is extensively more than around 20-year follow-up or up to 30-year follow-up, with very few mortality, around less than 3% and almost less than 9% in the long-term follow-up. And most of the patient was asymptomatically, no need to re-intervene. It's very few need re-intervention, and the freedom from mortality and re-intervention at 10 year or is 94% and 96.7%. it is this paper from the SDS, from the Chicago, Illinois group from with Dr. Carl Lewis Baker. So they report a huge number of the patient underwent coarctation repair with no mortality and no early reoperation. Only 2% patient require re-intervention up to 20-year follow-up, and the late hypertension is only 18%. So recently, as we all know, one of the risks of mortality and morbidity in the coarctation patient is the patient with low birth weight. But recently, with improvement of the pre-operative management, perioperative care, so the patient with the low birth weight neonatal safely underwent surgery. So this paper report 14 patients less than 2 kilograms with isolated coarctation repair and no death in hospital or during follow-up. This paper from Multi-Center Pediatric Cardiac Care Consortium provide a significant number of patients with the predictor of mortality, including the surgical weight less than 2.5 kilograms, and the patient have the genetic syndrome and repair, especially the patient underwent repair before 1990. So which means that at that time the surgical technique is not standardized, and the perioperative care is not comparable. Is not comparable until the recent period. And we, with the recent outcome, so we can estimate that the patient might have a better outcome. So according to the literature, so they now, for especially to resolve the problem of the patient with the high risk pre-operation, so they treat the patient with combined stent and surgery approach. And the patient who underwent, the patient have a high risk and who underwent the pre-op stenting and later and underwent secondary surgery have a safe result after operation and after remove the stenting. And we recently see the literature to show the approach of the stenting angioplasty for the high-risk neonatal with the low mortality, and but there was a significant number of re-intervention after operation. So this video shows how we do the surgical repair in our hospital. So you can see that we use selected cerebral perfusion and resected all of the ductal tissue. And you see a quite long segment of the smooth coarctation. So the inner curvature was open, and direct anastomosis was performed. And we harvested the anterior wall of the pulmonary artery to patch the anastomosis, creating an obstructed aortic arch. And then we reperfusion to rewarm the patient. after surgery. So this video also show how we reconstructed the arch with the orthotic wing anomaly. And in our hospital, we recently changed the strategy from one-stage repair after suture operation and arch reconstruction to the two-stage.
Well, yeah, you're a very quick surgeon. I would like you to speed up, if you don't mind, so we can have some time for discussion.
Yes. So in summary, so in our center, this is our data. So from 2016 to 2023, so totally 836 patients underwent coarctation repair, including isolated coarctation and coarctation associated with the intracardiac defect. So as you can see, the isolated patient is including about 330 patients with the mortality. The in-hospital mortality is just around 2.4%, and for the other lesion, the mortality is range from 4% up to 44%, especially for the interrupted arch associated with truncus or Northwood operation, in consider our limiting resource. But in the other lesion like ASO or simple aortic arch, simple interrupted arch, so the mortality, the in-hospital mortality is less than 10%. So in conclusion, the primary surgical repair is recommended for the needle coarctation of the of the aorta, and the primary catheterization should be considered as a bridge therapy before surgical repair in specific condition.
Okay, thank you very much.
Yeah, thank you
and
for your
Kevin, please come over to the podium. We will start the discussion or comments, then stay both there. I pass the microphone first to Martin for starting the discussion or comments.
Thanks. So I've learned right now that the gold standard for therapy of the coarctation in neonates is the surgery. As long as the patient is more than 2 kilograms or maybe more than 1.8 kilograms, there are no additional problems. I did my first palliative stenting in 1993 after the surgeon asked me to do this, and he was quite happy to go on with the surgery 2 weeks later. And since then, I'm on a regular basis asked by the surgeon to do a palliative stenting. One of the last was a 600-gram child. So I do think that this stenting, even in the eyes of the surgeon, is very important for patients with problems.
Quick comments from both of you. Very quick.
Yeah, no, I think it's always a good option when the surgeon asks you to do it. You always have to be a little suspicious as to why they're asking you, but it's still probably a good thing to do. At least you know you have his support.
Right? So more or less it's not a debate, it's a consensus.
Yeah,
yes?
We're completely in agreement.
All right, so, okay, so thank you very much. We are ready to go live. We are going to be connected with Kids Hospital here with Teen Lab. Teen, can you hear us? Yes, yes, we can hear you and see you very well. Can you present the case you're doing? Okay, that's very interesting case, of course. If there is a very quick question or comments from the panel or the audience? Well, if not, please carry on and tell us what is going to do. Tin. Yep. Excuse me, Tin, can you remind us the weight, the body weight of the patient?
6.8 kg, about less than 7 kilos.
7 kilo.
7 kilos.
Okay. 8. 7.5. Okay. Yes. What?
Just wondering, this just about the indication. Should we try to close the fistula in this small baby with the fistula, the size not too big, the aneurysm also just say not too really not too big, and the indication is really need to do in this age, or we can wait after several months, several years.
Tin, the main indication in an infant would be failure to thrive or symptoms of heart failure. I missed it. I don't, does this baby have any of those?
Yeah, the patient cry, and also the heart failure is not so clear. But this case, another indication is related of the LCA. The LCA, the Z score is plus 50.
What about shock and tin? Well, the anatomy was actually quite clear by CT before. I guess that if you bring the patient to the cath lab, your intention is to close the fistula,
you're committed
right?
then, yeah, but indications I was... and also, I think if in the absence of indications or good indications, we would wait until this child was much bigger, because then technically it becomes an easier procedure. Yeah. But it also depends on where you're planning to occlude this fistula, of course.
Well, I guess you already did a selective angiogram, Tin, correct? Can you show us?
Yeah, but it's not easy to do the selective coronary angioplasty. We think if we can make the crossing the median fistula, maybe IV loop, and
It's echo, huh?
so we can do injection to see the more selective coronary angioplasty. I think the image will be better.
Tin? Tin, Jonas here. We actually, there's an echo. When you talk, there's an echo, so it's a little bit harder to understand. Were you able to enter the fistula and snare it and was able to create an AV loop and you have an injection coming from the the right side? Or this is all retrograde?
First we try to cross the LCA to the fistula, but you see with the general guidewire, the guidewire general inside the LCA, but
Excuse me, this is live picture or recorded pictures?
it's a recording.
Right.
And so we use the micro catheter. You see with the micro catheter with the third tip, we do lead and injection. You see the very important was septum leg. And with the micro catheter, we use a coronary wire to cross the fistula to the eye, and we move to the SCC. And with the guide wire to the SCC, we snare the guide wire and the micro catheter together. And be careful with the snare with the guide wire. Guide wire can the one hole maybe touch some structure inside the eye. And so this case, you see when I in the case, the micro catheter, and in this case, just only the guide wire. And you can see when it really stand, you see now they have good ideas now. And now we do live. But with this one, what we do next, we advance second catheter to IVC. But now we need to exchange to the wire.
What catheter are you going to advance from the venous side, Tin?
Whilst you're doing that, Tin, I haven't got a clear, I didn't see the measurements of the vessel, the fistula vessel and the aneurysmal portions, because you must have a plan of what you're going to put in and where. Oh. You carry on doing what you want, but show us some measurements.
Tin, what wire is that? Is that a coronary wire or a glide wire?
So you are re-establishing the circuit, right?
So is this a Terumo wire, 035, or something else?
Yeah, 035.
035.
And what size fistula vessel and the aneurysms? Okay.
Yeah.
So I know you don't want to hang around with a circuit in this small baby, but where are you going to occlude the fistula and what width?
Yeah, in addition to that, at least, well, maybe I miss it, but I cannot understand exactly what's the native LAD as compared to fistulous vessel, which is...
we saw the native LAD on the angiogram.
Yeah, but I couldn't figure out exactly what it is, which is of I think, of paramount importance if you plan to pull something in. Yes?
It looked normal on quick angios afterwards, but we saw it before.
Tin, it's Martin. Could you show us the ECG whilst to doing this procedure? The ECG, can you show us?
Yeah, that is a separate branch, isn't it? Halfway down the fistula? It is, okay. So you're just going to go with a plug in the distal part just at the exit?
So, Tin, just a quick question. What diameter and what type of plug are you going to put in? No, no. The occlusion plug, which... No, no, no. Okay. Oh, okay. Okay, good. Okay. Maybe I was thinking a bit stupid, but I thought if there's any evidence of ECG changes, you need to be quick in deciding, put a plug in and get out, and release that tension. That was
Piccolo device would be very nice.
Yeah. Yeah. Because there's enough constrictions in this fistula vessel.
Well, I mean, the tortuous, the connection, the fistulous connection is very complex, tortuous, with different sizes at different positions, right? So are you going to plan to close the fistula as distal as possible? Are you going to do a test occlusion first? What's your plan, Tin? Yeah.
The-
So piccolo is a very good suggestion because the largest, well, it depends on what you've got
Yeah.
here, but it may be too small. If it's in that portion towards the circumflex origin, in that crumpled up part, then piccolo would work. Otherwise, AVP2.
The only thing, Tin, is you'll need to push eventually the guiding catheter coming from the IVC, and you're going to get a lot of resistance. So this is why piccolo would be very good, because you can deploy it into a 4-French catheter, so you can use your guide wire and position your catheter just distally to the last coronary.
Yeah, just would worry that the piccolo will be a little bit soft on the basis that at the moment this is crumpled up and concertinaed. When you take the circuit away, this is going to straighten out and look a bit different again. And I think I'd have a lot more confidence in a 6mm ABP2, which you'll be able to get through this 5-French guiding catheter and just put 2 inside and 1 outside. I think that'll do the trick. And I'm just worried that this is very, very constrained at the moment, and it's going to pop open into a different shape when you break the circuit.
Yeah.
A long piccolo would be very nice. Long piccolo, 6mm.
Yeah, yeah. Yeah, I think so. I think, Tin, type 4, do you have plug 4, no? Plug 4? Plug 4? Oh,
Okay, ask the question a different way. What have you got? Oh, well, then your choice is easy.
Yeah.
But even if you're using piccolo and you're worried, the distal part in the right atrium is so stenosed that the plug, even if it moves, is going to move into the aneurysm and not go anywhere else.
Jean, can you tell us again the type of plug and the size? AVP2. Okay. Yeah. No ECG changes, no nothing, huh? Yep. So you're going to do an aortogram or a selective left coronary before detaching the device?
cannot the device. What do you think? I think device block the A6 one, not the original A6 one. It blocks complete aneurysm.
Oh, yeah,
Yeah,
we
I
can
think-
see very nicely the right coronary.
It's normal.
I think it's nicely situated.
Tin, I wouldn't have done it at this age of the patients. I don't see a clear indication, but I have to admit this is great intervention you have just showed to us. Thanks.
Okay. So you're happy, aren't you?
Tin, you should release it and then discuss.
Well, would you anticipate that releasing the device will something funny will happen?
No, but we might
That
confuse.
will stay there.
We might confuse tin. So the only alternative suggestion I had, I don't want you to do it now, is I would have put the right atrial side of the disc in the right atrium and just have the two other portions within the aneurysm and the fistula vessel. That's all, but this has produced a good result anyway.
Well, let me ask you another question. There is still a rather long, excuse me, Tin, there is still a rather long fistulous vessel. Are you going to leave it there? Do you want to close it with some more proximal devices, or you're happy with this distal occlusion?
I don't think you can do anything at this stage. I think I would have implanted the device closer to the native circumflex vessel first, and that would have been a AVP2, but smaller than this.
Yes,
and
but
then
now
on the way
the device
out,
is there. What would you do now?
On the way out, I would have done this, but now I don't think I would do anything other than just this.
So, Shark, you'll be happy with leaving that device there,
Yeah.
and that's it?
Yeah.
Yes? Any other comment, Martin?
What anticoagulation will you be giving this? What anticoagulation?
Ask Tin.
So, Tin, what are you going to do? I'm surprised that you didn't release yet the device.
No. This is fine now, Tin. You can only make it worse if you like, and I'm happy to release. It's really good.
Yeah, don't follow all the times the Shark suggestion.
Exactly. Yeah. There you go. Beautiful result.
Yes, congratulations. Very beautiful result, Tin. Okay, if this is it, thank you very much. We will carry on. A big applause to Tin and his team. And we finish the session with the last 3 lectures. Thank you very much, Tin. Okay, so we will finish this session talking about the palliation for tetralogy of following neonatal age in the transcatheter techniques, balloon dilation, the RVOT stent, or PDA stent. So let's get started with Salim Jivanjing talking about the RVOT balloon dilatation in neonates with tetralogy of Fallot. Please, Salim.
So let's discuss some pros.
Thank you very much, and thanks to Dr. Tin and the directors for the kind invitation. So my talk is about RVOT balloon dilatation and whether there still remains a role for it. So it's worth just talking about the timeline. So since the first BT shunt In 1944, there's been a significant progress in the management of tetralogy of Fallot. The first case was in 1954, and since then there's been emerging evidence of advantages of primary repair. So most of the patients which are symptomatic benefit from corrective surgery, and currently, as we're getting more skilled in managing these patients, the operative mortality has improved because of surgical techniques and enhanced myocardial protection. But as we know, even in optimal conditions, repair at a young age remains a risk factor for postoperative death, with younger patients and smaller patients often requiring a transannular patch, which predisposes to hemiregurgitation and reoperation. So I'll just show the anatomy for the purpose of the talk, and we'll see the three variations from left to right. This picture is from Bob Anderson's book. And on the first one on the left, you can see a short infundibulum with a small sort of segment with dysplastic Pulmy valve, and the second one becomes longer with much more tortuous alpha attack, and the last one is significant narrowing. And we'll focus on the first two, which is the main part for this talk. So what's the aim? The aim for any child with Fallot is complete repair, but we know that this can be limited by other morbidities. The timing, particularly the age and weight for repair, is varied across different countries, and of course different centers in each country as well, and that's mainly due to institutional preference, the surgical skill, and the postoperative care. So the indications for interventions are desaturation, so homeolegemia. The age, now we're around 3 to 6 months of age in most centers for Fallot repair, and other morbidities which can prevent full repair. Also, it's worth pointing something that Dr. Rao mentioned in the 80s, that it's worth having 2 sites of obstruction before you consider balloon pulmonary just to ensure you don't increase the pulmonary artery pressures with increasing pulmonary vascular resistance. However, this probably is not really relevant now because you operate much early than they used to in the 80s. Parental choice is a consideration if the family are still not quite sure about Fallot repair. However, I don't think that's really an issue in most of the Western countries. And it's worth noting that untreated Fallot can have mortality reaching up to 75%. So just looking at this echo, the first, sort of the left-hand slide and the slide at the top are 2 variations of the same outflow track. I don't know if there's a pointer here, but I think what is pretty clear to see is that the infundibular area is quite short, and the valve is quite dysplastic, and on the bottom right panel, you can see that the turbulence takes place at valve level, and these kind of anatomy are really quite amenable to just ballooning it with a really good result. And this was a case that I'd done about 7-8 months ago. So same picture, same patient with the subcostal right oblique view. You can see that the infundibular area is quite short, the valve is quite dysplastic, and this should have a nice result with just ballooning it. So a quick picture of the angio. I think the right-hand panel probably shows it the best, with the muscle bundle just on the right of the catheter tip, which shows that there is a small length before the dysplastic valve comes into view. And this is a picture soon after the dilatation. You can see much better flow into the pulmonary arteries, and this patient did really well and was able to go home and come back after about 6 months for his full repair, which was just done about 6 weeks ago. So this same patient, this is a post-balloon echo, and I think what's really clear to see that the turbulence now begins at the muscle infundibular area, and it's worth pointing out that patients who have balloon valvuloplasty does not prevent them from having spells, but that still needs to be managed if that seems to be an issue in other manners. So a slightly other picture, don't want to support the next speaker, but for the purpose of just understanding what I mean by short, you can see this one has a much longer segment before the valve comes. And in this particular case, this would not be really suitable for a balloon valvuloplasty because you'd have significant swelling after opening up the valve by reducing the systolic load in the RVOT. So I'll skip these two pictures for the purpose of time. So there are plenty of studies which have talked about early palliation with balloon valvuloplasty. So the main, there was a lot of activity and in fashion in the early 80s, particularly because most of the operations used to take place around 2 years and above. And as we've come closer to the current era, the size of the patient and the age of the patient has reduced. In most patients, there was a significant rise in the resting saturations. Those who had persistent cyanosis had a BT shunt. But what was noted during corrective surgery in a couple of studies, and one in particular where half of the patients had tear in the leaflets, where the other half had opening between the commissures. The procedure generally allowed better growth, and also some of the studies suggested that there was a reduction in the need for a transannular patch with a valve sparing technique. And the ones which had the valve stenosis were the ones which benefited the most. So there are loads of papers. I've just put in about 10 of them, but the first 5 you can see are in the first 10 years when the first study was published by Dr. Rao from Texas. From 1980s to 1990s, you can see that most of the patients were bigger, and most of the patients had an increase in the saturations and the pulmonary valve annular size, and very few required any palliation, and most of them had their surgery about 6 to 10 months down the line, in some cases up to 30 months later. Then the following 10 to 20 years later, from 1999 to the current era, so if you look at the first 4 papers, the ages are much younger, apart from, of course, 1999, which was still late, and the operations were done around 6 months of age, with a similar increase in saturations and pulmonary valve annulus. In some cases, in both eras, there was an increase in the branch pulmonary artery size. In the last study, which is published from Toronto, this is just focusing on patients with less than 2.5 kilos. Even those patients benefited with increase in saturations and not requiring any interim palliation and getting operated about 3 months later. This table just quickly shows a publication from '98. There's nothing similar since, which shows the first 9 studies which had no intervention, who then went for fallow repair with quite significant mortality in most of them, and quite a high percentage of patients requiring a transannular patch. And Sluisman demonstrated by just using balloon valvuloplasty that the requirement of transannular patch reduced down to about 30%. Main potential issues can cause transient cyanosis for the first couple of hours. As I mentioned before, does not prevent cyanotic spells and may require medical management. And in surgical time, it's worth noting in severe cases, you can have up to 50% of tearing of the leaflets. So in summary, it's useful in select number of cases. It's probably relevant to the institutional philosophy at the time. Appropriate anatomy does work. In some centers, intraoperative balloon is used as an option during repair to have valve-sparing techniques, but they found that pulmonary regurgitation becomes an issue. And just one point noting that balloon dilatation does not prevent cyanotic spells. Thank you.
Okay. Thank you, Sarim. We shall proceed with Jay and Choi talking about RVO stent. Please, Jay.
Thank you, Mario, for a kind introduction. My talk is about RVOT stent, and okay. So, tetralogy follow is elective surgery usually done in between 3 to 6 months of age. Some young infants need for some early palliation, the BT shunt, or some interventional options. So primary neonatal repair is another option. However, it is reported to be associated with the worse outcome, especially in patients with risk factors who are frequently candidate of some transcatheter options. So balloon valvuloplasty and stenting and PDA stenting are among those options. So balloon dilation, as the previous speakers very nicely covered this issue. So however, it is reserved for pure valvular stenosis. So you can see this patient has some pure valvular stenosis, so this can be palliated successfully without the need of stent. However, the problem is that it is the durability or the predictability of the balloon palliation. So in many patients, the alveolar stenting is required. The outcome appears to be very effective and safe. Sometimes frequently reintervention is required. However, it is reported to be very very nice option. Most the important papers are published from Birmingham and Toronto. So you can see in this patient with a very hypoplastic pulmonary artery tree, we could stand there and you can see much improved pulmonary artery flow, which may be a good palliation option. In this patient with relatively the pulmonary valve Z value is larger than the previous patient, but you can see after stent implantation, the patient may have a good the integrated flow. So what should be considered for the decision making from various options? Safety and efficacy, a technical aspect, need of reintervention and some palliation durability, pulmonary growth, need for or suitability of additional intervention, for example, pulmonary branch stenosis, also suitability for the definitive repair, which means some removal of stent or some possibility of pulmonary distortion. And in the long term, the annulus or pulmonary valve preservation may be also an important issue. So direct comparison between these options may be not feasible because each options targeted to different the patient subset. However, indirect comparison of some outcome parameters shows RVOT stent and PDA stent is at least comparable to BT shunt in terms of early mortality, and reintervention is more required in RVOT stent and PDA stent. However, mostly catheter intervention. However, after BT shunt, reintervention is mostly more than 2/3 of the surgical intervention. In terms of procedure, the feasibility, RV stent appears to be more easier than the PDA stent. So there are some the papers comparing the BT shunt or the early primary repair versus RVOT stenting. The survival after RVOT stenting is at least comparable or better than either the early primary repair or BT shunt, even though the RVOT stenting was done in a subset of more high-risk patients. And more reintervention in RVOT stent, however, as I mentioned, mostly catheter intervention, however, BT shunt mostly surgical, to more than 2/3 surgical reintervention. Comparison of BT shunt and PDA stenting, similarly, in terms of early mortality, PDA stenting is better, and also some other morbidity indices. However, the reintervention is more frequent in the PDA stenting. That's quite similar to the RVOT stenting. However, after surgery, you can see some requirements of intervention after BT shunt, after palliative RVOT relief. Also, this patient was retreated using the RVOT stent with the subsequent very good growth of the pulmonary. So, on the other hand, what is some issue on the subsequent the definitive repair after RVOT stenting? So removing the stent lengthens the procedure time, and 86% require transannular patch. However, the surgery is safe, but the majority will require after RV stenting, surgery is not a big problem. However, requires more bypass time, and the majority will require transannular patch. That is the report from Birmingham. So Oliver Stumper is here. We can hear more detail from him. Subsequently, repair after PDA stenting. During the elective surgical repair, PDA stent were completely removed in only 23% and partially removed in the majority of the cases. And some patient, more than 50% of patients required surgical pulmonary arterioplasty. So for patients required additional interventional procedures on the left pulmonary artery after surgical repair. So the presence of PDA stent requires additional surgical maneuvers on pulmonary arteries in near half of the patients, and postoperative interventions can be required. So what is the comparison of RVT stenting and PDA stenting? In terms of mortality, early mortality, procedural success rate, and some need of pulmonary arterioplasty, RV stenting may be better. And in terms of technical burden on the definitive repair or pulmonary preservation requirements, the PDA stenting may be better. So what is the advantage of this advantage of RPOT stenting? Advantages include more physiologic source of pulmonary blood flow. So adequate oxygen the oxygenation is possible without excessive pulmonary blood flow. Less risk of pulmonary artery flooding, running off of systemic blood flow, and optimum pulmonary blood flow for adequate O2 saturation, more symmetric and good pulmonary branch pulmonary growth. Feasible by using only the venous access, less risk of arterial access complication. Larger stent diameter is may be associated with less risk of thrombotic occlusion. What is the disadvantages? The burden of subsequent surgery to remove the stent, and maybe some concern about the remnant of stents in the RVOT may related with arrhythmia or some infection. Less chance to preserve valve and annulus in subsequent repair. So, however, when we look at the fact that much less patient in neonatal repair, our patients requiring neonatal repair with multiple risk factors and poor RVOT anatomy, it is not just because of the RVOT stenting that we couldn't preserve the pulmonary valve. The patients subset, they have this characteristic. There is a reason why many patients have RVOT stenting, transannular patch is required. So two important, let's think about the two important is the advantage of RVOT stenting. Technical burden, maybe the feasibility to remove the stent is related to the duration of stent in the place. So in some papers, 95% of patients, approximately 6 months after implantation, could be removed all the stent. And the small retained portion, it didn't prevent the satisfactory repair. However, long term, maybe we don't know. So less chance of pulmonary preservation, as I mentioned before, proportion of pulmonary valve sparing was not different from RVOT stent versus modified BT shunt group. Also, valve preservation in patients with pulmonary valve Z value less than -2 is associated with the early moderate to severe PR.
If you could speed up, because we've got Joachim to do and Tin wants to do another live case.
So in summary, pulmonary valve preservation may not be significantly altered after RVT stenting. So take-home message is that this is the last slide. Initial transcatheter palliation of symptomatic neonate with TOF is safe and effective. And meticulous approach in this imaging is required in case selection, type of intervention, proper utilization of equipment, and careful periprocedural care. Further data is required for the definitive.
Okay, thank you very much, Jay. Joachim Mira will finish this debatable session talking about another option for palliation represented by PDA stent. Please, Joachim.
Thank you. Actually, the two previous presenters have done a lot of what I wanted to say. So it's important first just to say that whatever we do for tetralogies of Fallot, most of it is not correction. Most of it is palliation, because when you do a transannular patch, your patient is due for many interventions later. So this, there's two physiological types, either aortopulmonary connections or increasing RV to PA. All this has been already said. So what are the indications then for PDA stenting in my hospital? There are very few. We really either go for RV to PA enlargement, surgical or by stent, or by pulmonary valve dilation. So the indications are very uncommon in my hospital to put a stent. It would be a tetralogy of Fallot with pulmonary atresia and a long discontinuity between the RV and the outflow tract, because our surgeons usually would do a plasty using the left appendix, so they can do easily transannular patches. Coronary anomalies will contraindicate surgical patch, but not necessarily stent. And of course, discontinuous PAs will be an indication of stenting the PDA to keep the pulmonary artery connected. And eventually, we would do a stent in the PDA for pulmonary annuluses that will eventually, be sparable. But in those cases, most of the time, the surgeon will want to do a very, very early neonatal correction. So now, if we want to compare, it's also been compared actually. If we want to compare surgical shunts with PDA stenting, it's very institution dependent, but the trend in the last years really favors percutaneous PDA stenting. It's very anatomy dependent. It's been discussed also with very tortuous PDAs, with severe LP or RPA stenosis. Is it a sole supply or a dual supply of pulmonary flow? But many studies have been published in the last 5 or 6 years, and everyone actually says that the PDA stenting is non-inferior to surgery. And as you know, once a percutaneous technique is non-inferior to surgery, since the morbidity is always smaller, it means that it goes to percutaneous treatment. And all this has been. So this is a case where we did put, it was a very complex case with discontinuous pulmonary arteries, and the right pulmonary artery was actually perfused by MAPCAS. So we just basically put a stent to keep the LP open. This is a tortuous ductus arteriosus with a little stenosis on the LPA. We did stent it. Oh, we don't need to see this. So now the LPA looks nice, but eventually developed stenosis. Well, and sorry. And we eventually dilated the Strouds, and it went well. So in conclusion, RV to PA palliation is preferable to PDA stenting in most patients with tetralogic Fallot, and when aortopulmonary palliation is necessary, PDA stenting is preferable to a modified bile-toxic Thomas shunt. And just to conclude, this was me last year for the ones who remember, and I still do motorcycle. This was me yesterday in Dalat, very nice place in Vietnam, by the way. Thank you.
Thank you very much. Thank you to all these three speakers that has given us an exhaustive panorama of the surgical or non-surgical palliation that may be needed in the neonates. So thank you very much to all. We will finish this session with another like case that Tin will be ready to do.
Let's link up with Tin, and I understand, I think it will be Ahmed Chalabi. So, Tin, can you hear me? Okay. Yeah,
Yes,
it's
yes.
6:45. So if somebody could tell us very quickly.
It's going to be quick.
Okay, 10, I'm assuming this is isolated bilateral PDAs and with nothing else. Yeah, let's have a look.
Well, we can hardly see the
There's
PA.
retrograde filling of the left subclavian, I think, isn't there? And, and so where is this other duct coming from? No idea, because I'm trying to understand the anatomy of this.
It's an isolated left subclavian artery. It's connected to the left pulmonary artery.
Yeah. So pulmonary angiogram.
Well, but this injection, we are supposed to see some flow in the PA, right? But we don't. Yes?
So when you get the retrograde filling of the left subclavian, we're at the moment we're not seeing any filling of the pulmonary artery. So that doesn't add up for a PDA. And so you had a main pulmonary angiogram, didn't you? So that doesn't fill.
I don't understand anything.
You don't know if it's maybe
Sorry, I cannot get it, but at the initial presentation of the case, the plan was to close an additional PDA feeding the pulmonary artery from the subclavian, yes? But the aortogram showing both neck vessels clearly with no flow at all in the main PA. So I don't understand what is it.
we should do a selective carotid injection. If they don't see the PAs, the case is over.
Yeah, that's right. That's self-cured.
But
So-
you
GT.
clearly showed. But the echo clearly showed there's a flow to the PA, right?
Hold on. Ahmed is talking. GT has a question or a comment for you. Go on very quick.
I'm so sorry, Tin. Yeah, so I have closed one kind of bilateral PDA like this before. The thing is, your flow is not very clear the side. So again, like Miro say, whether we do a several angiogram and see whether the retrograde flow can give you a clear delineation, or sometimes you can see there's a collateral flow that filling up the isolated subclavian, left subclavian artery, so that it will give you some idea, because in the echo, there's definitely a flow to the PA, right?
Yeah.
So the problem is the opening is small, so it's difficult for you to cross in such a big PA to the isolated subclavian. So it can be difficult, yeah. Another thing is whether you can puncture to the left axillary artery.
Yeah. Okay. Yeah, so it's still not clear, this anatomy. And I'm assuming you had a CT scan or not? Yeah, but when you did the pulmonary angiogram, we didn't see any filling of the left subclavian. Okay. Oliver.
Push your pigtail more in the carotid.
Yeah, I think if the pulmonary artery pressures are normal, I would go home or have dinner because there's nothing to be done. Because also in the old days with the classical BT shunt, that was the situation. And thanks to the circle of Willis, this patient will be fine.
Yeah.
And tell the nurses never to take the blood pressure on the left arm again.
Yes. Okay. Tin, give us a clue. Yeah. So there you've got really nice filling of the left subclavian retrogradely, and it doesn't go into the pulmonary artery.
And not even a stump.
That's the...
So now do a left pulmonary angiogram and see if you've got any filling that way.
Yeah, that's right.
Okay, so the original PDA was definitely occluded with a PDA device.
Yes.
But on this view, there's no collateral that fits in with the echo.
But there's a collateral going up to the left arm from the descending aorta.
Yeah.
Hopefully the patient is right-handed.
Yeah.
Right-handed.
So, again, I've forgotten now, but was there ever a double arch? No, okay. The CT would have helped. Okay, where is that? So that's normal flow through the lungs into the left atrium. I'm learning the anatomy here really well.
It's also right. It's the right arch, isn't it?
Oliver, go on.
Yeah, it's the right arch, which is
Yeah.
unusual.
Mm.
And with that, your question about could it be a double arch is quite justified.
Mm. Okay. I'm confused. I would stop here and do a CT scan and get, if you need to do anything. Is there a murmur at all?
I mean, clearly you see the end of the subclavian. It's
Yeah.
It's the left PDA that is closed. It's a ligament.
Yeah, so the PDA is closed, the subclavian is closed and rehabilitated by the carotid. So that's it.
Yeah. And the original PDA is closed as well. So I'm tempted to go for dinner, Tin. Yeah.
Do you know?
Yeah.
You should measure the pressure.
Yeah.
So they should measure the pressure on the left arm.
Well,
Certainly
is the pressure lower in the left arm than the right? Have we done that before?
Well,
not now, but has it ever been lower?
Well, nevertheless, we may remember some years ago when the coarctation repair was obtained by subclavian flap, and we have a lot of patients that no problems at all. So that's a very similar situation for as far as the flow in the left subclavia. So I shouldn't be that worried, yes?
Eventually, he will get left subclavian steal syndrome when he's older.
Yeah.
But,
So, Tin, have you got any other ideas or another case, or shall we go for close the session and go for dinner? All right. Interesting case to finish the day with. It's been a fascinating day. So thank you very much, Tin, for your...
Right, thank you.
Thank you. Enjoy the rest of the evening.